So good morning. I see that the audience is light this morning, but I'm sure that in the next 10 minutes they will be there. As usual, we have a guest, doctors from Frankfurt that will present their city, their work. I don't know what they will do. So it will be done by Professor David Leistner and Dr. Marco Orks. So you are very welcome. It's time to present your city and your work. Thank you very much.
So, good morning, everyone. First of all, a very warm welcome to you and all the members of the European Bifurcation Club here to Frankfurt. And as you know, Frankfurt is not only a very, very lovely and a very dynamic city, it's also the heart of Europe. Why it is the heart of Europe? Because, and this was clearly determined a few years ago, it's exactly from the geographical sides, the middle part of Europe. And it's a part of one of the two rivers is separating Frankfurt in two parts, the part north on the Main and the part south on the Main. And if you look very, very exactly to the Main in the part of Frankfurt, you will see there's also a bifurcation in, not a true, or maybe it's a trifurcation, but it's a bifurcation. And so it's a perfect decision from you to visit Frankfurt this year with the European Bifurcation Club. Frankfurt has a long history in interventional cardiology, and I think some of the guys who are in the room know this. Frankfurt was the place where the second PCI all over the world was done. It was done by Martin Kaltenbach together with Grünzig in 1977. I will come back to the first case in Frankfurt. And Martin Kaltenbach was really a pioneer for interventional cardiology in modern heart medicine, because he had the idea that the surgeon and the cardiologist could work very, very close together, finding for each patient the individual best therapeutic approach. And this was, for my impression, the beginning of precision medicine and heart medicine. And so this is nearly close cooperated with Frankfurt and the history of Frankfurt. This was the first cath lab in the University Hospital of Frankfurt. That was a very, very hard fight for Martin Kaltenbach to get this cath lab and to start these procedures as first center in Germany. And as you can see, this is the statistics of Grünzig. I think this was in 1978, about the first year of PCI. This is a slide of Bernie Meyer presented at a historic session at the German Heart Association meeting 5 years ago. And as you can see, Frankfurt was the second place all over the world where the most PCIs in the first year were done, with 76 cases in the first year. Back to the first case, why it is important. This was the first case, and not only the second PCI all over the world, also the first PCI of left main. And this is important because you're today here, it's the first interventional treatment of a bifurcation. And this was done here in Frankfurt by Martin Kaltenbach together with Grünzig in 1977. So this was one-dimensional start of bifurcation, stenting and bifurcation PCI. And so then the time goes on and the young guys goes on, and this is Marco Orks, who is heading our interventional cardiology department, and he will take over and tell you what happened in the next years with the success and with the support of Frankfurt.
Yeah, thank you very much, Professor Leistner. I had the fortune here in Frankfurt to join the group of Professor Leistner and really get into precision medicine, precision bifurcation treatment. And our understanding for a long time was plain. we had an understanding of bifurcations that they are plane. And we looked at it mechanistically at a plane view. And this is what you see here, bifurcations, angles, and diameters. We looked at from an angiographic perspective. And even our bench testing, mostly these days, is plane. And what we have figured out during the next decades, from 2003 mainly, where the first crush technique was released or published, until 2019, where several generations and further developments of bifurcation stenting techniques. We have learned from studies what bifurcation stenting techniques might be prognostically beneficial. And the next step since 2023, we know now that the image-guided precision PCI is also of prognostic benefit. We can rule out complications, stent edge dissections. We know if we have to treat side branches. We learn if we have to perform calcium modification. And October was a very important study which has given us an impression how prognostically relevant this new technique was, published by Professor Holm last year with the October trial. And what's coming next? We are very active also in the field of CT. We think that bifurcations, the reality, is much more complex than the plain 2D view. It's a complex 3D anatomy, and we have to understand and have to get a better idea how we can adopt our stenting techniques to these complex situations. Yesterday and today, the next session will address that also, is that complex anatomy. And I think that CT will be a key technique to address these issues in simulation, in bench testing. And we are very proud that starting from next year, Professor Leisner has managed to get a photon counting CT to Frankfurt. And with this new technology, we hope to move the field further forward. So from my side, also a very warm welcome. And I hope that we will have a successful discussion, fruitful discussion together this day. Thank you very much.
Thank you very much. I invite the moderators and panelists to take seats. So Lilian, Dr. Swami, Fazila is probably connected, and Stefano. Here. Perfect. And this is the first news session. In news session, we usually present what is hot out of the press or just going to be submitted. The first lecture is Key Concepts from EBC Angio Guidance Consensus, Prof. Francesco Burzotta.
Good morning, everybody. So I have to start my presentation with specific disclosures. These are first that despite that this was angiographically oriented paper, I come from a center where we love intracoronary imaging, one of the highest imaging physiology rate in Italy in the last 20 years. And we worked hardly to promote the use of intracoronary imaging, specifically in the field of left main and bifurcation lesions. So there is a background that moved EBC in this direction was the fact that, okay, we worked hardly to put the left main and the bifurcation as the one that received the class 1A, so we are happy for that, and we think that we contributed strongly in this direction, and you will hear soon that we are working to standardize the use of them in this field. However, what we also know is the fact that all over the world, this is very recent publication from a group of Americans that worked hardly to increase the use of imaging. They reached 20% actually. So many PCIs on left main and bifurcation, as a matter of fact, are done with no imaging actually. So it is not possible for us to say that, there is a theoretical world where everything works well and do not take care about what's going on daily all over the world. So there is also a reasonable theoretical background for angiography guidance that should be in our mind. Imaging is wonderful and may facilitate our life. However, it might improve clinical outcome only by facilitating the achievement of the best PCI that is feasible in the individual patient. So this means that there are conditions where you add imaging, at the end it is impossible to dilate a lesion. So it is possible that this at best may facilitate, and as a consequence, a perfect result, full stent expansion and apposition should warrant a good outcome to the patient, regardless of the fact that it is achieved by angio or imaging guidance. So this is a strong theoretical background to, let's say, do our best in angiographic guidance. So aim of the board with this consensus is the fact that was to promote the concept that anytime we are not using imaging, we should use the microscope as much as possible. So we know that we are doing something that is more difficult, we are not facilitated, and this requires dedication, probably more than a standardized image-guided procedure. So we need to be even more focused on planning and meticulously performing our bifurcation PCI. And we should not complete our procedure with doubts regarding the result we achieved, because the final result we achieved at the end is the one that will be linked to the clinical outcome of the patient. So the paper came out, there was a lot of discussion, and in that we standardized that the work starts before PCI, during PCI, and there is also the confirmation for at least an optimal angiographic result. What should we do before PCI in the absence of imaging? First of all, also the Frankfurt colleague anticipated that the vast majority of the patients are going at least the stable to have CT scan as much as possible before PCIs. So we can look at the CT scan results like in this report, or we can by yourself analyze it using the best standards we have, and these are fantastic images provided by Carlos Collet and Patrick Serruis showing the potential that should be explored, should be incorporated in our way of performing PCI in the absence of imaging. What to do during PCI? Well, we have standardized the technique. This is very important because to have a plan is extremely important. So in the case, for example, we perform provisional, we should have in mind which is the best way of doing, and we should have dedication during our procedure in checking, in meticulously applying all the steps, and the systematic application of the technical steps reported for the selected technique is mandatory to translate the technique which is intended in a final results that resemble what we anticipate to have. For example, a critical point has been noticed in the October trial was the rewiring phase, a step OCT rewiring check that is extremely technically complex for the image operator.
So these are examples, proximal and distal rewiring. You understand that, we can have images that are easy to understand, but it should be really this quality of images. Alternatively, it will be very difficult to understand what's going on. So if we do not have OCT, or we are not able to interpret images or to obtain this kind of images, we should at least focus our attention in the best angiography views. So this is one trick. You can have the jailed wire that is pulled back and the rewiring wire that is in the distality very close to the carina. So this is a guide wire-based check. And other possibility is to add angiography. You see very well that this rewiring wire with the radiopacked part is really close to the carina. Difficult to have better, let's say, images and confirmation by OCT. Other aspects are related with the fact that we can see stents, like in the left panel, like standard with the standard angiographic view, or by stent enhancement. Why not using stent enhancement as much as possible? And in doing this, it is possible that we check step by step the process of our procedure, so that at each step where something is going wrong, we will discover that there is a problem very early, and not at the end a procedure where we have nasty conditions to be fixed. This is very smart way to proceed with this. So intraprocedural use of stent enhancement tools is recommended, especially for bifurcation interventions. And with that, we will disclose that, the standard pitfalls of PCIs, like proximal incomplete POT, or just, this incorrect tracing on with, a nasty result in the ostium of the circumflex, can be easily disclosed, clearly disclosed, and we need nothing more to go on, even if we have OCT in the cath lab, to understand that we have to correct this kind of conditions. And conditions like that compare how stent elongation is seen by OCT and stent enhancement. You understand that there are no many doubts about the fact that there is incorrect elongation, shortening of the stent proximally. So probably to add OCT at this stage was not so necessary. So to wrap up with the practice, example from my lab. Young lady, anterior ST elevation MI, borderline hemodynamics, 90 millimeters mercury, in the hands of one very, very, very expert operators in imaging of my cath lab, Enrico Romagnoli. This is the angiography. You see definitely that there is some tapering of the distal left main. There is a nasty ostial lesion that involves a little bit the circumflex. So what an expert operator like Enrico did in the night, he did just what he felt to do, and I reviewed the procedure using a QCA. So according to QCA, at this stage, the left main is 3.9, and the circumflex is around 3.4. Then, if you just reopen the flow into the LAD, you have a condition which is completely different. Now, nitrates came, and now you have 4.2 millimeters left main and more than 3.76 circumflex. This is by QCA. Then we discovered something looking at the literature. There is the possibility that these measures by QCA can be adapted. There is this important trial, the guide test trial, where the operators adjusted the QCA underestimation, providing these calculations that allow us to upload what we have. So size estimation for left main becomes 4.4, and it is 375 for the circumflex. Now, there is the problem of the LAD. I measured it by QCA, it was 2.1, the mid LAD. However, we cannot trust this. we have the branch calculator by EBC. If you put those measures for proximal left main and circumflex, what you have is the fact that the other branch should be like that. So we have a size estimation from the LAD that is at least 2.8. Now, what did the operator in the cath lab? He wanted to manage by provisional. He knew that he had to implant a stent that should cover up to the left main. So what he did was to implant a 3.5 millimeter stent at low atmospheres, but within the possibility of chart. That is another aspect that we put in the paper, the fact that we have also low atmospheres range, not only the highest atmospheres. Then he performed 4.5 semi-compliant balloon POT, and thereafter, this is the final result. So since he is really, one of the most imaging-oriented operators in our cath lab, and the patient was now stable and was a young lady, he decided to perform OCT. And this is the measures he achieved that are the ones that are really associated with good outcome, and this is the fantastic result he confirmed in the bifurcation. So it is difficult to think that this kind of results, based just on angiography, can be, let's say, ameliorated by the fact that you in a ST elevation MI decided with a borderline hemodynamics to embark in other things before having fixed the possibility to have stabilized the patient. Thank you for your attention.
Thank you, Francesco. Excellent summary. Do we have any short comment or question? Yves?
Congratulations, Francesco. I see that what I brought 2 years ago about the curve, and Fine brought about the balloon expansion curves, is described here much better than me. So much better than me. So we have to remember that in Europe, probably 95% of operators are not using intravascular imaging. This is not a reason to say that they don't have to treat patients. Of course, they have to do. And they have to use, ersatz of guidance, which is related to the fact that QC is undersizing the vessel. And using this technique, we have done that in Massy. I have done the same provocation, I would say, already in Bulgaria last year. You are able to get results that are really excellent, normally. Of course, you miss something, which is the quality of the wall, the content, and probably for the calcium also we need more support from intravascular imaging. So thank you very much for doing that.
Thank you, Yves. Thank you, Francesco. I just want to add that when we discussed consensus last year, we wanted to make part 1, part 2. Angio guidance, imaging guidance. But then somehow after discussing with the editors, we said let's do separate documents, and congratulations, fantastic work. Thank you.
So, and now we move from angio guidance to imaging guidance consensus, and it will be presented by Tom Johnson, please.
Thank you. So this is very much work in progress, but I think important to share as it is a consensus document, and hopefully there can be further consensus derived from this morning's presentation. So I present this really on behalf of a consensus working group. Myself and Nieves Gonzalo are co-leading this. So this is the authorship, which is a blend of EBC board members and then members of the EAPCI, and a panel of international experts. So I must acknowledge this was based upon when we first submitted the scientific document in 2022, and I think Mervat would suggest she's no longer part of the young committee. She feels older than that, but consequently this was derived from that time. Francesco's already alluded to the fact we're now in a new era. We have this Class 1A recommendation, but as I suggested yesterday, I worry that this is only the first step and doesn't necessarily impact positively on patient outcome yet, because the gap is in our knowledge and our ability to undertake interventions safely and optimally. And so I believe there is still a very long way to go, and Niels will be presenting again later today, but yesterday presented some fairly provocative sub-study data from October. And clearly the unintended stent deformation data is something we all have to acknowledge, where in the OCT arm undertaken by experts, there was still a fairly significant amount of deformation noted, and most concerningly, over half of those cases were left untreated because operators were unable to detect it at the time of the procedure. And where those deformations were left untreated, we had very significant MACE. Where corrected, MACE was 0. Now, clearly these are small numbers, but I think it acknowledges the power of imaging at the time of a procedure, but it is entirely dependent on us as the operator acknowledging those deficiencies. And that in some ways I think plays out when we look at sub-study analyses from all of the most contemporary trials, so starting from March last year with Renovate. Actually, concerningly, the signal there for the use of imaging here, predominantly IVUS, but 3-to-1 ratio of IVUS and OCT, we actually see no apparent effect of imaging on true bifurcation. And yet, in unprotected left main, there's a clear advantage to the use of imaging. If we looked at next in line, Illumium 4, now actually very few patients were actually recruited with an intention up front for 2-stent bifurcation, and hence the very wide confidence intervals, but you can see again no obvious benefit of imaging in the setting of bifurcation. October we've acknowledged is a very impactful study, but actually when we look at the left main analysis, there is no benefit. Now that is muddied by the fact that just under 40% of the angio cohort had intravascular ultrasound used at the time of their left main intervention. So we can't necessarily make full inference from this. But I think the most interesting sub-analysis from October, and clearly this is kind of only hypothesis generating, is we see the impact of OCT, oddly, in the more simple procedures. So with the 2-stent more complex, which made up about 60% of the entire trial, we see lesser impact. And I believe that's most likely diluted by the fact that the procedures are challenging and we have every chance of disrupting the procedure despite the benefit of imaging, which is what we see from the unintended stent deformation study. If we look at the most contemporary, so Occupy, again, oddly, we see here actually bifurcation failing to show full impact. And yet, again, we see that in left main, perhaps a more standardized, larger left main where operators actually have kind of a greater standardization to their approach, we can demonstrate the benefit of imaging. But really what I want this slide to highlight is that despite these fantastic tools, there remains some degree of variability in terms of the outcome we might achieve. And so we need to be standardizing as a community the way in which we use these tools and optimize the use of these tools, which at present we still haven't yet achieved. And that's the primary purpose of this document. So I'm just very briefly going to outline two components of the document, which are where the bulk of actually the discussion and the content comes from in the document we hope to be publishing early next year, which is focusing very much on the pre-PCI, so lesion significance, for which Chima has done a huge amount, then thinking about the importance of lesion morphology, and beyond that, how we might use imaging in the planning of our stent, both in terms of technique and then sizing. And then clearly there's a very important role in terms of the use of imaging in the post-PCI phase to ensure that we get adequate optimization. So this is a graphic that we introduced into the second part of the imaging consensus, which was led by Giulio Guayumi. And obviously at this point, this acknowledged the fact that we have some data from different regions of the world where actually these absolute thresholds vary. And so we took this 4.5 absolute cutoff, but then with a grey zone in terms of the need for physiological assessment. And so in kind of distorting this is a work in progress in terms of one of the figures from the document, but we might consider that imaging in addition to physiology provides a further assessment of lesion significance. So the importance of then considering the morphology, potentially considering more vulnerable plaque components against a more stable plaque type, in addition to then the physiological metrics that we might use for defining the significance. Beyond that, then we touch upon these different components of the pre-PCI imaging, so thinking about landing zone, the stent technique, the stent selection in terms of caliber, and then stent length. So taking those in turn, this is actually going to be a bit of a challenge. In yesterday's consensus meeting, there was a lot of discussion about the heterogeneity of left main lesions. We have funnel shape, we have diffuse disease, we have sometimes difficulties in determining a true healthy landing zone. And so the intention of the document is it will be a working document with case-based kind of illustrations within a large supplement, enabling colleagues to look and understand the best way of adopting these. This may be the most contentious element, which is, can we use imaging to define our stent technique? Are there, on occasion, features from the imaging that might push us towards considering the use of two stents rather than working through the stepwise provisional approach? And so maybe with greater extent of disease, greater threat of closure of the side branch, we might go with treatment of the side branch first in a culotte, inverted culotte, or even a DK crush type technique. Obviously, one of the key benefits of the imaging is the ability for us to determine stent sizing, and particular, as Francesco showed in that beautiful example from Gemelli, the idea of caliber discrepancy being one that is most frequently observed in the left main, and an understanding of the importance of determining the appropriate stent to overcome that caliber discrepancy. And then lastly, to think about the stent length, particularly the kind of nuanced decision-making in bifurcation in terms of ensuring adequate lengthening for placement of a pot balloon and such like. So these are some of the illustrations we intend to use to kind of standardize this approach for global use. Then I think that the most interesting element, and one that we still haven't yet nailed down in terms of the metrics, is the absolute cutoffs. And one of the concerns certainly I have from a personal perspective is the inadequacy of shifting between diameter selection of stents and areas for optimization. I don't think people can often compute a diameter to an area. So the intention of this figure is to give them a kind of upfront schematic of being able to understand 4 millimeters is 12 millimeters squared. I know it sounds simple, but I think in cath labs this is often something that's overlooked. And clearly we have historically the 8765 criteria of Kang, but in actual fact, there's new data to demonstrate that those numbers might not be so relevant. So at some point we're going to have to come off the fence and give our numbers for those different areas of the left main. This is just a tabulation of the most contemporary data, and the last meeting we had at ESC in London, it was suggested by Lawrence Raber that we actually try and get the data from all of these studies to combine so that we get then some overall feeling for where these MSAs for left main, LAD and circumflex should lie. And this is actually quite an interesting composite of data, 900 IVUS, 300 OCT, and a blend of East Asian and European Western populations. So I think this could generate some very meaningful data. And so for the moment, we're kind of around a 10 to 12 millimeters for the left main. Excel had said 10. We may have to be cautious in terms of not wanting to drive perforation. 7-8 LAD, 6-7 circumflex. So just to summarise, we are in a new place with 1A, but I think this will, I hope, be an important document for the interventional community. Bifurcation PCI remains a challenge, and I'm not sure the community necessarily acknowledge that challenge always. Intracoronary imaging definitely will provide precision, but there's an absolute need for better education, and we hope that this document will provide that. And critically, the message is from the document that the imaging must be used throughout the procedure, and that it requires engagement in order to influence decisions and ultimately impact on patient outcome. Thanks for your time.
Thank you, Tom. We have one question from the audience.
Tom, a great presentation. One caveat I think is warranted when you write these recommendations is when you do pre-planning of the left main with OCT, it's important to realize that you need to dilate the left main stenosis before you do the OCT, because what happens when you flush the arterial tree with contrast, you get a lot of contrast, you induce ventricular fibrillation, and then you start out with a bad outcome. And I think it doesn't really reflect in the documents that this is something that you need to be worried about. And it doesn't happen when you do like LAD, diagonal, OCT. It only happens when you do left main.
I fully agree. I think that's a very important component, is acknowledging safety. The one thing I pick up is you allude to OCT. This is an imaging consensus document, so it's both IVUS and OCT. And actually, I think what has to be recognised is that we've seen from Eve, the majority, and from Francesco, the majority don't use imaging at all. Right. But where imaging is used, IVUS is the predominant imaging modality. And the document has to reflect that. So there is going to be a blend of IVUS and OCT imaging within this document, reflecting use across the globe. Patrick.
Yeah, Tom, I have to make two comments. One which is, would say, political or legal, I don't know what to use, is that the last 3 years I've been 3 times in court now for colleagues. And it's basically because they did not apply the guideline. One was very obvious, the 3-vessel disease, not discussed with the surgeon, patient died at the time of the PCI. And now I'm in court because I'm an old man with what, blah, blah, blah. Okay, and it's very difficult for me because, when we start the guideline, we avoid the word mandatory and we use the word recommended. That's how I always save the colleague which is in trouble but I warn the people, these guidelines, like somewhat in the United States, will become more and more legal. And at some point, if you don't do what is in the guideline, you will be sued by patient because my brother, my father, my sister die in the PCI without consultation of the surgeon. That's an example. Yeah. Now, the second point, your talk is remarkable, and the talk of Francesco was also remarkable because it shows that we are achieving something which looks more and more scientific. Now, I'm biased because I'm coming back from 3 days on vulnerable plaque. That's a meeting that we are holding for 22 years. We are a little bit older than you, with your 20. But and I think what is amazing today, especially with the PREVENT trial, is that for similar plaque burden, you may have different level of vulnerability. So I think that this club will, in the future, get in this, because you have to revascularize, you have the significant, which is a mixture of physiology and anatomy, and then you have conservative. But for the similar plaque burden, you could move from conservative to treatment depending on the vulnerability of this plaque burden. Yeah. And of course, it's becoming more and more complicated. If you have a plaque burden of 50, but you have a huge index burden on near spectroscopy, what do you do? Yeah. So I think in the upcoming years, you will go in that direction.
The Star Wars music is very appropriate because it's so far from reality. If we can't get people to compute diameter to area, the idea of being able to define an intraplaque hematoma or a thin vulnerable thin cap fibroatheroma, we are so far from people being able to do that systematically. Just the final response, the guideline. This is a consensus document, so it's not going to have mandated statements. It's an expert group suggesting what we feel is best practice. And in some ways that gives us a greater freedom to suggest things that might be outside what can be evidence-based, which is useful.
Thank you. So, can I make a 10-second comment? Oh, okay. Yeah, so three things. One thing, I come from a country where imaging is available, but it's not universal. It's difficult to use. The patient has to pay for it. So I'll just make two comments. One is I think operator volume is something that we need to incorporate in both angiography guided as well as imaging guided. And legally, we're probably looking at using two experienced operators, because I think that makes a difference. If there are two operators working together, safety, outcomes, I think this is something we need to look at. The second thing, post-preparation. Imaging, third time, second time is post-preparation. Once before, once post-preparation, and then once post-PCI. I think probably that is something that we need to do. And lastly, we're working a lot on post-PCI physiology. I think it's not really, it's probably a stronger indicator of outcome in the intermediate term than even imaging. So I'll be doing some work on that. Maybe next year we'll get it. Our next talk is going to be angiography-derived FFR for bifurcation lesions, Shenzhen 2.
Thank you, Chairman. Dear Chairman, dear colleagues, it's my privilege to come to here. So I come from Shanghai, and this is my disclosure. So study shows that final gel Cybrance FFR is associated with long-term clinical outcome, and lower FFR in Cybrance is associated with poor outcome. But it's technically difficult for gel Cybrance assessment after main vessel crossover stenting, and there's safety concern for the where to go through the Cybrance. So we developed the angiographic-based FFR called QFR to calculate FFR from angiogram. The first generation can be performed only in a single vessel without Cybrance. The second generation is applying the bifurcation factor law, the Murray bifurcation factor law in the computation. That's why it's called MuFR or MuQFR. So Mu stands for Murray. So as you can see, all the Cybrance were detected and then incorporated into the computation to reconstruct the reference vessel with step down across the bifurcation depending on the size of the Cybrance. And let me show you how easily this can be done. So your operator need to only need to select the angiogram, and the software is doing the other step automatically for you. So it selected the best frame for analysis, and then the software using artificial intelligence to delineate all the lumen border in the band vessel and Cybrance. As you can see, the MuFR computation has been complete, and you have the pullback co-register with the angiogram. And the interesting to see is that you can do some virtual standing, assuming that this, let me see what this segment is complete revascularized, and you can see the MuFR in the distal left LAD will increase from 0.72 to 0.80 to 0.92. At the same time, you can also look at the Cybrance. For example, the second diagonal branch, after standing, you will increase from 0.78 to 0.98. So this gives you a sort of indication. So with this tool, we analyzed the more than 1,000 patients with unprotected left main bifurcation lesion from Forward Hospital. So because it only requires a single angiographic projection, so the feasibility in post-op analysis was high. So we were able to analyze more than 90% of the patients. So among them, we identified 13.2% of the patient has a residual ischemia defined by MuFR less than 0.80. So the patient was followed up for 3 years. So post-PCI residual ischemia was detected in 10% of the 10% in the circumflex artery, and 2.7% in the LAD, and 0.05% in both LAD and the circumflex. And this is the main result. As you can see that the indeed the residual ischemia was associated with poor outcome, also including cardiovascular death and also bifurcation-oriented cardiovascular event in 3 years. But we have to acknowledge that even only one single angiogram is required. It could be difficult in some cases, especially if you have a zero Cybrance at the very ostial. But using intracoronary imaging, you can, even if you have the pullback in the main vessel, you can appreciate that the Cybrance ostial. So we came up with the idea to integrate both the main vessel OCT with the angiogram to have this fusion model and present this technology in JAC 2015, many years ago. So as you can see that you can really appreciate the sideburns of the angiogram is overlapping with the OCT. That's a good indication of perfect matching. However, there's a limitation there, is that we only assume that there's a linear alignment longitudinally and circumferentially. And this is not always true because of the cardiac contraction. So the cardiac contraction will make the pullback not non-linear. So we further improve this algorithm, and now we can have this new algorithm to do the fusion using artificial intelligence. So it's separated into 3 steps. The first step is initial reconstruction. You do the angio reconstruction and OCT reconstruction. You can also do the plaque characterization automatically. And then we can use the correlation using this artificial intelligence network called Transcan. The Transcan can really align the angio and OCT in a linear fashion. You can perfectly match the sideburns and also in the angulation. So after that, you can fuse these 2 imaging modality. And as you can see from the lower figure there, you can map the plaque characterization on top of the model. And the purple at the sideburns oxygen there, the purple surface indicate that's the lumen taking out from the main vessel OCT pullback. So we are really taking the sideburns sizing from the OCT and then make combination there. So this is one case of the OCT and the angio fusion in the left main bifurcation. As you can appreciate, the angio and the OCT perfectly match at the sideburns, and you can see the purple indicate the size from the OCT ostial at the ostial sideburns. So how to validate it is not easy. So we collect the case with both OCT and CT, because CT is the true 3D data, so it gives you the best angulation of the sideburns and also the position of the sideburns, and also can be reliable quantify the bifurcation angle. So we use them as a reference to validate the fusion. And this is so a few cases, as you can see, that the shape of the 3D reconstruction by the fusion of the angio and OCT looks very similar with the CT. So this indicates the quality of the reconstruction. So in order to quantify the error there, we defined 4 types of errors. So the first one is called in the longitudinal direction. So we call unaligned longitudinal distance, which means that the sideburns should be there, but it's not there longitudinally. And second, we quantify the circumflex direction. So we have an unaligned circumferential angle showing in the middle. So the sideburns have angulation error there. And the last 2 is bifurcation angle using CTA as reference standard. As you can see, the result, we analyzed 216 bifurcation from 67 patients. The result was not bad, so we got a reasonably good result. And in order to validate the sideburn sizing from the fusion model, the purple surface, as you can see from the top figure there. So there was outside a layer half transparent there. That was the angio. So the half transparent surface is the 3D angio. And because some overlap and you don't see the narrowing there, so sometimes the half transparent surface is bigger than the purple surface. And we studied the correlation with CTA derived ostial airway from the sideburns, and also the minimal lumen airway, 1 millimeter distal to the carina. As you can see, the left figure shows that there was more scatter when you correlate with 3D angio with CT. If you use the fusion model in the green dot there, you can see that the scatter reduced. So we improved the correlation there. That's the indication that fusion with OCT improved the correlation with CT and compared to the angio. So ladies and gentlemen, in conclusion, angio physiology provides significant prognostic value in patients undergoing left main bifurcation PCI, and fusion of angiography and intracoronary imaging provide better geometry at the sideburns ostial for computational physiology assessment. The future direction is to investigate whether the fusion with intracoronary imaging could improve the accuracy of angiographic-derived sideburns physiology assessment in bifurcation lesion, and to investigate the performance of OCT IVS-derived MIFA for guiding sideburns treatment after main vessel crossover standing. And thank you very much for your attention.
Great talk. Thank you very much, Dr. Tu. Presentation is open for questions, comments. Anyone? Do you think there is possible role of using this in, for example, future DCB studies? So
yes, good questions. Yes, I think the intention from our group is to make to be easy to be used in the cath lab, and you can use to for example, in the Stent or DCB. It doesn't matter which technology to be used.
Thank you. If there are no other, Francesco.
Small comment. So, do you think that artificial intelligence might in the future automatically correct, provided that you give some insight regarding the quality, and the pitfalls that you have, so that at the end we can incorporate, we can have, after having done OCT, an automatic reconstruction that takes care not only about the limitation of angiography, but also the possible learning of the machine by the fact that it understood that from other cases like that?
Good question. I think that indeed we can see that the artificial intelligence has really playing a big role in every corner of life, but we have to be acknowledge that there should be so behind it there should be a rationale. For example, now the artificial intelligence is very good for automated contouring and also detect the subtle change there. Sometimes visual estimation is difficult to see that artificial intelligence can detect some subtle change. But if you don't have, for example, if you completely overlap in the cyber oxytocin and there's no chance for the artificial intelligence to detect it, you don't give them any sign. That's also a limitation.
Thank you very much. Exciting data as always. Next talk, Dr. Nagoshi, clinical study of novel technique of removal of jailing struts in side branch ostium. Recorded.
Good morning, Chairperson, distinguished colleagues, ladies and gentlemen. Thank you for allowing me to make a presentation in the EBC 2024 meeting. My title is Balloon Push Technique to remove side branches strut and 3D OCT guidance. This is my disclosure. As a background, these are two patterns of jailing configuration over side branch orifice in LM. The upper figure shows the link-free type. The distal guide are reclosed with subsequent KBT removes the jail strut completely. On the other hand, lower figure was the link connecting type. The stent link located at the middle of carina, so kissing with the distal guide recloss causes the severe stent deformation. Distal guide reclossing is not always optimal. In such a situation, the proximal recloss and KBT might be better in terms of the stent deformation. However, the proximal recloss with KBT could not remove the jet strut around the carina. So I wondered if there was a way to make the stent strut inverted at carina. I performed the bench test. The lens was implanted with a stent link located at the middle of carina by checking from side branch using microscopy like this. And with the proximal guide wire recloss and dilated balloon was pushed towards the side branch direction. Kissing was followed. You can see the jail strut that inverted at the carina. I reported the first case in the EBC 2017 in part. First case was the LED diagonal case. You can see the jailing configuration was link connecting type, so guide wire was recrossed into the proximal cell, and the dilated balloon was pushed towards the diagonal direction, and the balloon was passed. Final angiogram good, and the 3D image reveals the jail strut inverted at carina. At 1 year follow-up, angiogram was good, and the 3D image reveals the good neointimal coverage around the bifurcation segment. I think the procedure is applicable to link connecting type with the stent link located around the middle of carina, link-free type, where distal guide wire recloss is difficult, and where distal jail strut. We have performed this technique in 51 cases and reported the success rate of the procedure. We defined the procedure success was about 1 crown length distal shift by the procedure, like this. Inversion into main vessel lumen, no or insufficient shift as a procedure failure. We classified the patterns of the Z strut movement into 2 patterns, parallel strut type, Z strut shifted distally into the main vessel lumen without inverting, and the under-carina type, Z strut shifted distally under the carina by strut slide or by strut inversion. This is the example LM bifurcation lesion. You can see the stent link located at the middle of carina, so we perform the balloon twist technique with the anchoring balloon in the LAD, like this. And after this technique, almost no gel strut overside branch orifice. This is also LM bifurcation case. In this case, the configuration is link relief type, but the distal guide wire recross was very difficult, so we performed this technique. The dilated balloon was pushed towards the left circumflex direction, together with guiding catheter like this. And the final angiogram is good, and the 3D image reveals no gelled side branch, no gelled strut over side branch orifice. Among 51 cases, ACS 15 and LM bifurcation lesion 22, true bifurcation lesion 19, true bifurcation hole, and the side branch difference diameter 2.5, and bifurcation angle 65 degree. And the push balloon size was 2.5, push balloon pressure about whole atmosphere, and among the port and balloon anchor were performed in about 60%. Guide wire recross point, in terms of the guide wire recrossing point, proximal recross is 65, distal recross is 35. Configuration is in configuration, link connecting type about 60, link relief type about 40. Among 51 cases, 39 cases were success and 76.5%. Among the success cases, parallel slide type 43% and carina type 33%. Among 51 cases, only 2 cases was inversion into main vessel type. Factors related to the procedure failure, bifurcation lesion, side branch difference, larger side branch difference diameter, and a smaller balloon hole push. Complication, in terms of complication, no procedure complication like the balloon stuck and rupture, and a side branch dissection was confirmed in 21 cases, but all is the type A and type B, no acute and chronic occlusion of the side branch. In summary, the balloon push technique is a unique and useful technique for removing gel stent strut without causing severe stent deformation in the bifurcation stenting. With a success rate of 76.5%, the procedure was applicable to the link connecting type, to the link relief type, when distal guide wire recrossing was difficult, and 2 case failure of far distal gel stent strut was present. Strut removal patterns were classified into 2 types, the parallel slide type and the under-carina type, occurring in 43% and 33% of cases respectively. Bifurcation lesion and lower pushed balloon side branch artery ratio contributed to procedure failure. Thank you for your attention.
Thank you. I don't know if Dr. Nagoshi is connected now or not. Yes? Dr. Nagoshi, are you connected now? Can you? Okay. Thank you very much for connecting, and thank you for excellent presentation. If you have any questions or comments, please let me know, how do you correct finally stent deformation? Do you perform routinely kissing, or what are the steps after pushing the balloon into the side branch? Is there any mandatory sequence of steps following?
Thank you very much. I usually perform the final kissing balloon inflation after this technique, but I think this technique don't cause the severe stent deformation.
Yeah, we have a question.
Congratulations for the excellent presentation. I noticed in one of the cases that you were using anchoring balloon in the main branch, and afterwards you presented that in 61% of the cases you were using anchoring balloon. I guess that means that you are using 7 French for this technique, right?
Thank you very much. In most of the cases, I usually use 7 French guiding catheter. So I think with the 6 French guiding catheter, this technique is applicable. But 7 French catheter is better.
Dr. Desai?
Yeah.
Okay.
Is he talking about a standard size side branch dilatation with 2.5 in irrespective of the size of the side branch?
I usually select the side, push the balloon size in reference to the side branch difference.
Yeah. Do you do high pressure stenting of the main vessel before you do this pushing? Do you deploy the main vessel stent at high pressures? So what pressures do you deploy? More than nominal?
Yeah, we usually implant the stent with a nominal pressure, and before this technique, I usually perform POT. POT is important before this technique.
Wonderful presentation, Dr. Nagoshi. And I was wondering, what balloon do you use? Use a compliant or a non-compliant balloon for your balloon push?
Both balloon is okay, but I often use the non-compliant balloon.
And balloon length that you use? The balloon length. What length of balloon? Yes.
Length. Okay. Maybe short length balloon is easier to cross. But sometimes I usually use the balloon 12 millimeter length. So such a length of the balloon is applicable.
And in few cases you use scoring balloon. What was the reason to select scoring?
Because we usually use the balloon to which used for the pre-dilatation. So I use the pre-dilatation scoring balloon, so I used it.
And then you use balloon that is already on the table. Okay. Thank you very much. Excellent presentation. Looking forward to see you next year. And the next presentation.
Yeah, very interesting presentation. And the next one is how to manage link-connected type jailed side branch for optimal dilation. Will be presented by Dr. Kume. It's also recorded. Yeah.
Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is How to Manage a Link-Connected Type Jailed Side Branch for Optimal Dilation. For the background of our study, jailed stent strut at side branch ostium might cause lumen narrowing of side branch ostium due to neo-intimal proliferation at follow-up. Therefore, when considering from a long-term perspective, we should avoid stent jailing at side branch ostium as much as possible for side branch blood flow at chronic phase. We previously reported that when the stent link connected to the side branch ostium, there was a significant narrowing of the side branch ostium due to neo-intimal proliferation in the chronic phase. Recently, this condition has come to be referred to as fenestrated stenosis. To address this issue, we have conducted various stent bench tests so far. As for single crossover stent implantation in bifurcation region, our previous bench test showed conventional balloon dilation for side branch opening might cause stent deformation toward the side branch, resulting in an incomplete stent apposition, especially at the opposite side of the side branch ostium. We previously reported that proximal balloon edge dilation pivot technique for side branch opening might minimize stent deformation like glider balloon. Previous studies showed that link connecting type immediately after main branch stent implantation was significantly associated with a higher jailing rate at the side branch ostium, even following kissing balloon inflation. On the other hand, a link-free type with distal cell rewiring was significantly associated with a lower jailing rate, like this. Considering these results, stent link location significantly influences stent deformation during the side branch dilation. Therefore, we conducted this stent experiment to investigate the influences of the jailed stent link. First, we performed crossover stenting using the previously mentioned bifurcation vessel model with a giant stent. Using videoscope, we intentionally set the absence or presence of stent link on the carina, link-free type or link-connect type, and compare the stent parameters after pivot procedures with nominal balloon pressure. This slide shows the result of stent parameters. As you can expect, link connecting group showed that the side branch jailing rate was significantly higher than link-free group. This slide shows representative 3D OCT and videoscopic images. As you can see, residual stent strut were observed even after side branch dilation using pivot technique with nominal dilation pressure in the link connecting type. So what should we do if a link connect occurs after main branch stenting? To answer this question, we conducted this stent experiment. We intentionally made all the giant stent link connected and compared the stent parameters among the different balloon dilation numbers of times, 1 times or 3 times, and the different pressure, nominal or rated burst pressure. This slide shows the results of stent parameters. The jailing rate was significantly lower in 3 times balloon dilation with rated burst pressure than in 1 time balloon dilation with nominal pressure. Increasing the number of inflations and the balloon inflation pressure could have led to an increased incidence of incomplete stent apposition, especially at the opposite side of the side branch. However, this was not observed using pivot technique. Other stent parameters, including stent area and ellipticity ratio, were similar among the 4 groups. This is a representative image obtained through videoscope showing the ostium of the side branch. As you can see, jailing rate was significantly improved after pivot procedure with 3 times rated burst pressure. To summarize, the jailing rate was significantly lower in 3 times balloon dilation with rated burst pressure than in 1 time balloon dilation with nominal pressure. Other stent parameters, including incomplete stent apposition, stent area, and ellipticity ratio, were similar after the pivot procedure among the different balloon dilation numbers of times and different pressure. There are several limitations in this bench study. In conclusion, in the pattern of the link connect type, pivot with 3 times balloon dilation of latent burst pressure might be preferable for reducing the gelling rate at the side branch ostium. Thank you for your kind attention.
Thank you. Let's see if Dr. Kume is connected. Seems he's not. Professor Ruiz wants to comment. But this is just the extension of what Yves said. With repeat balloon inflations, you reach bigger diameter.
No, it first is quite extraordinary to see that Takayuki Okamura was in Rotterdam between 2009 and 2011, and the whole process of the OCT to judge what we do in bifurcation. I present that in 2010 at the EBC. So it is extraordinary to see the progress. But one thing which is very important, you have to know your device very well. You have seen some of these pictures was Ultimaster, which is very, very peculiar when you want to recross. Then we saw in the benchmark, we saw the science. But I think you have to know very well your device. For instance, if you do with the Supraflex Cruise, you have these longitudinal Z connectors. So you have really to think and try in advance. You will be surprised. And I don't know what's going to happen with the bioadapter. The bioadapter will be quite interesting. I mean, can you break some of these connections on bioresorbable in advance at the time of the implantation and get something else? And I was also, we don't talk anymore about specific device for bifurcation, but I saw that Antonio Bartorelli just published 56 cases of Triton in CCI. The new Tritons, if you can say that. So I think maybe in next year we have to reintroduce this type of talk and see what we are going to do with the bioadapter. I think David Erling has certainly some bifurcation, is 2,600 patients for sure. Yeah, it's a very good presentation.
Thank you. I'm a little concerned about the pressures going up to about rated blood pressure. I mean the rated balloon pressure. Because I'm worried about the injury to the side branch. So is there a guide as to downsizing the balloon when you go up to the rated bus, or you go to the 1:1 sizing of this?
I believe he just wanted to show the extremes. Low pressure, 1 inflation, burst pressure, 3 inflations, just to see whether that will progressively enlarge and remove the struts.
So, yeah, so Ajit,
it's a bench, it's not clinical. So.
The extension to what you said just now. So when you, what I do in my practice is when we do high pressure dilation in the right branch ostium, I get the balloon towards the main vessel. Because the side branch ostium is oval, it is not circular. And when you go up on pressures at the side branch ostium, as you pull your balloon towards the main vessel, the risk of injury is less and the advantage of expansion optimally conforming to the side branch ostium is much more.
Excellent. And the last talk for the session today is angiography-derived bending angle analysis in left main bifurcation disease, implications for prognosis and decision-making. Shengjian Tu.
Thank you, Chairman. Thank you for having me back again. So I just present that we can use angiogram to compute the physiology, but there's more we can do. We can also derive biomechanical assessment. So this is what I'm going to present in this talk. This is my disclosure. So a few years ago, we present the superficial wall strength. So calculate by reconstruction from the 2 angiogram. You can have reconstruction in multiple phase and then quantify the strength and stress at every location. So the superficial wall stress is actually an integration of different components. So mainly two parts. The first part is because of the cardiac contraction. So you have a stretching, benching, and twisting. So it's more like a mechanical force. The other one is more in the radial direction, is the interaction between the blood pressure and the plaque composition. So the blood pressure change will interact with the plaque composition, and you can get the radial strain and stress. So these two are mixing together, so we want to separate them. One is more related to plaque vulnerability, and the other one is more related to mechanical stress. So we present the angiographic derived radial wall strain RWS. So this is the concept. So if you have a vulnerable plaque behind, and during cardiac cycle, the blood pressure is changing. So we have systolic pressure and to diastolic pressure. So the change of the pressure interacts with the plaque composition. So if you have a more vulnerable plaque, mean that you have more lipid content and also thin cap, then you will see more deformation there. And this deformation is reflected in the lumen. So if you quantify the maximum lumen deformation over the cardiac cycle, that gives you an indication about the plaque vulnerability behind. And actually this information is hidden in the dynamic angiogram, but visually it's very difficult to see that. But if you're using artificial intelligence, if you precisely extract the diameter over the cardiac cycle and perfectly match them, you can quantify the diameter change, the relative change over the cardiac cycle, and you get this radial wall strain. And this has been implemented in the Angio Plus Core software by Postmedical. So after single view MUFR, if you click and if you good angiogram, you can automatically get this color-coded map. The hotspot indicates that the lesion behind this is more vulnerable. We have demonstrated this in a study with the OCT, showing that there was a good correlation between the angio-derived radial wall strain with OCT-defined vulnerable plaque. So with the parameter called lipid to cap ratio. So the lipid to cap ratio is quantified by the lipid burden. So by artificial intelligence, as you can see the figure here, the yellow part, the percentage, the yellow part in the plaque, divided by the cap thickness. So it's a continuous variable to quantify the vulnerability of the plaque. As you can see, there was a good correlation between the angio-derived radial wall strain with OCT-derived lipid to cap ratio. And we further demonstrate that in non-flow limiting vessel, if you have a vessel, if the vessel has a high radial wall strain, then the event rate is much higher. On the other hand, if you really have a normal flow and a low radial strain, then the event rate is very low. So it's safe to defer the vessel, the patient, if you have a low radial wall strain and also MUFR. The second component to quantify the mechanical stress is called the bending angle. So this is how we calculate the bending angle. For each position, we take 10 millimeter proximal and 10 millimeter distal, and then we estimate the principal direction. So you can calculate the takeoff angle, and then using 180 minus the takeoff angle, you get this bending angle. For example, for the circumflex ostial, you quantify the takeoff angle from left main to circumflex, and then you get the bending angle. I have to stress that this is computation can be different from the bifurcation angle. First of all, you only need to reconstruct the single vessel without the need to reconstruct the bifurcation, because if you want to do bifurcation reconstruction, you need two good angiogram without much overlap, and this is not always easy in practice. So it has high visibility to analyze the bending angle. Second, for bifurcation angle, it's calculated without including the curvature information at the bifurcation core, as demonstrated in the figure here. But the bending angle does take into account the curvature information at the bifurcation core. So now we have a radial wall strain to quantify plaque vulnerability. We have a superficial wall strain, so integration of different components, and also we have the bending angle. So this can all be calculated from the same angiogram. So radial wall strain from single angiogram, superficial wall strain, and bending angle from two angiographic projection. And the superficial wall strain is the most technical demanding. It can only be analyzed by very experienced operator in the core lab. So what are the correlations? So in order to do that, we also include the OCT in the analysis. So we have co-registered the OCT and quantify the lipid to cap ratio as an index for plaque vulnerability. And this figure shows the main result. So the radial wall strain is not correlated with the bending angle. That's expected because radial wall strain is more indicate the plaque vulnerability. Bending angle is more mechanical force, mechanical factor. But radial wall strain is correlated with lipid to cap ratio, so by OCT. On the other hand, the superficial wall strength is correlated with both the bending angle and also lip precapital because in integration of different composition, but the correlation with lip precapital is less than radial wall strength. So our advice that for plaque vulnerability is better to use the radial wall strength. But if you want to quantify the mechanical strength, maybe you should use the superficial wall strength or bending angle. So this is motivated was to do the study to investigate the association between the cardiac motion induced change of the bending angle taking off from the left mantle circumflex and the risk of the osteo left circumflex in stent restenosis following two-stent technique. The bending angle has been assessed before by 2D angiogram, but we have to remember that the accuracy really depending on projection, so it's not easy to get a reliable measurement of bending angle. So in this study, we are using 3D. So we quantified the bending angle before and after PCI, and also we quantify at the end diastolic phase and end systolic phase. So you have 4 bending angle, 2 in pre and 2 and post PCI. Then we define the bending angle change as a delta C angle. So if you have a cardiac motion-induced angulation change called delta C, and you have a stent-induced bending angle change called delta S. I'm sorry, a lot of them, but it's a very complex study. You see that we have 2 delta, 1 delta C and delta S. So we analyzed consecutive patients from 2 hospitals underwent left main bifurcation lesion PCI, 2-standing technique, and with 1 year's angiographic follow-up. So in the end, we analyzed 101 patients, and 30 of them developed in-stent restenosis in 1 year at the circumflex osteo, and 71 without ISR. This is the baseline characteristic. As you can see, there's no significant difference between these 2 groups, either bifurcation type or QCA or standing technique. There's no significant difference. This is the main result. So we observed that the bending angle change because of cardiac motion before PCI is the strongest predictor. So if you have a change in the bending angle before PCI due to cardiac contraction more than 16 degrees, it clearly shows that it will lead to restenosis with higher rate. So with an adjusted hazard ratio of 11.5. At the same time, we analyzed whether different standing technique to standing technique will influence the angle change. As you can see that the different standing techniques does not have impact on the angle change because of before and after standing. So ladies and gentlemen, biomechanical force have a critical role in stent failure and as well as sclerotic percutaneous, but accurate in vivo stress simulation remain challenging in clinical practice. Simplified coronary biomechanical analysis can be performed solely from angiogram by characterizing the coronary deformation behavior in multiple directions. Angiographic left bending angle change induced by the cardiac motion has critical prognostic implication for stent failure, while angiographic left radial wall strength analysis can help to identify bone envelope plaque phenotype. And thank you again for your attention.
Thank you very much, fantastic, and thank you for attending this year in person. Really, you always bring brilliant new data. Questions? I was expecting Professor Ruiz even sooner.
No, you know, I know Dr. Tu so well. I mean, we had a weekly meeting in Galway for some times, and all 3 we have been working with Hans Schreiber. So every time he's presenting something, it's always high level, yeah, and complex. I'm sure it's sometimes too complex for the audience and for myself, but we really appreciate. So about the strain, because he mixed the 2 topics, the strain and the bifurcation. The strain, the criticism that I had at that time is that the resolution of the angiography is about 200 microns, 0.2 millimeter. So you measure something which is 0.23, 26 in the range of things. But the big advantage of the angiography is that you don't have the to and fro motion. When you look at the strain with OCT, the OCT is pulled back, that's one thing, but the systole and diastole, so you never interrogate exactly the same level. With angiography, you can do that because you move with your target. So that's a big advantage. We do now stationary OCT in a model in human coronary artery fresh that we get from the coroner. And then we do stationary OCT, so nothing moves, and it's amazing to see the strain of the vessel, even in diseased vessel. I don't think that the angiography is the perfect technique. I don't know how to get stationary OCT in the coronary artery, but it's a very nice topic, and we have to follow if it has a value clinical. Now, the angulation, you remember that I present the 5 years follow-up of syntax, and it took a long time. That was a paper of Chris Girazis in JAC intervention, if I remember well. And it's interesting is that when you do what we call wrongly provisional stenting, which is provisional, when you do one stent, you maintain some angulation in systole and diastole, and it seems to be good. It seems to be good. When you put two metal, double crush and this kind of thing, there is no more systolic and diastolic motion. And you know, the systolic and diastolic motion seems to be important. If you look at the last ESC meeting with David Erling presenting the bioadapter, okay, you see things, the pulsatility come back. So it might be interesting to see if that technology in bifurcation is going to maintain something, liberate somewhat the systolic and diastolic motion in systole and diastole, because apparently Mother Nature doesn't like the rigidity of two stent and a double crush and so on and so on. Yeah.
Especially at the left main.
Especially in the left main. I mean, the work that we were presenting was only left main. Yeah. Yeah. Very, very interesting data. Yeah.
One more question, Dr. Chico.
Congratulations for the excellent work. I think it's the first time we prove something that all the interventional cardiologists intuitively had done for years, which is avoiding stenting hinge points at potentially high mechanical stress. And I think, I don't know if you agree, probably this is pointing out the spots where drug-coated balloons may be especially advantageous as compared to stenting. Because I guess if you treat the lesion with a drug-coated balloon, this mechanical stress, this hinge point, probably will have less effect in the stent failure that the lesion will have if we stent it.
I completely agree with you. I think that with this study, we also hypothesize that the less rigid stent, so it's more comfortable stent, would probably better to implant it at the circumflex altitude. And Professor Saroy, I think thanks for the comment. I think when we first proposed this technology, it's difficult to believe, as you say, that the resolution is close to what we are going to detect. So the normal angiogram, if you quantify them, is like in 1 or 2 pixel change there. So the original angiogram, the resolution is about 100 micrometer, but sometimes we explore them in a low resolution. So actually you reduce the resolution there. So it's better to implant in the original DICOM data instead of exporting them. Second is that if we look at those with high deformation, the really large lipid core and the vulnerable plaque there, there's more than 2 or 3 pixels. So we can go to 3 or 4 pixels. So in that case, you can quantify them. But you have to be very accurate in the quantification. It's not about the lumen size, but to matching them. You really need to have a good algorithm to co-register the different cardiac phase, and that's not easy. We have spent several years in this, to developing this, and now we think it's comfortable to bring to the society. Yeah.
Fantastic. Thank you very much, Sanvin.
Thank you.
I would like to thank co-chairs, panel, and all the speakers, and would like to invite Prof. Serus for CT scan session.
Can I have a very good. Okay, so we're going to start 2 minutes earlier this session, so we have a little bit more time for the discussion. Robert, come in. Good. So it's my pleasure to start session number 8, which basically will address something that is growing in the community, which is the use of the CT scan to plan bifurcation PCI. So the first speaker, well, no introduction required, for Professor Sorois, who's going to talk about the myocardial blood flow distribution from CT and the implications for surgical revascularization. Professor?
Let's see if this laser is working. Yeah, it's working very well. So that's the title, Myocardial Blood Flow Distribution, derived from CCTA, myocardium at risk, and revascularization completeness in the fast-track CABG, but everything I say could be applied to PCI. And you see the co-author of this paper, and it is on behalf of the fast-track CABG investigate that I'm presenting this data. So there is no universal definition of complete revascularization. However, we know that incomplete revascularization of coronary arteries after PCI or CABG has been associated with a poor prognosis. And complete revascularization is frequently self-judged by operator, PCI operator, but also a surgeon. So this is a paper that we published this year. That's coronary bypass surgery guided by computed tomography without cineangiography in a low-risk population. It was a group of 114 patients. And I would like to mention that in my AC 2024 lectures, the title I received from the ESC was Coronary Revascularization 2040. Good luck. And I said conventional coronary angiography prior to CABG will no longer be performed in 2040. And with the sole guidance of CCTA, decision-making in favor of surgery, PCI, or pharma will be made routinely by the heart team. And CCTA, as a game changer, may change the gatekeeper of the mechanical revascularization. Now, what is the fast track? The fast track was a first in man. 114 patients referred to CABG by conventional heart team using invasive coronary angiography. Then they underwent a CCTA with FFRCT. And then the CCTA was transferred to the Academic Coronary Lab in Galway, blind to ICA, of course. We did a lot of measurement discussed at the time of the heart team with the surgeon and the radiologist and the interventional cardiologist, MPR, cross-section, MIP, 3D reconstruction, anatomic and functional syntax score. And then the core lab sent the result back to the site, but to a different heart team, the heart team called CCTA Planning and Operating Heart Team. That's basically the surgeon and the radiologist blind to CCTA. And then the surgeon can request to see a coronary angiography, and then the surgeon is give access to the ICA and unblind. That's the feasibility assessment. Then they do the surgery, and 30 days later, we repeat the CCTA for graft patency assessment, and that's the safety assessment. So this is the kind of information that we discuss every Thursday in the heart team. It was a proof of concept demonstrating that we can operate patients without knowledge of the conventional invasive cineangiography. And in a nutshell, the result is that in these 114 patients, only in one case we unblind the surgeon, and that was the core lab which was requesting that. That was not the surgeon. And the safety assessment was that 93% of the anastomos patency were patent at 30 days. So that's the maximal intensity projection, volume rendering, the FFRCT, and then we were presenting to the surgeon who loved it, this multi-planar projection calculating for them the syntax score. Now, one slide from the paper is that there was an excellent concordance of ICA, CCTA, heart team planning and actual treatment. This is what we call a quantitative Venn diagram, and you see that the concordance and agreement in the planning of revascularization between ICA and CCTA heart team was 82.4% with a kappa of 0.54. Now, this is a complex slide. At the bottom, you have the whole literature, so you can read if you want. It's basically the technique of percent left ventricular myocardium flow. We call that LV percent myo, not to be confused to something, name of nomenclature of the PET. And what you do in 5 steps is the LV myocardium and coronary tree are extracted with deep learning algorithm. Then the total LV and non-LV flow are computed based on myocardium mass. That's what you see here. Coronary tree center line are classified as LV feeding or not LV feeding based on a diameter-dependent distance threshold, and you see the reference. 0.4 LV and non-LV flow are distributed top-down in the LCA and RCA in proportion to downstream vascular volume at each bifurcation, so you have a kind of fractal flow division with a flow to volume scaling low down to the outlet of each tree. And finally, you have, as you could see here, the percent LV myo at any location in the tree. So if you look at that slide, in the middle, you have basically the classical heart flow presentation. You could see that the right coronary artery has an FFR-CT just before the bifurcation between the PD and the posterolateral of 0.8. The LAD, there is no problem. Just after the takeoff of the diagonal, you have an FFR-CT below 0.5. There is a first obtuse marginal, small, with a FFR-CT of 0.77. You have the circumflex and the obtuse marginal with 0.68. So if you this is the center line, also color-coded, same color-coded than the product of art flow. But now we have at the end of the right coronary artery, the myocardium at risk, 8.3% for the posterolateral, the myocardium at risk for the PD, 9.3, combined is 17.7. Then you see 1%, 0.7%, 0.8%, that small side branch on the way to the bifurcation. So all in total, the right coronary artery is an area at risk of 20.6%. Then you take the LAD, and again you see the big red arrow here is the point where the FFR-CT goes below the value of 0.8. The same for the circumflex. And everything which is in red is in percentage myocardium at risk. You notice that the first diagonal is not involved, and you notice that the first obtuse marginal is there for 13%. So before surgery or before PCI, you had a total LV percent myo at risk of 87.2%. Now you have the situation post-bypass surgery. As you could see, there is saphenous vein graft on the right, very highly implanted, amazing, but now the FFR-CT is 0.88. You have a beautiful lima on the LAD, and the FFR-CT is 0.91. And you have a saphenous vein graft quite distal on the circumflex, and it's almost normalized 0.81. So many of these territory which was in red are now in green. The only one which is not normalized is the first obtuse marginal, because the surgeon did not graft that vessel. So the residual LV% myo at risk is 13%. This is the result. The pre-CABG total LV% myo at risk was 70.1%, standard deviation 18.8. The post-CABG residual LV myo was 14%, standard deviation 15.3. You can see the difference with patients having at least one total occlusion versus the patient who have no total occlusion in their multivessel disease with or without main stem. So what we have done now is that we have revamped the syntax score. This is the formula. If you have an LAD proximal with 43% myocardium at risk, you multiply it by 6, which is coming from the segmentation of the syntax, and you get the new syntax score for the LAD proximal, 2.58. On the left-hand side here, you have what we call the fixed weighing factor in the syntax segmentation. You remember the LAD, for instance, was 3 proximal, was 3.5. Now the real value average, this is an average, but you have for every patient is 2.5 with a standard deviation of 0.4. This is important because using the machine learning, we will get now these syntax score automatic. You know, I'm fed up with the tedious, cumbersome, unpleasant measurement of these things, yeah? So this is one of the last slides. It's a syntax segment weight factor derived from measurement, from LV% myo, which differs significantly from the traditional fixed weighing factors. You could see on the vertical axis the weighing factor, and on the horizontal axis all the segments. There are quite systematic difference, not dramatic, but existing. And in an AI system, we want to have the individual of the patient. So these rings show the blood flow distribution according to anatomic syntax segmentation, 58.3% for the LAD, 25% for the circumflex, 16% for the right. The blood flow distribution according to the LV% myo in patient without total occlusion, 41.5 for the LAD, 36.8 for the circumflex, 21.7 for the right coronary artery. And then the blood flow distribution according to the LV% myo in patient with TO, and many of them was in the right coronary artery. You could see LAD 50.5, circumflex 40.6, and right 9%. So the next step, I guess you know that individual here must be in the audience. I didn't check, okay? But the next step is to combine peri-procedural measurement, okay? Measurement of the bypass flow at the time of the procedure with the multi-slice CT scan. And we will need the brain of Yanis to make that kind of combination, but he has already published 2 patients, and he called that patient-specific computational simulation of coronary artery bypass graft. So, in conclusion, the percentage of ischemic myocardium in pre-procedure can be quantified on CCTA pre-CABG or pre-PCI bifurcation. Should I do that bifurcation? If it is 6% myocardium at risk, should I take the risk to treat that bifurcation? That's the whole issue for today. The CCTA post-CABG, post-PCI allow the quantitative assessment of the residual ischemic myocardium. This is a unique way to provide individual quantification of the revascularization completeness. Therefore, before the procedure, we can identify the best anastomose site the bifurcation strategy that will maximally minimize the residual ischemia and help the surgeon on PCI operator in identifying the vessel and subtended myocardium at risk to be revascularized. Now, this morning I put 3 slides more, and this 3 slide is friendly warning to the PCI community about what? About what? The fact that there is a new tidal wave. You know, the last time I used that slide is Amsterdam in 2000. I think drug-eluting stent is coming. There was only 33 patients, so I used the same slide. The new tidal wave is the photo counting. In the next 5 years, with the advent of photo counting detection CT, the disappearance, the conventional invasive coronary angiography as diagnostic tool of CAD will be accelerated. And just now, there is already 150 hospitals in the world. And it is said that by the end of the year, it will be 600. So I'm pleased to hear that Frankfurt will have a photo counting. Now, 2 slides. This is amazing. This is a document coming to the core lab to Filippo Cademartiri. That's the conventional CT. You could see the blooming effect of calcium. You could see the unsharp contour of flow attenuation area. This is the high-resolution CT, less blooming effect artifact, but disappearance of low attenuation area. You don't see that anymore. And this is the photo counting scanner. You have a sharp contour of calcium. At 40 kV, you will not have any blooming effect, and the low attenuation area is still visible. Now, more specifically, this is the quality of the document today. I can tell you it's easy to quantify the left main. It is 9.54 millimeters square. You can do that 10 times, you will get the same value, believe me. And then it becomes a piece of cake to quantify the diameter stenosis. Now we are in a bifurcation meeting, so my very last slide will be this. Photo counting CT can visualize stent strut by struts. You could see here, systematically you see the individual struts with minimal blooming effect so that you can reconstruct that like we did 25 years ago with IVUS gated. And then look, in this case, the metallic carina is clearly visible. So that's for the next meeting, go around to have a session especially on that. Yeah.
Professor, that was fantastic. Any question? If you have a question, go ahead. Take the microphone, please. Behind you.
Incredible presentation, Patrick. So, I have a very practical question. When we are looking at the coronary angiography today, we are correcting the measurement we have by 5%. You know, this is a work you did with Kubo a long time ago. With the proton, the diameter that you will have is
so the photo
has to be modified or not?
No, everything will be modified. It's very simple. I mean, Carlos Colle is very aware of that. The fact that, number one, the resolution is 111 micron. That's the official resolution of the Siemens photo counting. Is the first. There will be 600 at the end of the year, but GE is coming, Philips is coming, everybody is coming. Siemens has abandoned the manufacturing of their multi-slice CT scan conventional. They only now photo counting. That tells you something, you know. And the image we got in the core lab is so clear that on the shoulder of the fellow I can say, oh, that's a photo counting. Yes, sir, it's a photo counting. So that's point number one. 111 micron. That's somewhat better than some old IVUS. It's better than coronary angiography, which is 200 micron.
So some of the image, I can show you plenty. I mean, I have a library now, extraordinary. Some of the image look like IVUS. I think it will compete at a certain point with IVUS, or eventually be complementary. We will know where to look specifically, don't need to make a pullback the whole things, just go where you want to go. That's point number one. Point number two, with the blooming effect disappearing, it's very easy to subtract the calcium. That's what the people do. But now you have a high resolution. So if you look at the finite element of the whole system and the finite element of the same vessel done now, you gain. So everything is going to be more precise. FFRCT will be more precise. So I think that's the way to answer your question. So the 5%, I don't know exactly what it will be, but it will be better.
Yeah, so I presume that now we'll see how to prepare the treatment of a patient with a CT scan only.
Yeah, we have done that. If you remember at PCR last year in Clinique Pasteur with Bruno Farah, we made the case completely multi-slice CT scan in this institution, but we make the interpretation and in analysis. And in that patient, we discover a circular main stem, completely calcified, 380 degrees, with some calcium going in the circumflex and some calcium going in the LAD. We said to Bruno, live case for PCR, start immediately with lithotripsy. That's what he did. 10 session, 10 activation of the lithotripsy, short because it was the main stem, and then stent, and it was done.
Good. Last question, Habib?
Quick question. Amazing talk, as always, very disruptive. Question for you is, as you've moved this concept to functional syntax, essentially, but for all three vessels, and really leveraging the value that CT brings over angiography, where do you view the next disruption in this area, and this whole idea that you're not just using the angiography or the physiology as a dichotomous, red-green, but augmentation of FFR? So do you think the next level would be to look at sort of a more quantitative or continuous improvement in delta FFR rather than red-green?
Yeah, I think, you know, the term which has been coined by Elucid, by Clearly, by HeartFlow is AIQCPHA, which is for artificial intelligence, quantitative coronary plaque, and hemodynamic assessment. So it's complete assessment of the coronary artery. The weakness now is, on one hand, you have to recalibrate everything for the photo counting. That's one thing. The second point is that we have to stay away from the categorical. You know, the 80, okay, 80, that's 1994 in the New England. No, it was 75 at that time. And we moved to 80 with the interventional cardiologists because they were not happy about the 75 and there was a plateau there. But I think that has to be recalibrated for the photo counting. And then we have to use the delta. The ICFA, this group, has put that the first important things, the 5 features which is important, is the delta FFRCT, then the plaque burden, then the total volume, then the low attenuation volume, and then the LV myocardial flow, which will be commercialized early 2025. Yeah? Okay. So the next speaker is Carlos Colle, the classical sentence. He doesn't need introduction, but maybe he needs some introduction still today, yeah? So it's a good friend. We have been working together for 2 years, I think, in Rotterdam, and then he did a wonderful career, first at the University of Brussels and now in Aalst. The title is 3D Plaque Assessment for Bifurcation PCI Planning.
Thank you, Professor. And of course, everything that you're going to see in the next slide has been deeply influenced by my time with Professor in the Netherlands. But we're going to now shift to the cath lab. And we're going to make this very practical And the reason why we're having this session today is because this has been, you talk with Professor Sorois and he will tell you that he was doing this 15 years ago, and that was true. The thing that is new is that you have this photon counting, basically you go to 100 micros resolution, and then you have AI. So this becomes a click in a software, and this is going to show you in the next slides. So basically, I'm going to make just a case presentation to make the point, and this is typical day in the cath lab, 70-year-old male, angina class 2, normal function of the ventricle and the kidneys, and then you step in the lab, and then you get this shot schema. And then you start thinking, okay, long AD lesion, some disease in the distal left main. Start thinking what would you do, because that's my next slide. I'll give you the still picture. This is basically how we work it. So now we have to decide. Now you have to take a decision, and to take a decision, basically here, I will put 4 options for you. Give me what you think about this. Keep it simple, as the EBC promotes. It's provisional to the LAD. Well, there is some disease in that ramus. Maybe 2 stents is the best approach. Someone will say, well, why not surgery? Distal vessels are good. Eve said no. And then we'll have someone saying, listen, there's no difference really with revascularization. You can treat that patient medically. And then you say, okay, what should I do? You are at the table. Basically, you have to take a decision. Normally, you only have the angiogram, and you start thinking, okay, how long is that plaque? Do I need to modify that plaque before putting the stent? How big is that vessel? It's a side branch. I'm going to lose that side branch. How important is that side branch? Do I have to modify the calcium? With what? IBL? Should I take the rota? And this is happening in every single case, and it's worse in every single complex PCI. So the reason why I'm telling you this is because this is what happens in clinical practice. Everyone takes a different decision, and this leads to treatment variability. If you do that in Spain, if you do that in France, we do that in Belgium, we'll probably decide something different depending on your expertise, the information that you have. And basically, treatment variability results in this, outcomes variability. Famous slide from Professor Sorois, basically showing the event rate in both the PCI and the surgical arm in the syntax trial. And every ball is a different site. So look at the variability in the outcomes according to the randomization arm. This is unbelievable. And the reason is basically what I showed before. Why is this? Well, basically we're making decisions without really being informed. We're taking decisions based on the luminogram. We don't know anything about the plaque composition. We don't know anything about the disease burden. We don't know anything about the real presence of ischemia, if this is focal, if this is diffuse, and we have absolutely no clue about the microcirculation status. So this is where the adjunctive technology plays a big role. We are fans of invasive physiology, but maximum 30%. That's the numbers from the Netherlands. And intravascular imaging is the same. The top country in the world, outside the Asian countries, is 20% adoption. So how can CT help? And this is extremely relevant, again, because it's fully automatic. Now, of course, we have started the presentation by showing the clinical and the angiographic picture, which is basically something that we have for every single patient, but we need to turn on the light to look at the plaque, to look at physiology, and we're going to go back to the case and understand how those two information basically help solving this case. Let's assess the plaque. And to assess the plaque, we have basically developed a curriculum to train interventional cardiology. So if you know nothing about CT, this is everything you need to know. There is nothing outside this slide that you should be aware if you are doing PCI and you're looking at a CT scan. Basically, you have 4 names. These are the 4 reconstructions that you need to remember. The 3D MIP is extremely intuitive for us. It will tell you the amount of calcium. The actions we use for the guiding selection, the NPRs to assess the lesion and the lesion length, and of course the cross-section is pretty similar to what we do when we look at IVUS or OCT. Now, back to the case. This is the same case. Now, we suddenly realize that the plaque extends to the left main and to the mid of the left main. Very easy to see. Then you see the plaque there. Basically, it's a left main PCI, and you have to land mainly in the proximal part of the left main. Clear. Second answer, beautiful landing zone in the mid LAD. And what is even better, a 48 covered the whole plaque. So basically, you have now understood that a 48 will solve the whole problem in the LAD. And again, when you look at the cross-sections, I'll come back to the calcium analysis, but you don't see any circumferential calcification. That's good news. You can also see the other vessels. And you see, well, There is no so much disease in the circumflex, which is in the middle. There is something at the ostium of the circ, and the ramus is free of disease in the ostium, but there is some disease in the proximal ramus. Now, you don't need to learn how to do that. You don't need to learn how to look at those pictures. And the reason being that those pictures that we call MPR, this is all being now reconstructed in 3D. This is the same case, 3D measure reconstructed, and now you see that the calcium becomes white, the non-calcified plaques become green, and if you want to look at this case, now this is what you have. And this is going to be in front of you in the cath lab. We're going to show you what we're doing. So basically now, this is the same case. You're understanding the disease. So basically, you see the plaque in the left main. You see that there is a trifurcation. You know where to wire. The circumflex is 90 degrees. There is some calcium at the level of the ramus. And then look at the augmentation of information that you had just by analyzing the CT scan in this way. And to put something on top of that, this comes in the lab. So this geometry, you put in your C-arm. This geometry is synchronized with the machine. Every time you move your C-arm, the geometry will move at the same time. It's extremely powerful to see the lumen on one side and the complete plaque in 3D next to it. It's like the feeling is that you have been blind for your whole life looking at the angiogram, and suddenly you can see the plaque. Now, when we talk about the calcium evaluation, I will not go in depth, but you need to know that 30% of the severe calcium we cannot see with angiograms, and of course, this impedes stent expansion. And again, this correlates linearly with the arc of calcium, as Professor Serrois mentioned. And again, this is data from Christos, which is in the audience, basically showing that in severe calcifications we have higher mortality compared to absence of calcification in patients undergoing PCI. So this type of calcium detection is extremely relevant. This is again the same case. Now I'm plotting only the calcium in that case, just to show you that again there are no circumferential calcifications. The position of the calcium relative to the side branch, which is something that we're learning, is extremely important for the selection of bifurcation techniques. And again, this also helps in wiring. The field of calcium is, in my view, something that is being revolutionized by CT scans, and I will explain you why. This is all the data you can derive from CT relative to calcium. This is going to go to a complete new level with photon counting, but all the images that I'm going to show you are with the old scanners. I'm going to call it old scanners. Basically, you can look at morphology in the same way you do with intravascular imaging. You can look at the 3D calcium, and there is something that is coming that you can not only understand calcium in terms of how severe it is morphologically, but how hard or compact the calcium is. And we're going to talk about density. And something that I'm not going to talk today, but Professor Okutso is somewhere in the audience. He's been working on predicting wire bias, which is basically a tool that will help us select the calcium modification tool. Calcium arc is very easy. It's even easier than intravascular imaging because you see this white image, which basically is this calcium. It can be circumferential, no circumferential. You can assess the thickness. And of course, it becomes very, very easy because you can also assess the length. Now, this is where CT adds value to the conventional morphological approach. I'm going to go slowly here. On the bottom of the slide, you have an extraction of a three-dimensional calcium, which is the same one that I showed you before, but removing the lumen. In the mid-panel, you have all the cross-sections, now looking at the arc, and you will say cross-section A, 180 degrees, cross-section G, F, H, and I, 360 degrees. But on top of that, we have now the Hounsfield's units. The Hounsfield's units reflects the density of the calcium. So how hard is the calcium? So we're not talking anymore about concentric and non-concentric calcification. We're talking about hard and soft calcium. So all are calcium, but some are soft and some are hard. And you can imagine the clinical implication. Of course, you have soft calcium that can be broken very easily. If you have hard calcium, you have to do it differently. And again, all this can be easily co-registered. And imagine that you have these maps before you go in the lab where basically you get a complete three-dimensional plaque of your calcium on top of your angiography. And this is basically happening today. Now, I'll show you a couple of cases that we had to deal with. This is basically a mid-LAD. And what you see here, we call this calcium, when it's above 1.5 K Hounsfield's units, these are very difficult to open. Sometimes this is, we deliver 80 pulses IVL and we didn't open. When you have calcium, we have calcium above 2K. Calcium above 2K is almost impossible to crack. And this is basically what we have been learning in the calcium arena. We're going to have a dedicated talk for myocardial mass. This is a different algorithm. We're using this again. I will show you what we're doing in the trial. But basically, in the same case that we had before, we understand that there's a big, big ramus next to that LAD. And look at the size of the ramus in terms of mass. is the same size of the LAD. So you're going to revascularize the LAD, you cannot lose that rainbow. So that's important. So, and everything, all this information is given to you before the lab. And of course, I'm going to end up by telling you that you can also, as Professor Serois mentioned, add physiology. And physiology, Habib, not in the classical less than 0.8, more than 0.8. I think that's the old way of using physiology. Physiology has advanced tremendously. Today we're using physiology completely different. We're using physiology to understand whether, one, is this a case for PCI, yes or no? Because in the meantime, we understood that we cannot treat diffuse functional disease. That's another story. And then to predict the improvement in flow. Now, back to the case. This is a patient with focal coronary artery disease. All the pressure losses are in the ostial LAD. If you want to look this in the pullback, you can understand here very quickly that it's a big pressure gradient across that proximal and ostial LAD. And if you want to calculate the non-invasive PPG, you see that is very high. Now, imagine that with one click for every single case that you're going to do in the lab, and this is not the future, this is the present, you have a complete map of the anatomy of that patient and a complete map of the physiology of that patient, and then you basically execute the case. So it becomes easy now, because all the questions that we had at the beginning, we'll basically can now simulate, well, let me put a 48 from the mid-left main to the mid-LAD, basically will improve the FFR to 82. That looks pretty good. But, well, then you basically go in the lab, give me a guide, 2 wires, put that 48 in the proximal LAD with extension to the left main, and that's it. And this is the way we're executing PCI today, and what appeared to be a very complex, uncertain disease becomes a straightforward PCI. We measured post-PCI FFR in this case, and it was 0.85. So this is everything that you can get from a CT scan today relative to PCI. So basically, you can understand the complexity of the disease. You can select the best guiding for the take of that vessel. You can understand the need of plaque modification specifically for calcium. For bifurcation lesions, understanding the mass at risk changes the procedure many times. You can get the best angulation. This is something that you get in the lab. And of course, you can get the complete physiology in the traditional way, positive or negative, but in this new advanced way of using physiology, which basically predict the outcomes in terms of angina relief. Everything that you have seen before, we're basically finishing the P4 study. This is a randomized clinical trial, including a little bit more than 1,000 patients, randomized to CT-guided PCI, which is basically everything that you have seen in the previous slides, versus IVUS-guided PCI, which we believe is today the standard of care. We have included 720 patients. We think we're going to finish by December of January. So in a couple of years, we'll have the results of this trial. So to conclude, I think that CT has evolved tremendously, and it allows today to characterize coronary artery disease both morphologically and functionally. I think the P4 approach is basically testing two elements. The first element is the planning element, which is extremely important. Going in the cath lab, exactly knowing what to do. And second, the online guidance. Having that plaque reconstruction in front of you all the time really makes a difference. And I truly believe that, I think we are fully aligned, Professor Serois, that CT will become the standard of care for planning revascularization procedures. Thank you very much.
Fantastic talk. I've one question for you. So I've been wondering for a while why it is that we don't get access to this fantastic detail that you're telling us about. And we mostly get a report that says moderate lesion may be in the mid-LAD. That's all I'm telling you. And what I was thinking is that partly because the whole, you actually need the whole data set of the CT scan to get this, and what we all get on our imaging systems is just a small section of that data set. So if I go onto my PACS system and try and recreate what you've done there, I will struggle. Is that because only a certain amount of data is uploaded in most hospital systems and the rest is kept on the radiology server?
Yeah, so the answer is very simple, David. The radiologists, they choose what to put in the PACS in terms of reconstructions. So what you need to have is a discussion with them. I have to say that the first reconstruction that I showed called 3D MIP is perhaps the most important projection for you because, one, you will understand that very quickly. Second, it will tell you how complex is the disease. Based on that picture, you not only know how complex is going to be the PCI, but you will change size of the guiding, even access site, so you will really understand what is the complexity that you're stepping in. But the radiologists, when you tell them, please put a 3D MIP, they say, you want to put what? We don't look at that picture. We don't look at that picture. So
that's true.
We have come into a moment where what we want from the images is not what the radiologist has been trained to look at. That's the reason when you go to our courses of CT guided PCI, you have to look at the images because the radiologists have never put a stent before. You are the one who's putting the stent, so you need to know where is the calcium, where is the calcium. Now, I will tell you right away, you will not need to open the packs. All this information, this DICOM, will be processed 2 to 5 minutes processing time, and you will get all the three-dimensional stuff, which will make your life extremely easier. And that is not the future. That is happening in the trial, and this will be available as soon as the evidence is collected to support this.
Let me do a few comments. First, it's the second time that I heard the story. I heard 3 weeks ago in Milano during the European Association of Cardiovascular Imaging, and I had the same pleasure today than 3 weeks ago. You know, it's like a good movie you want to see a second time, and I got the chance to see a second time. I don't know if you realize, but it's dealing with very complex material in a very educational way. I was looking at the audience. When the audience take the iPhone, is a bad talk. Nobody was using at the iPhone because they were following the talk from the beginning. Okay, that's the compliment, and we stop here. Now, the second point is that when you are in the audience, you must have some feeling of frustration. You know, I don't have these things. And what is complicated in life is that if Carlos, myself, Yoshi start to say, that's system, that software, that algorithm you could find here and there, you will say you have a conflict of interest, you are promoting something. But when you leave the audience, the people come to you and said, where can I find this software? And I think that EBC should have the gut to say, forget the conflict of interest, say where you have the software and who is the person, because we are all entitled to have this information. And it's a question, it's not tomorrow, it's not science fiction, it's not Star Wars, it is the reality today. I mean, it's amazing that what we were doing in the past in 2 hours, you know, these kind of pictures, is done now in minutes, okay? And it's on the cloud. You can interfere with the cloud, but the concept of core lab will disappear because all of us will have access to artificial intelligence, which is not to make us afraid, but it is to facilitate our operational task every day. Yeah? So at the end of the meeting, you consult Carlos and said, give me the address of all this software. That's my advice. Question, Francesco.
So, no, it is just one comment. For sure, I mean, it was fantastic to see this movie. But I want to come back. I think that you let us see our future, and it's good. However, I want to share with you what I think that for all the community is the present. That is the fact that regardless we have or not the software, it is time that before performing PCI, if a patient received a CT scan, even if it is low quality, even if it is without contrast because of a possible lung cancer, the operators come back to see the DICOM file by his own. This is something that should be the statement because as TAVI operator, I learned to use all the fancy devices that allow us interpret. But if the machine doesn't work, I will never implant a TAVI without having a look on the DICOM file. And it takes really a few seconds to have at least, I mean, the main information we cannot miss today. So this is a call for action for each of us. Let's start seeing the images, because at the end we will be better in selecting the best, let's say, software that will be proposed us according to our knowledge.
Francesco, I think that I'll tell you two things. The workflow that we have for PCI basically takes between 3 and 4 minutes, and we standardize that for the trial, and that's what we're telling the community. It's 4 minutes. Look at this, guiding. Look at this, IVL yes or no. Look at this. So it's like TAVI, you know. This is a workflow that is solved. And the second comment you made is extremely important. And yesterday I did this lecture about young physicians, but even in STEMIs, I tell the fellow, they have a chest CT, open the chest CT, let's look at the calcium, let's see how much calcium it is before we do the primary PCI. So I think I cannot agree more with you.
Okay, there are 4 potential questions. Question short answer.
Go.
My question is, what is the role of intravascular imaging and physiology when you have this technology available? And when you have it, how many times are you using this technology?
Short answer. I think this facilitates the interpretation of intravascular imaging. That is extremely, when you have a 3D plaque, it's very easy to know where you're looking at the cross-sectional plane. So that's one option. But to give you the controversial answer is that for the pre-PCI part, CT solves almost all the questions that you will answer with intravascular imaging, pre-PCI.
Thank you very much. More than frustrating, I think it's motivating to see all this. One question, from the mechanical and morphological point, it's absolutely clear, but what about the biological factors like in acute settings, how they would compromise? Also in the previous talk, the blood, myocardial blood flow and all this analysis.
Yeah, when you speak about biology, I focus on PCI and calcium, but there is a big part of CT for vulnerability, assessing the vulnerability of the plaque, of the activity of the plaques. And I think this is a fascinating topic. We're still learning a lot about that, but what has really changed in that field is that we now have a tool that is screening the patient for us. Because in the past, no one would screen with IVUS or OCT, but now everybody's getting one of these when you have a little bit of chest pain. So I think that field is going to really be enriched by the fact that we can look at the morphology, at the risk, at the plaque level. So that is what I see coming.
In acute settings, can you use the same thing?
In ACS, non-STEMIs, yes.
Do you think the CT scanner should be part of the cath lab because structural is doing it? If we do it now in this setting, people with pulmonary embolism are doing it, and that's a political fight. And do you think our trainees should get this training separately, and what about radiation safety?
Yes to all. So yes, all the interventional cardiologists that are starting or young physicians should get trained on how to read CT. That's point number 1. Point number 2, yes, I think that cardiology should little by little start owning the CT scan because this is just going to evolve. Professor Serrois presented the surgical part, this is the PCI part, but this just continues to evolve, so yes.
Okay, Joanna, and then Boranta, and then that's it.
No, that's okay. I think that you sort of asked my question about IVUS, and you also answered it. So, I mean, what is the percentage of the cases then where you plan with the CT, but you find something different, it goes differently, and then you rely on your IVUS and FFR? I mean, because, you have to also check what is actually your result post-procedure, right? So, and that's, you can...
Yeah, so intravascular imaging, as I said, pre-PCI is pretty much solved with these pictures, but after you place a stent, you will need to have intravascular imaging either to assess the effects of modification or the placement of the stent. So it becomes more kind of a checking tool at the end.
Chris, last question. Yeah.
Very, very quick, Carlos. Fantastic work. And this is important the technology to be pushed and brought to the lab, especially with the photo counting. From my experience, what I have seen, there was quite a few cases that, for example, fibrotic plaques can be missed by CT because they have the similar Hausdorff units with the contrast. And the other thing is, I've done a CT, I measured the lumen diameter, for example, to size a stent. Then I did a balloon angioplasty. I put an intravascular imaging catheter, give some nitrous, have a different vessel. Have you seen something like that? I mean, I don't believe that does not have a value CT in the cath lab, but sometimes we see different vessels with after dilating a lesion and missing some fibrotic plaques. And the Brockback calcification as well. You can see the calcium, but don't know where exactly it is, it's superficial or not. And most of them would be resolved with photo counting, of course.
That's a very important comment, Chris. And, a few days ago, I was in a similar meeting, but with radiologists. I'm not talking to radiologists. And the reason that I'm talking to radiologists is because they need to understand how important it is to give nitrates to the patients, because we're doing now sizing. So if they don't do nitrates and you do nitrates, that's going to be different. So they need to understand that they give nitrates and that they need to set up the tube in a way that allows to assess the calcium. Because what they have been doing so far is reducing the radiation at the expense of getting this blooming artifact that you cannot read the calcium. Now we're teaching them, listen, forget about the radiation, because what is going to happen is that in the cath lab, we're going to give 5, 6, 7 times more radiation. So it's better for us that you make a diagnostic exam that we can use, that we spend more time in the cath lab. So that they started to understand that to look at calcium and to be, perhaps you can talk with your radiologist, you need to use 120, 140 kVs, otherwise you cannot look to the calcium. So these are small details, but both communities, the interventional community and the radiological community, are understanding that this is, a CT is beyond a diagnostic test, and we're using that for planning, and that's going to be the future.
We have to stop, Joanna, because we give plenty of time for the question. Carlos, you're still in the phase where you will have in the audience in Dutch, ja maar, or in English, but. Chris starts by but. He's a young man, but he has a but. So I think that it will take some time. I mean, it took me 10 years to go from the balloon to the stent, 10 years to go from the stent to the drug-eluting stent, and another 10 years to go back to the balloon. So that's part of the history. You know, don't be worried about that. You will have followers, like in a crusade, more and more, but it will take time. Okay, we go to the next now. David, you want to announce the next speaker? Yeah. So we stay a little bit in the same topic with mass at risk and PCI bifurcation strategy. Frédéric Buisset.
Thank you very much, Professor. So, ladies and gentlemen, dear colleagues, it's my privilege to be part of this session to discuss about mass at risk when we are planning a bifurcation PCI. These are my disclosures. So, getting the mass from CT, how does that work? Well, we have seen this a bit in the two last presentation. We have basically two methods to get mass, specific vessel mass from CT. The first one is the Voronoi method, which is based on anatomy, and the second one, presented by Professor Serius, is the hard flow method, which is based on the flow. This is practically speaking how we use in the core lab the Voronoi method with the software. We just upload the CT, a normal CT, no photon counting, good CT quality, but normal CT. Automatically, the software has recognized the myocardial, left ventricular myocardial mass. It has recognized the coronaries and the branches. And if you are willing to know the mass of a specific branches, just like in this example, you just drop a point. For example, in this example, we wanted to know the mass of this diagonal, and we know that the mass is actually 13%. The fractional mass of this diagonal is 13% of the mass. So we can also get the mass in volume, in milliliter, and if you wish, you can convert this in grams if you are willing to know the mass in grams. But for bifurcation topic, it's probably more relevant to discuss about fractional mass in percentage. So this has been validated against histology in a clinical validation. And this is the hard flow principle. This has been detailed by Professor Series. Basically, it's based on the flow, hard flow model, based on the mass of the ventricles, the total flow that will subtend the myocardium, divide this flow in all branches based on the branches diameter, and then as mass and flow are proportional, we can get the fractional mass for every branches. So why is this relevant? Well, in a recent document published a year ago by the EBC together with Bark, there was an emphasis put on the relevance of the side branch. Basically, actually, it was stated that the relevance of the side branch is important to qualify a bifurcation as such, especially in a study perspective. If we wish to discuss about bifurcation, we should know how important is a side branch. And in this document, it was stated that CT is one of the tools that we can use. And what is a relevant side branch in terms of prognosis? Well, it's a side branch that subtends more than 10% of the myocardial mass. We can get this from CT, as we have discussed and seen in the previous slides. And if we don't have CT, we can also get this with angio based on the length of the side branch. This is from a previous work from the group of Bonkuku. And those branches with a myocardial mass more than 10% are relevant in terms of prognosis. That doesn't mean that you would be happy to lose a branch that is subtending less than 10% of the myocardial mass, but in a PCI perspective, maybe in a bifurcation, that would be probably worth
to discuss a two-stent technique, for example, if you have a side branch that has a mass that is more than 10%. And we admit that in a left main bifurcation, whichever is a side branch, it's always more than 10% of the myocardial mass. And this 10% is coming from this paper that we all know, that we have seen many times from Ashamovich years ago, saying that 10% is a cutoff to say that this is a prognosis, that has a prognosis relevance. So it's probably good to have in mind some repairs. This is a work from our group, the group of Carlos Collet. A colleague took 1,000 CT and analyzed almost 10,000 vessels. And we saw that in average, the mass of LAD is 43%, 29% for the left circumflex, and 27% for the RCA. But probably even more relevant is this analysis of the side branches. You see that PDA, PLB, and first marginal usually make the cut of 10%. First diagonal is usually around 8%. And what was very impressive to us is the mass of the first septal, which very often is almost 10% and very often even more, actually. So it's probably good to have in mind. Of course, what is very important in this mass distribution is the dominance. These are two extreme examples with a huge RCA and a small left circumflex. The circumflex in this case is 11% of the mass. And this is the opposite example in which we have a left dominance with a circumflex which is 54% of the mass. So if you were to do left main PCI for those cases, maybe you would not consider them the same way, probably. This is to show that indeed the dominance has a huge impact, especially on left circumflex and RCA mass. That's obvious, of course. So how to use this in practice? Well, I will show you a couple of examples. This is a case with two, I would say, big diagonal. I mean, if you ask me, I would say that both are big, actually, and both are diseased, by the way. But I don't know, if you were to treat those diagonal, I don't know which one would you choose, but we were very surprised when we did the analysis of mass to see that basically the second one is basically has basically 2 times the mass of the first one. So in this case, we chose to treat preferentially the second one for prognosis, of course. This is another example in which we were about to treat this lesion in proximal to mid LAD, crossing over 2 big diagonals. And again, the question would be, which one will I protect? Of course, you are experts in bifurcation. Maybe you are not afraid to use 3 wires, but in daily practice, sometimes we prefer to use only 1 wire to protect the diagonal, and we have to make a choice. That's also something that you can do based on mass. And in this case, it was obvious to see, you see that the diagonal 2 is actually 10%, while the diagonal 3 is 5%. So we choose to protect the diagonal 2 and go for a provisional approach with the second diagonal protected. So finally, an example of how to integrate this in a bifurcation PCI planification. The previous speaker has detailed everything that you can get from CT. This is an example of a bifurcation between left circumflex and first marginal. We saw from the mass analysis that both branches are actually relatively important. And this is the outflow model. We have a deep ischemia in this lateral territory. And from the outflow planification, we saw that one stent approach from left circumflex towards the distal left circumflex would be okay, but somehow disappointing in terms of flow improvement in the first marginal. 086 is not that good for a non-LAD lesion for post-PCI FFR. So what if we stand towards the marginal? Then that we would be disappointing by the flow in the distal circumflex. So in this case, we conclude that a 2-stent approach would be probably worth, and that was done in the lab by the operators. But most importantly, this was planned up front. Up front, we knew that we would go for a 2-stent approach, a 2-stent technique. Again, you are all experts in bifurcation. You are not afraid by doing a culotte, but it's not the case in every lab. If I'm not comfortable in 2-stent technique, if I knew up front, maybe I can do with a colleague who is an expert in bifurcation or more comfortable to do complex cases. So in conclusion, the myocardial mass is, especially in the context of bifurcation PCI, is a very relevant information, especially in trial perspective to qualify bifurcation as such. You saw that with a dedicated tool, it's just a couple of clicks, literally a couple of clicks, very easy to do with specific tools. And combined, as explained brilliantly by Dr. Cooley just before, with all the information we can get with the CT, we do think that this would enhance our planification and hopefully will improve patient outcome. Thank you very much.
Thank you, Frederic. That was a very complimentary talk, I think, for everybody. One question that I have immediately, we are a little bit in a prognostic context. Yeah. We don't want to lose 25%, and maybe we can lose 6%. But what about in the context of symptoms?
Yeah, definitely.
Can 6% of 8% be as annoying than 15% in terms of angina?
Yeah, that's a good point. Actually, in this document that I showed before, it was clearly stated that the cutoff of 10% is made for prognosis. And of course, we may have a patient having symptoms for a lower mass, 8%, 9%. So why not doing PCI for if it's technically accessible and if not controlled by medication for a smaller mass? But this is not prognosis approach.
So I think we have maybe to revisit the data from Courage, because that 10% date now, what, 12, 14 years ago. I saw this week that ischemia has been completely analyzed by Jim Min. I didn't have the time to read the paper, but I'm curious to see if there is something in terms of myocardial mask and prognosis. Any question? Now, Carlos.
Concerning So I think this approach really tailors the PCI strategy. I want to just answer your question and then make a comment. Your question on symptoms. We're analyzing the data from Rasha Lamé from the recent trial in the Orbita family, where she inflated the balloon and see if the patient has symptoms or not. So we'll have the answer on how much mass triggers symptoms. Probably not definitive, but some guidance in terms of that. Now, this data of Abramovich, I don't know if I pronounced that name correctly, but it's basically too old and coming from PET. So I think this 10%, you use it. I use 5. You know, Frederick, what do you use? I use 5. You know, I don't want to lose anything that is bigger than 5. If it's less than 5, I don't mind. But I have to tell you that I've been impressed by losing some septals that have 15, 17% of mass. These septals produce a lot of symptoms in the lab. You get a huge troponin. All those go to the Kaplan-Meier curve. So I think by having an understanding on how important are the mass of the side branches involved, I think you can. I'm protecting septals now in my PCI, so this is how my practice has evolved based on this.
Yeah. So one of the things you've not taken into account is large acute RV marginal branch that you might jail in right coronary stenting, or diagonal that you've left that can cause symptoms, not only symptoms, but sudden cardiac death, or large acute RV marginal branch being jailed causing RV infarction. So where does that fit into the picture?
Yeah, that's true. That's a limitation of this analysis. We are only taking into account left ventricular mass, not right ventricular mass. Yes.
No. Yeah, excellent presentation, and Carlos, your work has been great showing us again. So David asked us before, so it's all on the DICOM files. It's just on the coaxial slices, but you have your own workstation. We use it for the CT, it was already mentioned before, and we have to prep our heart team better because, you know, these are big questions. So it should be a side branch with a large mass. It's a side branch where you see the ostium is diseased, so I have a big chance to lose it during the procedure. And if I'm going to go for a two-stent strategy, I go back to my question, should I go back to the heart team and say, if I do a two-stent strategy, a large bifurcation, there's multiple disease, the outcomes are poorer, we know that also from Patrick, then maybe you better go back to your heart team and say surgery is maybe a better option. So yes, mass is important, the ostium is important, is it going to be two-stent, going to lose it, etc. So great work, and we should all prep our heart teams better. I think that's your message.
Patrick, just one question. I just want to say that you know, I think the message about the journey that you gave us, right? Always go back to history and say, you know, where have we come from with angioplasty stents? I said there's no question that CT is the next frontier for sure.
And I think that some of the software, Carlos, that you're working on and others are going to be critical for that. I do think that today CT is going through the same process that angiography went through 20, 30 years ago, where image quality does matter. If you've got a 64 slice, 128, et cetera, the acquisition parameters, the amount of contrast, the artifacts, all those things, garbage in and garbage out. So I think the software and AI will allow us to correct some of that. But the exciting point, as you said, with the photon CT is really the evolution and the standardization of practice patterns with CT, so we can leverage it. So I do think that it's going to take us, a number of years to kind of bring this into the clinical practice, but absolutely disruptive and very exciting.
So the point that you are making is very important. I mean, photo counting is eliminating two layers. Okay, the photon is immediately directly transferred in an electrical signal, if I want to say that in one sentence. So it's a quantum leap in the technology. It's not another CT. No, it's another concept. And that's what the people, I think that maybe next year we need a short introduction for Mr. Everybody, and I'm part of it, about what is the photo counting. Yeah.
The questions there remains a bit the same. So you're jumping in quality and resolution in calcium detection. You're not jumping in speed. So you say 100 micron. The heart sometimes is more moving than 100 microns in this acquisition window of 250 microns or 200 microns. So, and the body mass of our patients go up, go up, go up, and the radiologists go down in kV. So I think that we have quite some problems left. Quantum leap, yes, problems remain.
But if I can make just a comment, of course, photon counting will solve this quality problem. But already with standard scanner, if you go to your radiologist, explain what was mentioned before. This is when you see calcium, please increase the kV. Please use nitrates. If you go to your radiologist, show the type of images that they can get, that you want to get. Already today, with their current machine, they can probably do better. But we need to push. That's also our role. We need to go to ask them, this is the standard now, please improve your quality. I mean, France, photon counting in my hospital is not for tomorrow, I know. But already, with what we have, we can improve our quality.
Okay. Yeah, one question from my side. How good is the assessment of the myocardial mass in patients who have got a proximal lesion in the main vessel, and you assess the branches? For example, a proximal lesion in the LAD, significant lesion, and you have lesions in two diagonals. How do you assess? How good is the assessment?
I think the next talk will talk about that. So I think it's a good question. Now, I just want to say that at the ESC, I had the privilege to present hierarchical phase contrast CT. That's the next generation. It's if we have the time, it's a video of 2 minutes. It's amazing because the voxel is now, listen carefully, 2.26 micron. Voxel of 2.26 micron. I will not tell you how they get there, but the pictures is amazing. It looks like an OCT, better than an OCT. Yeah. So that's if we have one moment, we'll put the video just to have the electrical shock, and then I will tell you how it is done, because it's a little bit misleading. Thank you, Frederic. That was very good. I don't think that anybody is a volunteer to introduce the next speaker, but that's my partner in crime, if I can say so, for 15 years. So Yoshi Onuma, Professor Onuma, will talk about comparison of FFR-CT, Murray-Bayes and geography, and I see that Dr. Tu is still in the audience. That's a good news. And QFR, impact of serial bifurcation. That's probably the answer to your question.
Yeah. Thank you for the introduction. So this analysis is part of the fast-track trial, which already have been shown by the Professor Sirais. So as you know, that there is a fractional flow reserve derived from the coronary computed tomography, FFR-CT, such as heart flow, quantitative flow ratio, and also the Murray law-based quantitative flow ratio, Sanven just presented in the previous sessions. And those are the image-based non-pressure wire-derived FFR tools for the diagnosing and potentially planning of the treatment of the obstructive coronary artery disease.
So those technologies have been developed and also tested in clinical trials, and as you could see that in the new guidelines, the QFR is listed as a 1B recommendation for the physiological assessment. And Murray law-based QFR, MuQFR, is a novel computational method using based on a single view, so you don't need two views anymore, and also taking into account the side branch diameters by the Murray's law to compute the fractal flow division. So this just analysis was to investigate the correlation and agreement with between the FFRCT and QFR and the MuQFR at sequential side branch point in patient enrolled in the fast track CAVIT trial. The one kind of disclaimer is this patient has the 3 vessel disease or the left main disease, so it's a very complex coronary artery disease. So the diagnostic accuracy of the QFR, FFR is not really a problem for this population because anyway patients need the revascularization. So we try to really use these technologies to plan the procedures, and actually those patients were treated with the CABG, but you could also use this technology for the planning of the PCI. So all patients underwent the CCTA and angiography, and FFRCT, QFR, and MuQFR were calculated using the HeartFlow, Medis Angio 2.1 software, and Pulse Angio Plus version 3.0 software, respectively. And FFR values were calculated as a sequential side branch point with all 3 softwares, and we measured the FFR at the point of polygon of conference, the end of the polygon of the conference polygon of the conference in the distal main vessel. So it's just distal to the bifurcation. So this should be this way. Yeah. So these are the physiological principle of 3 technologies. HeartFlow is based on the CT, and reconstruction is very complete in the sense that all the side branches, coronary arteries, are reconstructed based on the CT images, which is very easy to present in a 3-dimensional reconstruction. Medis QFR is based on the 2 angiographic projections, and you need to have 25 apart 2 projections, and it's based on the Landskurd equation, and it's as some veins show that reference diameter is tapering model, so it's only the one line of the reference diameter. And for the pulse MuQFR, the Murray's law is implemented, so you can see that the reference diameter is somewhat changed over at the point of the bifurcation, so it's accurately calculates the reference diameter. So the software of the HeartFlow recognize the side branches because all side branches are reconstructed in 3 dimensions. MuQFR also recognize the side branches in this analysis. Medis does not really see or calculate the side branches in its analysis. So these are the population. We had 114 patients, 342 vessels, but we exclude the CTO because there's no need for the CTO to do the QFR, and the software doesn't give the values. So we have 266 vessels, and because of the technical problem of the angiography or the FFRCT, we excluded some vessels. So in the end, we have 199 vessels analyzable for the FFRCT, QFR, and the MuQFR. So this is the images of the one case we did for the analysis. You see that MIP and volume rendering. This is a MPR, curved MPR, and this is the FFRCT images. So angiography, we need to calculate Medis. We have 2 projections, and for the MuQFR, we could derive this measurement from the 1 projection with the minimum overlap. So what we have done is that we just co-localized all these projections. So for the CT and the angiography, we have exactly same projections, and we could also derive the pressure curve from the FFRCT, also from the Medis and Pulse.
We also look into this each bifurcation. So in FFRCT, the major side branches were reconstructed. So each side branch point just distal to the polygon of conference in the main branch, we measure the QFR or the FFRCT. And for example, for this MEDIS, you could really locate the exactly same side branch on the angiography. And for the each side branch point, we look into the QFR value along this main vessel. Same has been done for the pulse QFR. So you could see that already there's some difference from the first branch, which is 0.78 in the CCTA heart flow, which is 0.98 for the MEDIS. For the pulse, it's more close to the heart flow analysis, 0.88. And along this analysis, there is some trend toward the little bit higher value with the QFR MEDIS. So these are the just entire analysis. So we have a 984 measurement points. So it's a little bit difficult to comprehend or grasp the message, but basically if you compare by means, the QFR is the 0.0 by 0.026 higher than the FFRCT. The limit of the agreement is 0.244 and minus 0.295. If you compare the μQFR and FFRCT, the systematic difference in mean is very minimum, just 0.004, and relatively similar limit of the agreement was observed, 0.245 and minus 0.252. So if you divide that each level of the side branch, the first side branch from the proximal, so including left main or the major bifurcation in the right corner artery, you could see that the value of the FFRCT is 0.94, QFR was 0.97, and μQFR was 0.94. So there was a significant difference between the FFRCT and QFR. QFR is higher than the FFRCT and also than compared to the μQFR. There was no difference between the FFRCT and the μQFR. Same are observed in the second level of the side branches. So you can see that on average, FFRCT has a value of 0.87, QFR 0.90, and μQFR 0.88. Third side branch is the same. The QFR has highest value compared to the other two modality of the image-based FFR. Fourth side branch, the number becomes relatively small. In that level, still the QFR has a higher value compared to the FFRCT, but there's no difference between the QFR and the μQFR. And fifth side branch, apparently not so many patients have the 5 side branches, so the number becomes a bit lower. In that level, there's no difference between these 3 measurement, FFRCT, QFR, and μQFR. This is the same data, but dividing into each level of the bifurcation, like left main, diagonal, obtuse marginal, etc. You can see that left main has already shown that the QFR has the highest value, 0.97, compared to the 0.93 of the FFRCT and 0.94 of the μQFR. So there's no difference in the diagonal D1 level. However, if you go for the obtuse marginal, there was a significant difference, again highest with QFR compared to the other 2 measurements. Obtuse marginal 2, there's no difference, but for the right corner artery, the major bifurcation between this PL and PD, then you can see again some difference. The QFR has a value of 0.82, which is significantly higher compared to the FFRCT 0.76 and the μQFR 0.77. So in general, the QFR has the highest value. Of course, we have seen that improvement of software with the MEDIS as well. So the analysis, what I have shown, was done by MEDIS 2.1, but now we have a MEDIS 3.0. This is how the MEDIS 3.0 works, and it has a more automatic calculation of QFR, and also the algorithm was somewhat improved in terms of the reference vessel diameter calculation. So
work is ongoing to use this MEDIS 3.0 to update this analysis. But so far, what we have found is that if you compare the MEDIS and PULSE and the FFRCT, the value of the QFR is in majority of the bifurcation a little bit higher than the other two modalities of the imaging. Myocardial were not significantly different from the FFRCT in this side branch analysis. So these results suggest that the implementation of the fractal law or the bifurcation law is very important for the image-based FFR measurement in bifurcation. And I think for the next step, we want to extend this analysis using the latest version of MEDIS software. And I think we need a further research and analysis to confirm this result in a larger population and also look into some validation in the phantom. Thank you for attention.
Yoshi, thank you very much. That was a very comprehensive presentation. And I have to say that I was a bit shocked when you showed the correlation plots, because removing these points in the 0.5 line that we know is because the FFRCT cannot go beyond that, but even removing those points, you see that the scatter is significant. And although you have a mean difference that appears to be low, the limits of agreements are huge. You have almost 50 points within the limits of agreement, basically meaning that 68% of the data will have a difference of 0.15 or something. So it's quite large. In the context of the limitation of the study, which is that you don't have the gold standard.
Yes,
that's a big, I think, the biggest limitation. But how do you then, and I make these questions to you too, because you have been pioneering this new kind of insights into this technology that perhaps is not so accurate as it was shown at the beginning. So how is your thinking evolving on the real accuracy of all these technologies after this study?
Yeah, thank you for your comment, and I agree that we are also a little bit shocked to see this result. But the one thing is that for this population is very severely diseased, so syntax score is 44. So it's not about the diagnostic accuracy. Anyway, if you go to the end of the analysis, in the end of the vessel, the FFRCT is more or less than 0.8. So it's not about diagnostic accuracy of the vessel level or the patient level, but I think that has an implication when you use this technology during the procedure, because in the procedure you have to select the which bifurcation should be treated and how. So I think it's more a little bit subtle, and it's not about the diagnostic accuracy, but for the planning phase, I think it's important to take into account this difference, and I think further validation is probably needed for this population. And I didn't show that, but also the PPGI and the other parameters we have tested in this population, and we have seen that the PPGI is completely different from the three technologies. So I think we need really more data to validate these technologies.
Yeah. Yoshi, can I ask one thing? So PPGI will be actually overestimated by the MEDIS QFR from what you're showing, right? Because if it doesn't take into account the side branches, it will be already lower and will show you more diffuseness of the disease. Is that correct or not?
Yeah, so I have actually the one, can I come back on my slides? I have that in a backup slide. And that was a comparison of the PPGI index in the QFR and Myocardial and FFRCT. So the PPGI index value is higher with the QFR, so you're right. I think it's not picking up probably the diffuseness of the disease, and FFRCT and the Myocardial has a lower value, which means that it's more diffuse. But also the three values are very different, so I think we need a further validation if you really try to use it for the planning of the PCI, which is different from the diagnostic accuracy, I assume. So.
You know, it's a very interesting story, because if you think about it, what is determining a gradient? A gradient is determined by the flow and the anatomy. So basically, it's a long discussion with Nico Pels in 91, okay, when he wanted to introduce the pressure measurement of the gradient. As I'm sure you have to do it because the anatomy is poor and the velocity is poor. So for almost 2 decades, the golden standard, the validation is versus the pressure. But I can tell you, when the anatomy got a resolution of 20 micron 10 micron, 2.5 micron, as I was mentioning, the finite element of that plus the flow will be superior to the pressure. The pressure is just 1 point. In that lectures about how do we see revascularization 2040, I was illustrating my case that I think in 2040 we are no longer recording the pressure. For which reason is that more and more, take the MRI, you have all these vectors, and you can have the velocity of all these vectors that's far more superior to a pressure at 1 point. It will take time, it will take 1 or 2 decades, I will not be there, but for sure, I think pressure will disappear. And the imaging, getting a high resolution, is the determinant of the pressure gradient. That's the paradox. It's a indirect product. It's a surrogate.
So to answer, that's the music, Bernard. If you are applauding, it's because I have to move. I just want to make one last comment, is that for the question you made, Joanna, I think it's important we look at this, and Professor Rosa and myself have been looking at all this angio-FFR systems and the simulation of FFR, specifically addressing the pattern of disease, which is, as you know, that's the next step in physiology. And we have, last week, we published the first validation, invasive versus angio-FFR, and basically, you need the pressure wire. You need the pressure, that's the short answer.
So we start 1 year ago with this iconoclastic paper and JAK intervention, and I think that the IMR will be the next victim in the process. But okay, so let's go on. And the next paper is Nikolai Brench-Old Stortrup. I hope that I pronounce that more or less correctly. It's case-based presentation integrating anatomy and physiology. So we will have a reconciliation at the end. I think it's a video.
Dear Chairman, thank you for the invitation to present at the European Bifurcation Club 2024 meeting. The title of my presentation is Case-Based Presentations Integrating Anatomy and Physiology, CT-Guided DK Crush and Provisional Percutaneous Coronary Intervention, the P4 approach. This case was performed at Aarhus University Hospital, Denmark, in collaboration with Kåre Alst, Dr. Carlos Collet, Dr. Frédéric Busset, and Dr. Hirofumi Ohashi. I have no disclosures. This case is a 75-year-old gentleman with stable angina, CCX class 2. He had a previous history of bicuspid aortic valve disease and hypertension, and treated with ACE inhibitors and beta blockers. He had a normal ejection fraction and preserved renal function. The CT was acquired on a Siemens Force scanner using 90 kVs and 70 mils of contrast. He was moderately symptomatic and scored 69 on SAQ-7. This rather busy slide illustrates the structure of CT-guided intervention broken down into 3 distinct phases: a planning phase, a strategizing phase, and a potential outcome phase. Initially, we obtain information about coronary anatomy, calcium load, and global calcium distribution, and this helps us to stratify case complexity. In the axial view, we can appreciate coronary ostium takeoff and plan for optimal catheter selection. Lesion characteristics are seen in curved and straight MPR and cross-sectional views to help understand plaque morphology, lesion length, and requirements for vessel preparation and stent length. The myocardial mass at risk can be seen and help to identify important side branches that need protection. And optimal angulation may be explored to achieve best available projections. Finally, physiological properties can be integrated through computational models of fluid dynamics, identifying severeness in stenosis and predicting post-PCR FFR. Using this workflow, we could see a moderately calcified LAD with steep angulations in both the left main and LAD diagonal bifurcation. Disease involved both the LAD and the diagonal without any proper landing zones in the proximal LAD. The myocardial mass analysis showed that the diagonal subtended 12.2% of the left ventricular mass, deeming it important for protection. The CT showed a calcified lesions and areas of concentric calcification. Likewise, the diagonal and the bifurcation core and areas just adjacent to this area showed high lesion complexity involving moderate calcium and plaque, and furthermore, the presence of calcium in the main vessel on the contralateral side of the diagonal, raising concerns for the ability to achieve a systemic stent expansion and possible carina shift. Both the circumflex and the RCA showed no signs of significant disease. A computational fluid dynamic models was created by HeartFlow and showed a significant pressure loss across the LAD and first diagonal branch. By using these in silico prediction models, 2 stent strategies were developed, one proposing a provisional approach across both diagonal and circ, and a 2-stent strategy involving the LAD first diagonal bifurcation and a provisional approach across the left main. And this is the angiogram showing the LAD in orthogonal views, confirming angulated anatomy and severe osteal disease involving in particular the LAD D1 bifurcation. Pressure wire physiology testing confirmed significant disease in the LAD at 0.75. Confirmatory iris aligned with the CT demonstrating circumferential calcium in the LAD just exceeding arc of 180 degrees and fibrocalcific disease in the proximal LAD. So based on this information, there are a variety of different treatment strategies involving the possibility of medical therapy, different PCI approaches from balloon angioplasty, provisional stenting of main vessel to complex stenting involving 2-stent strategy in the LAD diagonal bifurcation. We chose a 2-stent strategy out of a safety approach with a concern for the diagonal bifurcation, risk of severe side branch dissection during side branch pre-dilatation, and risk of difficult rewiring after a provisional attempt. So I chose a systematic 2-stent approach by DK crush technique for the LAD D1 bifurcation, addressing the severe disease in the bifurcation and proximal diagonal branch. Lesion preparation was done using a semi-compliant 2.5 balloon in the diagonal and a 3.0 scoring balloon in the LAD. A science 2.5 times 28 was implanted in the diagonal. LAD was stented using 2 stents with overlap distal to the LAD D1 bifurcation, and the distal LAD was stented with a science 3.0 times 28 millimeter stent. The proximal LAD into the left main was stented using a science 3.5 stent platform. After subsequent second post-dilatation pot and second kiss, and a pot kiss pot in the left main bifurcation, the angio showed a good result. Post-PCI physiology confirmed a satisfying result with 0.86 in the distal LAD and 0.90 in the diagonal. This was further substantiated by confirmatory iris showing good stent expansion in the LAD and good stent expansion in the diagonal, proximal LAD and left main. So in conclusion, this case demonstrates a novel approach incorporating CT-derived anatomical and functional procedural planning and guidance in a case of complex coronary artery disease. And this comprehensive non-invasive planning approach is currently being tested in the precise procedural and PCI plan study, the P4 trial. Thank you very much for your attention.
Okay, I have no idea of the timing. I think we are a little bit behind, no, for sure. So if there's no burning question, I think we can make the conclusion. And the conclusion is, from my point of view, multi-slide CT scan is going to stay in ABC. It's here to stay, okay? Okay, thank you very much.
Please take a seat. Still good morning. I have a big pleasure to co-chair this session with Professor Manuel Pan and Professor Habib Samade. He will come, he will appear. Yeah, okay. We have distinguished set of panelists: Dvorka Lulic, Nicolo Ciardetti, Wojko Kanic, Yong Lee, and Peter O'Kane. So please take.
Thank you so much. I just want to say that we have a wonderful session, but as Professor Soroy's mentioned, if we can allow him 5 or 6 minutes at the beginning of the program, he's going to just share with us his concepts about hierarchical phase CT contrast. So we do sort of, we're going to try to get all the other speakers in, but we want to have Professor Soroy share some of this really latest concepts with us.
I should not have mentioned it now. Okay, so that's my first slide. You see that clearly this morning we were talking about the photocounting detectors, and beyond the tidal wave, let's have a glimpse into the future with the hierarchical phase contrast tomography. It's called HIP-CT, going from microscopic volume rendering to microscopic morphology. So what you have today is to take note of that paper. The video is in this paper, and as you could see, it's a brand new data, and Rio Tori from the London is working with us. So the statement here is in the future, we could have a resolution of 20 micron per voxel and ultimately a resolution of 2.26 micron per voxel with the hierarchical phase contrast. So the video is going to show you a lady of 87 years old, okay, and stent in the LAD, an inferior myocardial infarction. I will not talk about the mitral, but she has also mitral regurgitation. So if we are ready, let's look at the video. We will start by the volume rendering. Yeah? This is the fat surrounding a heart. We go through, and then notice immediately that you see the artery and the vein. Look that you see the primary, the secondary, the tertiary, the quaternary vessel. And if you look, you can see that all these small vessels, less than 400 micron, is going perpendicular to a myocardium. So it's as if the fat has lifted away the coronary artery from the myocardium. I have never seen that pictures. And it gives us a lot of idea. The black is the place where you have some subendocardiac ischemia of injury. We will not have the time today to talk about the mitral valve and the other. So I just have 6 slides. I'll let you see again, going back. The resolution of the aortic valve and the mitral valve is phenomenal. The resolution of the compact myocardium, the border zone, I don't have the time to show you that today, but it's quite fascinating. So this is 2 hearts. One is 60 years old male, no comorbidities, normal heart, and this is the lady that you just saw a few seconds ago. And what I never realized, for me, that's conceptually something new in my brain, that you could have this coronary artery lift away from the myocardium. And basically, if you calibrate that, you can see that all these small vessels are arterial, basically, 400 micron and even less. So when you think about microcirculation, I always thought it was in the myocardium. But now I realize that the fat surrounding the heart can collapse and compress all these small vessels. And for me, it's a really new concept. Yeah? So this is a conventional virtual CT pullback. The vessel in blue, the fat is in green. That's called perivascular fat. You know the Caristo technology with the Ansfield unit to say
inflamed perivascular fat is Ansfield-Lunat even lower than -70. And then if you look at these, at the fat around the heart, it's unbelievable what is there. I make some beginning of the listing, adenopectin, cytokines, gaseous messenger. We know nitroxide. I didn't know about hydrogen sulfide. So it's really amazing. And then could the perivascular fat mechanically interfere with the conductance resistance of the pre-arterial and arterial and the responsibility? So I go quickly. You know these pictures. I don't want to interfere too much. Again, that pictures by multi-slide CT scan versus a cast of polymer, plastic polymer of the anatomopathologist. You can understand why it will be quite funny. Now, look at this. This is the top panel A, and you have the RCA. And the RCA is in panel C. And with this voxel resolution of 2.26, you see the adiposity, you see the lumen, you see the media. And if I zoom in the vessel wall in panel D, then you see small nodule of calcium, you see atheroma, you see media, you see vasa vasorum. The stent with the calcium around, that's a banality now, okay? And this is already the last slide. On the left-hand side, that's the non-invasive hierarchical contrast computed tomography. And on the right-hand side is the work of Gary Turney with intravascular micro-optical coherence tomography, published in Nature already a few years ago. And you could see crystal of cholesterol. You see the cap crystal of cholesterol, and then the necrotic core. And you can even see leukocyte attached to the endothelium. So the question that I was asking myself, if available, what are we going to do with that level of image granularity in the context of revascularization? And that's my final slide, but now I have to say the truth, all the truth, but the truth. Oh, yeah, let me see. So I misled the audience, and I must confess, okay? It's a post-mortem art. It's fixed in formaldehyde. The impinging photon is accelerated linearly by a synchrotron, which is in Grenoble. And as you could see, the heart is in a container, okay? And there is 170 meters between the cyclotron and the heart in the container. But it's a major program of the European Union, which was started at the time of the COVID. They want to understand the microstructures of the lung without cutting through. And this is going to be used by the anatomopathologist. So my last slide, and instead of rotating beam, we have to rotate the heart, okay? So the conclusion, if the future is unrealistic, fortunately, it will remain the future for us. If the future is realistic, sadly enough, it will soon become the past. That's my philosophy in life. Yeah.
Patrick, thank you very much. As usually, you shocked us. It's really difficult to come back to the real program of the session. My feeling is that might be at least this kind of research will make possible to let's say to construct to project new drugs, new strategies of treatment for atherosclerosis, at least. So, but now the realistic plan is session number 9. The topic is how should we treat 001 bifurcation stenosis. This is one of the unmet
demands of interventional cardiology. Let's start with the first presentation. Comparison of outcomes between 1 and 2 stent technique for Medina 001 coronary bifurcation lesions. Chang Wook Nam.
Thank you, Chairman. It's my honor to have presentation in here. And then sorry about bringing you to the floor again. It's realistic. Yeah. So there is a limited evidence regarding the optimal treatment strategy for the Medina 001 bifurcation lesion because there is some uniqueness and the reality of 001 is lesser than 5% in reality. So today I will a brief introduction about the 001 lesion. So first thing is how many 001 lesion in our daily practice. So to solve this, the answer is we need large registry data to the prevalence of 001 lesion. So we make an extended bifurcat registry, including Cordis 2, 3, and RAIN registry, more than 8,000 of patients performing bifurcation PCI, and do the Medina classification, and it was 4.1% for 001 lesion. It's really rare. And the second question is their behavior of a 001 bifurcation lesion. Is it benign or malignancy? So according to the previous Cordis 2 trial, we find out that the true bifurcation lesion is more event rate compared to non-true bifurcation lesion. And 001 is non-true bifurcation lesion. So in this extended bifurcat registry, we find out true bifurcation lesion is higher event rate than the non-true bifurcation lesion. But if you see the 001 lesion, even though it's anatomically non-true bifurcation lesion, but the event rate is most high numerically. But as you can see, the Cordis 2 registry is more than 15 years ago, so very old style. So we exclude again about Cordis 2 and include ultra registry performed in Italian group and very recent data, and then gather more than 6,000 of patients, and then do analysis, same thing. So how about the Medina class 001? Same instance, 4.0%. And how about the behavior? Same, even though it's a recent trial, recent data, but it's still very high event rate. So I think it's 001 behavior is a little bit malignant, not the benign. And again, back to the extended bifurcat registry. So we compared the 1 stent and 2 stent strategy. So when it was more than 15 years ago, we preferred the 2 stent strategy. At that time, we focused on the technique. Maybe you can remember that. So I was junior, but you are very know about that time trend. It's a complex procedure. But recently, getting provisional approach more. So mostly 1 stent technique was performed recently. How about the result compare the 1 stent strategy and 2 stent strategy? So most of 2 stent strategy location is a left main or LAD, more than 95%. But the 1 stent strategy, non-left main bifurcation is higher prevalence. And so how about the technique? The kissing balloon technique was performed mostly in the 2 stent strategy, but the pot technique is preferred in the higher prevalence in 1 stent strategy. And about the QCA data, it's very limited data because Cordis data has a QCA, but the RAIN registry do not have a QCA data, so it's a very selected patient. But anyway, 2 stent strategy has a relatively small side branch reference diameter compared to 1 stent strategy. So it means it's a side branch is a bigger, we can approach the 1 stent strategy. And about even though it's a 001, it means that there is no main vessel disease, but diameter stenosis is 2 stent strategy is 40%, more than 40%. It means even though 001, but we can consuming that there is some disease in main vessel, even though we classified in the 001. Anyway, the result, its primary endpoint was a composite endpoint of all death, MI, and TVR and stent thrombosis. And when we compared 1 stent and 2 stent, there was no difference in outcome.
not only one stent on two stent strategy, but also one stent simple crossover without main vessel opening was same result compared to one stent with strut opening. So there is no difference. Anyway, it's very higher event rate compared to the not the 001 reason. And when you do the sub-analysis compared to age, gender, diabetes, and left main bifurcation and non-left main bifurcation, and the complex 001 and non-complex 001, there is no difference. And the Cordis 2, 3, and range is also same, no difference. So why there is a higher event rate compared to non-001 region? Is higher event rate in 001 bifurcation region because 001 side branch disease is a negative remodeling. So it is higher chance of recoiling and less acute gain. And also, when you treat the side branch with a balloon OR stenting, there is higher chance of injury to main vessel. And also, the side branch has a smaller vessel diameter, and then we will input the smaller stent and higher risk of stent failure. And most important thing is angiographic 001 bifurcation lesion is not always true 001 lesion. Let's simply this case. It's angiographic definitely 001 lesion, such osteal disease. But if you see the IVUS, the distal left main has a more than moderate plaque calcified lesion. So in IVUS, we can say that 101 or 111 lesion, even in main vessel, LAD also have a moderate plaque. So angiographic 001 is not always a real 001 lesion. And when you talk about the treatment option, there is three ways of medical approach or balloon angioplasty and stent strategy. I already mentioned the stent strategy about one stent or two stent is higher event rate and no difference. But I want to emphasize about medical treatment because we already know that side branch myocardial burden more than 10% is a lesser chance. So generally, we can approach with medical therapy. And then we know that the DCB is another good option. But still, there is some strong point and weak point. Most important weak point is we don't have a large clinical data about the DCB use in 001 region. So we have to wait the result. So finally, this is my last slide. The incidence of angiographic 001 bifurcation lesion is rare, less than 5%. And recently, there has been a tendency to prefer the one stent provisional strategy for treatment of 001 lesion. And an angiographic 001 bifurcation lesion is not always real 001 lesion. So additional intracoronary evaluation like intravascular imaging or physiology would be useful. And the clinical outcome after PCI in 001 appears unfavorable about the stent 1 stent or 2 stent. So therefore, we have to take a higher risk than our thought and consider various treatment modalities when deciding on the most appropriate approach for each 001 bifurcation lesion. Thank you very much for your kind attention.
Thank you very much for this very fair presentation of the real field of 001 bifurcation treatment. Do we have any questions to the speaker?
Okay. Do you think the highest event rate of 001 bifurcation related to the concealed or undertreated the region in the main vessel, right?
Actually, we don't have a more advanced analysis about major event cases, but we believe that the early pace of Cordis 2 study is more aggressive approach is a problem. So higher rate of two-stent strategies, such kind of 001 is make higher event rate, I believe. So more conservative approach will be better. And then also, the second point is even though we believe that that's angiographic 001 lesion, but the reality is not the 001 lesion. Reality is more complex, like true bifurcation lesion, even though angiographic 001.
Do you recommend the more use of intravascular imaging?
Sure. Yes. Actually, if you want to treat with stent in 001 lesion, I think we have to
use the intravascular imaging before the procedure strategy decision-making.
You know the percentage of patients in which physiology was used? Because sometimes 001 is 000. So,
yes, of course, yes. That's why I emphasize medical therapy will be enough in most cases.
You know the percentage?
Sure.
You use physiology frequently in this study or not?
Although this is only retrospective registry data and performing with stenting cases. So it's very limited.
I was just thinking about the presentation that Carlos Collet did and the idea of, bringing anatomy, physiology, all of this together with CT, and it would potentially completely revamp the way we think about all this. But that was really an excellent presentation. Any other questions for Dr. Nams? Okay. So in the interest of time, let's move on. So our next presentation is by Dr. Yoshimura Sato, Impact of Medina Classification on Image-Guided Bifurcation PCI. Welcome.
Thank you, Chairperson. My topic is the impact of the Medina classification on imaging-guided bifurcation PCI. 2 years ago, the impact of Medina classification on bifurcation PCI was investigated in the large clinical trial E-Archmaster, which contains more than 4,000 coronary bifurcation regions. It revealed worse clinical outcome in Medina 001 as in 111 region. Higher target region failure and cardiac death was reported. In the previous speaker, Dr. Nam demonstrated the bifurcated trial, which is the integrated analysis of Cordis 2 and 3 from Korea and the Rhine registry from Italy. It included more than 8,000 bifurcation cases. And it is similar trend. 001 region has a worse clinical outcome compared to other non-true bifurcation region. So we conducted the integrated analysis of Japanese bifurcation studies, which conducted complete imaging guidance. We enrolled 4 studies: J-reverse with IBAS guidance, 3D OCT registry with OCT guidance, proper trial with OCT guidance, glider registry with IBAS or OCT guidance. A total of 778 coronary bifurcation region cases included, and the IBAS and the OCT frequencies are almost half and half. Major adverse cardiac event at 1 year follow-up demonstrated that there were no significant difference between the true bifurcation region and the non-true bifurcation region, except for the higher event of the 001 region, 18%. So we compared the risk of the Medina subclass hazard ratio compared to the Medina 010, which is the least event rate. Only 001 region has a higher mass rate with a hazard ratio of 4.1. So we compared these 3 trials. In terms of distribution Medina classification, as the previous speaker, Dr. Nam said, the 001 frequency is almost same, 2.8 to 4.1. So not so frequent population. However, true bifurcation region frequency, E-Archmaster and bifurcated trial are almost half of the cases. However, this trial, intracoronary imaging guidance is not so frequent, 12% and 49% respectively. In Japanese registry, with 100% imaging guidance, a frequency of true bifurcation region is less, 36%, because of the accurate assessment of side branch region. In terms of PCI procedure, 2-stent performance, the Japanese registry has least percentage, 20%. However, there is a similar trend as the E-Archmaster. True bifurcation region has significantly higher 2-stent performance compared to the non-true bifurcation region. However, 001 region has more frequent two stent compared to the other non-true bifurcation region. Japanese registry 9% versus 3% in the non-other non-true bifurcation region. E-Arch Master 12% versus 5%. Only bifurcate trial performed the two stent 39%. And the final cavity or strut opening in Japanese registry, the 0-1 region, more frequent performance was found, 86%. That is similar as in the true bifurcation region, and that is more than other non-true bifurcation region. Even in the bifurcate trial, 2/3 of the cases performed in Korea. However, 0-1 region final cavity performed 81%. And in terms of pot, in the Japanese registry demonstrated less pot performance, 32%, compared to the other median subclass, around 50%. Similar trend was found in the E-Arch Master. 0-1 region, 15% versus other region, 30 to 40%. Therefore, more frequent two stent and the final cavity and less pot performed in the 0-1 region. This is a comparison in the major adverse cardiac event in median subclass. E-Arch Master clearly demonstrated the significant higher event in the 1-1-1 region. A bifurcate trial, there were no significant difference among the median subclass. Japanese registry has a similar trend, except for the 0-1 region. 0-1 region has a only significant higher event rate. This is a target region revascularization in median subclass. E-Arch Master demonstrates a higher event rate in the 1-1-1 region and 0-1 region. However, Japanese registry, there was no significant difference between the true bifurcation region and the non-true bifurcation region, except the higher event rate in the 0-1 region. Therefore, imaging guidance improved clinical outcome in true coronary bifurcation region, similar as in non-true bifurcation region, because accurate assessment of the side branch lumen expansion and dissection, and appropriate pretreatment according to plaque morphology and distribution, and optimal device size selection and less two stent deployment. However, worst clinical outcome in 0-1 region under the imaging guidance was reported in a study because angiographic non-significant members region includes a moderate flag and similar PCA treatment as in true bifurcation region, more two stent and final cavity and less pot than in other non-true bifurcation region. These are possible mechanisms of worst outcome in 0-1 region. Over-treatment of invariable or non-ischemic side branch without confirmation of functional ischemia or peripheral perfusion territory, and more wide bifurcation angle between proximal member cell and the side branch, it leads to the more likelihood of neurological disturbance in the side branch, and hinge motion in the bifurcation, and angiographically non-significant member cell with moderate flag is ignored or injured during a treatment with POVA. Therefore, the following treatment is recommended in the 0-1 region. Prevent side branch over-treatment, decrease the stent number, and care the member cell plaque injury. In conclusion, intracoronary imaging contributed to reduce MACE in true coronary bifurcation region as in non-true coronary bifurcation region, except for 0-1 region. Despite of the less frequent needs of the treatment of 3 to 4%, 0-1 region remained higher risk of TLR even under the imaging guidance. Thank you for your attention.
Thank you. Any question from the...
May I ask you, do you believe that that in every single case the analysis of intravascular visualization is right by the operator? Because I guess that this is also the part of weakness arranged by the operator. Because you know, it's not a matter of fact to make a investigation, intravascular, IVUS or OCT. The main problem is just a good interpretation and translating these images into the good practical maneuvers.
Yes, totally agree. The intracoronary imaging interpretation is very important, especially the one region. The one region only is very rare. According to the imaging study, the consecutive plaque is existed in the proximal member cell. So the plaque level in the proximal member cell is that problematic. So our study, 90% of the case, provisional stenting proximal member cell to side branch. However, in that procedure has a significant higher TR rate. So that is a feature of the region.
Fantastic presentation. Thank you very much. Do you think now then we're ready? I mean, given the results of stenting in 001, do you think we're ready for a study now where we don't stent and perhaps we should do this trial of a DCB approach versus stent, because it's quite a high outcome, isn't it? You could drive a trial quite nicely.
According to this study is a historical study. So we learned about the provisional stenting for the one region is not so a good option. So the developing the plaque in the side branch and DCB is another treatment for the one region. Even in the small vessel, the squatting of the side branch ostium and the DCB is another option. So stent-less, stent-free for the one region is applicable treatment for this region.
Okay. 2 years ago, we published a BIF-R consensus with Patrick. In the paper, you can see the ranking of severity of bifurcation lesion. 001 was the less severe bifurcation lesion. But in contrast, we have the worst result as compared with other Medina classifications. I don't know if we have to rewrite the paper or what is your opinion about this paradoxical finding. Is a bad treatment for the operator? Is a worse type of lesion? What is your...
So the one lesion should be discriminated from the other non-true bifurcation lesion. True bifurcation lesion, non-true bifurcation lesion, and the other one lesion. 3 parts should be discriminated.
In the meantime, I have a comment, Professor Murasato. So before discarding the value of drug-eluting stent in in Medina 001, don't you think that we should check if the technique for implantation was appropriate? I mean, POT done not systematically. How it is possible to implant stent in Medina 001 not performing POT when we know that it is really the condition where there will be the measure mismatch between the two sizes? Did you analyze in this direction?
So in the study and E-arch muscle, the one region has less port performance. That is another reason for the worse clinical outcome in the one region. So the one region also has a proximal member cell has a moderate plaque. Should be done. Port should be done for the one region equally as a true bifurcation region.
Okay, well, so, I think there are a lot of, would you mind if we just keep moving, because we're a little bit behind on the schedule, and we'll grab you on the next one. Okay, so our next, thank you so much, Dr. Murasato. Let's give him a hand for that. Fantastic. So our next speaker is Dr. Francesca Sanguinetti. And it looks like it's going to be a virtual talk, and the title is Decoding Medina 001 Bifurcation, Are all codes equal? Insights from a multi-center registry. Welcome virtually.
Dear Chairman, dear colleagues, thanks for inviting me to present at EBC 2024. The title of my presentation is Decoding Medina 001. Are all code equal? These are results from a multicentric study. Why this registry? Because among all bifurcation lesions, Medina 001 are the less frequent, mostly excluded from bifurcation studies, the most underrated, because probably we consider that this kind of bifurcation is associated to a limited myocardium supply, but they are also those with the worst outcomes. There is at this time no registry dedicated for this kind of bifurcation. So the idea to build an international and multicentric registry, patients were included from retrospectively and from 2017 to 2022. The objective were to provide a real-world clinical, angiographic, procedural, and follow-up data, and to assess the clinical outcome after different PCI strategies, to identify potential predictor factors for the adverse outcome after PCI in Medina 001. Our inclusion criteria was at least one de novo significant Medina 001 lesion that was starting at less than 3 mm from the ostium. We excluded all previous PCI in the main or the side branch, thrombotic ostial lesion with the landing zone more than 3 mm after predilatation, and we excluded all side branch diameter inferior to 2 mm. We collected data, angiographic and demographic and clinical, and we performed clinical follow-up to all the patients included. Our primary endpoint was 3 years MACE, a composite of cardiovascular death, myocardial infarction, and target vessel revascularization. Our secondary endpoint was the target lesion revascularization. We were also interested to subgroup analysis, and in particular to the PCI strategy and comparing ostial versus the provisional stenting. We were interested to EBC recommendation applications, considering as application a procedure in which we had the inverted provisional stenting as a preferred technique, with both branches wired, the jailed wire technique, and a pot correctly done. We also compare left main versus no left main bifurcations. So if we look at the baseline characteristic, we can see finally our database counting 273 patients. Female were less represented, and we could appreciate 30% of diabetic patients. The clinical presentation was more represented by stable angina and silent ischemia. Looking at the lesion characteristic, was particularly less represented at the right coronary artery, and the side branch diameter was quite big. For the procedural characteristic, we could see one stent strategy preferred in mostly of patients, but in half of them, we could appreciate an ostial stenting, which is not considered a real bifurcation technique. The use of DCB, as well that the imaging was less represented. So the endpoint was experienced by 74% of patients at the median follow-up of 3 years, and the only independent predictor of MACE at 3 years was the diabetes. Looking deeper in the technical aspect may be more interesting for this kind of treatment. The 3 years MACE were compared for ostial stenting and inverted provisional. In this comparison, we could not appreciate differences in MACE at 3 years, but we could also appreciate that ostial stenting is preferred when there is an acute presentation, when the bifurcation doesn't involve the left main, and when the side branch is smaller. This probably means that when we are in an acute setting, we probably prefer to go faster and to stay simpler, especially if the bifurcation is not very big. Comparing the EBC adherence, we didn't find differences in MACE at 3 years, but in this case, we could appreciate that the EBC was very well applied and respected when the bifurcation involved the left main, and of course when the clinical presentation was chronic. And going to consideration of the left main involvement, we could see that this kind of bifurcation is associated to more events at 3 years, but we are talking about more stable presentation and a larger main and side branch diameters. Our study, unfortunately, presents a lot of limitations. We are talking about a retrospective design. So, of course, we have some potential selection and bias regarding the side branch dimension in particular. We have not a lot of right coronary arteries included. Our diameters are bigger. So probably there are a lot of bifurcation treated by just oral medical treatment, which was not included in this database. The sample size is unfortunately relatively small. Even if we have 300 patients, we do not probably have enough statistical power, especially in subgroup analysis. And there is a low use of intracoronary imaging, probably because we consider this kind of bifurcation less important than other, and so we keep this kind of expensive technology for other kind of bifurcations. Also, DCB were underrepresented, and this, I think, it will be an important idea for future studies in this particular setting. So in conclusion, this kind of bifurcation presents high rates of the adverse event after PCI. There is an heterogeneity in treatment strategy more than for other bifurcation, but it seems that there is no clinical impact of this stenting strategy on MACE. There is a less common application of EBC recommendation when the artery and the bifurcation, and in particular the side branch, is smaller and in acute setting. Thank you for your attention.
Okay, thank you for your nice presentation. Any comment for the panel or from the audience?
Yeah, I think it's clearly coming out from this study that left main is making a difference. That means when we have distal left main, means we do not have side branch, we have main vessel. In non-left main, I think what is lacking is the medical therapy, the outcome with medical therapy against interventions.
Great. I think there was another comment from the prior speaker, please.
I would be interested in knowing, you spoke about the adverse events occurring. What were the adverse events? Were they related to the side branch or were they related to the main branch problems coming up?
I don't know if you can hear me, but yeah, all our MACEs were principally driven by the target vessel revascularization, and target lesion revascularization was quite high. So I think that the treatment of the bifurcation is what is driving the MACEs at 3 years.
I have the question regarding the ostial treatment of, let's say, ostial stenting of the 001 bifurcation, because it's not well or very loudly disputable thing. We theoretically we should avoid these ostial lesions, especially without imaging before the procedure. Could you tell us really that the results were the same? So it's safe. That was really 001 bifurcations without this imaging. It's safe to do this, say, this technique.
I just want to be a comment for, first of all, I really not agree with this kind of treatment, but of course we have to discuss all the bifurcation included. So even if I not agree with this technique, we can find it in this treatment. And even if we are talking about the 3 big volume center in which I take the bifurcation is very well studied, this kind of practice is anyway founded. I think that bifurcation were really 001 bifurcation, but of course, it was about in the limitation of the study. We do not use a lot of imaging, so it's a limit, of course. So I'm talking about angiographic evaluation, and I think that the result, of course, seems to be the same, but we have to consider that this kind of bifurcation, the kind of bifurcation treated with ostial stenting is a bifurcation which is not a major bifurcation. We are talking of a smaller diameter of the side branch. If we keep the mean diameter in our series at 2.7, it's quite bigger, and that's because we are including left main treatment. So when we are talking about diagonal in particular or marginal branches, of course we are dealing with a smaller diameter. So I think that clinically we do not appreciate event because the ostial stenting is chosen when the bifurcation is smaller, but probably if we could perform a coronary evaluation in this patient, we probably find more events. But as the evaluation was only clinical, maybe this the myocardium associated with a small marginal or a small diagonal branch is less than for a bigger bifurcation. So that's why it doesn't speak clinically.
Peter O'Kane, just a great talk. I mean, I think the lack of physiology for me is something which I think, is, for me, it's very important to understand whether this is a relevant bifurcation before we start, because clearly I think you've demonstrated, as is the previous talks, that the event rates are higher, and we need to really make sure that we should be treating this before we even embark on it.
All the patients included in the basis, in this phase, had a clinical relevance of these branches, and this was demonstrated by the clinical setting in acute coronary syndromes or by MRI evaluation or CT scan and a clinical assessment or echo stress that was pointing in this territory. So we had actually clinical evidence of the relevance of this kind of bifurcation.
Okay, thank you for the presentation and for your answers. It's time to continue with the next presentation. It's the treatment of 001 left main bifurcation lesion by Soledad Ojeda.
Hello, good afternoon. Thank you very much for the invitation. My disclosure. As everybody knows, 001 left main bifurcation lesions are particularly challenging for PCI. Although different techniques can be performed, such as nailing the osteo, inverted provisional stenting, angioplasty with drug-eluting balloons, or even more sophisticated techniques, it's important to highlight currently there are not randomized studies or robust evidence comparing different techniques. There are several key points to keep in mind when dealing with this type of bifurcations. Bifurcation angle is very important. It's important to assess the type of angle. It's important to assess the circ size and the dominance. Other point to consider is the intracoronary imaging techniques, because IBUS and OCT can reclassify the lesions. Really, as previously commented, pure 001 lesions is very, very infrequent. Physiology can also play a significant role in avoiding treating no significant lesions in this complex scenario. Regarding the techniques, the first one, nailing the ostium, although in the past probably was the most popular technique, currently its use is more controversial. However, it can be an option in these situations if the angle is perfect, close to 90 degrees between left main and circ. There is a perfect visualization of the takeoff of the circ, and the left main is healthy. This technique obviously has some drawbacks. There is a risk of carina shifting. Stent protrusion into left main and LAD is frequent, or incomplete cover of the circle lesion, because a perfect angle a precise deployment really is not easy. This is a demonstrative example. The patient is a young man with an acute occlusion of the circ after predilation. We can see the lesion, the left main and LAD apparently healthy. So in this context, with the patient in a bad very clinical condition, the decision was to implant an stent, doing a nail in the ostium. But the deployment wasn't easy due to the movement of the heart. But after implantation, really the result was angiographically pretty good. But as we can appreciate in the stent boost technique, the adjustment is not so precise. We assessed the result by IBUS, and we can see in the slides there is a pullback from LAD, another pullback from circ, and the stent protruded into the LAD. So it really is difficult to do a perfect nail in the ostium. Inverted provisional stent is maybe the better option for most of the cases, because the plaque usually stents to the left main. With this technique, the ostium is completely covered, and current stent can accommodate significant discrepancy between circ and left main diameter. So the issue of the mismatch is less relevant nowadays. Obviously, the technique also has some drawbacks. There is a risk of damage of the LAD, and if the angle is very wide, the excessive angulation on the stent can be associated with a risk of stent failure at follow-up. This is a demonstrative example. We can see the video. Video, please, both. This patient had a very severe lesion, a very calcified lesion, and the circ and the ostium. As we can see, the circ was dominant in the assessment by IBUS. We can see the ostial circ with a very severe lesion, a very calcified. So after plaque preparation, An inverted provisional was performed, kissing balloon inflation, and this is the final result, very good. In the stem book, we can appreciate the scaffolding of the LED, and we achieved very good areas in the distal left main, in ostial of the circ, and LED. So in this patient, inverted provisional was a very good strategy due to the anatomy and the dominance of the circ. Drug-eluting balloons can have or can be a potential alternative to this in this setting. It's very attractive technology, and it avoids the issue of ostial miss or main vessel protrusion. With this technique, there is a lack of data to support this strategy, but there is a risk of optimal result and acute occlusion. So, although the technique is very attractive, we need more data to support the strategy. This is a very representative example. Please, video. We can see video, please. I don't know why. No. This patient was an elderly patient with severe aortic stenosis scheduled for TAVI. The patient had a very calcified lesion at the circ, at the ostium of the circ. We tried to pass the IVUS, but the catheter didn't pass. So we performed plaque preparation with OPM balloon and lithoplasty. After that, the decision was to consider the clinical characteristic of the patient. The decision was to do an angioplasty with drug-eluting balloons. And here we can see the ostium of the circ, the area very good, considering the critical stenosis at the beginning of the procedure. So in this patient, it was a good alternative. Finally, medical treatment can be an option in some patients when the vessel is very small, the lesion is not a culprit lesion, or the lesion is not significant from a physiological point of view. For example, in this patient, he has an unstable patient with a very severe lesion in the middle part of the circ, and not really a lesion, but yes, a very ambiguous image in the ostium. So our decision was to treat the severe lesion, and after that, the ostium was evaluated by IFR. IFR was negative, so we decided to treat the patient medically. So avoiding a more complex treatment in this scenario. So, in conclusion, really, left main is different to the rest of bifurcations. 001 are complex lesions in this scenario. There are different strategies depending on several factors, and we need more evidence to establish the best strategy for our patients. Thank you very much for your attention.
Well, that was an excellent presentation. Thank you. And in many ways, it brings all the prior presentations to life because it demonstrates sort of the contemporary approach using physiology and imaging, and also really focused on the medical therapy component. Any questions from the audience or from the panelists?
Thank you. Great presentation. What do you think is the best strategy in case of nodular calcium in the left circumflex ostium, especially in case of wear bias opposite to the nodule?
It depends, in my opinion, it depends on the severity of the lesion, because lithoplasty, lithotripsy is very useful, but the problem is to the crossability. So in this case, for example, we needed to pre-dilate with OPM and non-compliant balloons, and after that to pass the lithoplasty. Rotablation is an option if you have a good contact of the wire with the nodule, and I don't know if orbital atherectomy will be an option, because we don't have at this moment experience with this technique.
in the last PCR, nailing the osteo was not recommended in the session of Goran. Also, you participate. Do you think that there is still a role to do this technique, to nailing the ostium at the circumflex? And do you think that it's different, the ostium of the LAD and the circumflex for this technique?
I think in some selected patients, nailing the ostium can have a role. For example, when the circumflex, when the angle is perfect, the circumflex is not very big or very large. You need to implant at least 3.5 millimeter to make sure in the left main you are going to achieve a good apposition. If the left main is very big and the circumflex is not more than 2.75, and the angle is perfect, probably yes. With respect to the second question, there are few data comparing LAD and CERC, but it seems to be CERC has worse outcomes at follow-up. There is we have a study, floating stent in ostial LAD. In this study, the results were relatively good, but comparing CERC and LAD, there is a recent paper with a very small number of patients, no more than 47, and most of them treated with nailing the ostium, and the MACE, the target lesion revascularization at the CERC was higher than in LAD. So it seems to be CERC is the weak point of the bifurcation.
So thank you very much. We have to proceed with the next presentation. Thank you very much. We have still to do. The next one is 001 bifurcation lesions. Does image change our therapeutic strategy? Jose de la Torre Hernandez.
Hello, panel chairman. I have to answer this question. Does image change our therapeutic strategy? I hope in the next slides I could be able to do it. These are conflicts. This is 001. By the way, we are very close to the 20 years of the Medina classification. Next year is the 20 years of this, and this has been extremely helpful. There is no talk that this Medina classification is not mentioned in these meetings. No? This is less frequent. We have seen this, but to start, I will say that it's clearly debatable how well is indicated PCI in these cases. I think side branch, the 001 could be seen now like a wolf disguised of a woolly sheep, because we have seen that it's quite simple, or looks like a quite simple lesion, but the MACE rate is the highest compared to the others. Then I think that should be careful. First, it's indicated to do PCI in these cases. We know that very, very few side branches supply more than 10% of the myocardium. And then how important is the side branch, how symptomatic, medical therapy was optimized or not, is the cause of the symptoms, and finally the functional assessment. Then after this is properly answered, we can establish the indication. What about this lesion is very clear. It's an infrequent type, we know very well. Intravascular imaging assessment, I think, is very important to reclassify the anatomy, and we must not sacrifice or damage the vein vessel, which is the principle of these interventions. The value of imaging is to select the most appropriate strategy according to the anatomy and disease pattern, the size in the devices, and of course, to guide the procedure, evaluate the optimization, and eventually to change the strategy along the procedure because there is some plaque shift or dissection, whatever. We have different strategies, as Soledad has been shown in the previous slides. Stenting of the nailing the stent, just crossover the stent, or inverted provisional, and the use of DCBs also in different ways. We have two elements that are important for the strategy, which is the distribution of the plaque of the disease in the main vessel and the angulation. This is the angiography. The angiography of these lesions looks the same always, but it's a clear 001, but may correspond to different anatomies, may different disease patterns. All of them look the same because the positive remodeling makes not reveal the presence of the plaque. We have moderate plaque in the main vessel and the positive remodeling preserves the lumen. So angiographically looks the same, but the disease pattern is quite different. By intravascular imaging, we can identify this pattern and to find where is the plaque, if this is only in the ostium or this is extending to the main vessel in a more or less proportion. These are the bifurcations that are angulated. The angle is narrow, and we can have this distribution. And if imaging guided, maybe we can get this. The problem is that many times, and it's not infrequent, the stent, when we try to nail the ostium, is going to miss plaque in the ostium, or sometimes it's going to protrude a lot within the main vessel. This is a problem that we cannot identify properly only with angiography, and we need imaging just to identify these pitfalls. We have this ideal angulation for these strategies, but other angulations that are not so good. And in fact, we can also predict the combined length or missing protrusion just considering the size of the side branch and the angulation. In this case, we have the missing 1.7 millimeters, or we have the same length in protrusion. In this chart, in this publication, you can see the different combined missing and protrusion lengths according to the side branch size and the angulation. And this is over 1 millimeter once the angulation is over less than 60 degrees. If we guide the procedure by angiography in a case like this with some plaque extended to the main vessel, then we can have this problem. We can have some plaque shift and even dissection in the entry of the stent. If we do maybe a crossover stenting, but we do not cover properly proximally, we cannot select the proximal landing site, we can get finally this result. This is a good thing that we can get if we use imaging in these cases. For those cases that are perpendicular, things appear like simple, but it's not so simple. Angio-guided, maybe we have this, and we have more plaque that is shift to the main vessel, or we can have the same problem. The proximal landing site in the main vessel, when we are using the inverted provisional, is not adequate. And the best result is obtained when you have a proper selection of the length of the proximal landing site. And this is also a good result with a perpendicular angulation with imaging guidance. It's an example of a subtotal diagonal, typical 001, in this case a patient with a non-steal vision MI. We did IBUS, we always do imaging in the main vessel. You see the wire coming from the diagonal. There is not much disease distal to the carina, but there is some plaque proximal to the carina in the main vessel. And we can identify the best proximal landing. This is the different pictures from distal to proximal. And the plaque is mostly accumulated in the polygon of confluence or in the just proximal to the carina. Then the strategy in this case is clear. We have to go for a crossover stenting. This is what we did. Balloon to diagonal, DS in LED diagonal, pot 3 millimeters in the LED, balloon to LED, and something that is empirical, I like to do it, but this to apply a DC bead to the vessel, not very aggressive because it's not an stenotic vessel. I don't want to create any dissection. It's just to prevent any reaction in the innocent main vessel in this case. Then they apply DCBs in these cases, but I am not aggressive. Finally, we have the result. We have the intention of doing just without kissing. This is the result, not good. The stent is just like a half moon, you can see in the right. And then after kissing, the result is good in this case. This is very important sometimes even in provisional results, in only one single stent, but it's very clear. This is the final result of this case. We have another example of the classic 001 diagonal stenosis that was treated with the DES from LED, from diagonal to LED to 25, according to the distal landing site in the diagonal, then pot with 3 in LED, and rewiring, stress opening, and IBUS, in this case with score registration, and it's really clearly, we can identify suboptimal results that are not evident in angiography. In this case, we have a malapposition, a gross malapposition in the proximal, in the main vessel of the stent that was fixed with a larger balloon pot, and then we have a good apposition, as you can see in the still image down. This is another example of a case that have some particular features because there was a previous stent implanted in LAD by an operator that he tried to adjust to the ostium, but we do not know now if this circumflex that is really diseased in the ostium is jail or not. Then we have two questions to answer here. First, the wire is going just that way, which is correct because the stent is properly nailed to the osteum, or maybe we are just crossing the cells of the stent going to the cert. And the second question is if there is plaque or not extending to the left main. That's the reason why we did IBUS in this case. First from LAD, this is the all stent without significant stenosis, and you see the left main with some plaque. And now from the circumflex, when we see the distal normal reference, the TIC lesion here, and the wire coming from LAD, and having this range analyzed immediately, we have a clear idea that the stent is really adjusted to the osteum. Fortunately, the wire is not crossing the cells, and there is plaque in the left main. So the strategy in this case is crossover stenting from left main to circumflex. Is what we did. We're 3.5, pot with 4.5, and then stratus opening, and again the DCB to LAD. Is what I cannot give you any evidence, but they like to do that. And finally, the kissing, and we have a final IBUS with a very good result, which is a polygon confluence, when you see perfectly a huge lumen and the two stents now. Of course, these are IBUS cases, but OCT may provide more fancy images and more effective images when you are trying to evaluate, for example, the floating stents or the presence of struts over the main vessel. As an example of floating stent, and the operator crossing with a wire perform a mini culotte. That's to correct for this abnormality, to just illustrate and to show how OCT can be more illustrative in these cases. What about the evidence for use of imaging in this 001? We don't have any evidence. In the October trial, the dedicated trial for bifurcations, 001 was excluded specifically. There is no evidence coming from this trial. And I think, well, I was unable to find really important stuff, but I found this with this an IBUS study, it's a registry, and they, by propensity score, were able to make some analysis. They included 233 osteal lesions, 50-50 between ortho-osteal and other locations osteal lesions. And they found these positive hazard ratios for use of imaging, with reduction on MACE, TLR, MI, and very close to signification reduction on TLR. And these hazard ratios were equivalent for the half of lesions that were ortho-osteal and the other half that were other osteal lesions. So this is not a randomization, this is not a randomized trial, but some insects, they provide some positive news about the use of imaging. No? In summary, I think the Medina classification is based on angiographic, and this is valid, it's true, but intravascular imaging is helpful to redefine the pattern of the disease in these lesions. This is particularly relevant in 001 because the definition of the disease pattern may have important implications with regard to the optimal management approach, and also helps to optimize results and identify pitfalls that could decrease these really pretty high MACE rates that were presented, for example, over 13%, 14%. A clinician would say, why are you treating these lesions? You have more MACE than the problems that to leave the lesion behind with medical treatment could be associated. Then we have, as interventionalists, be very careful with this. So my answer to the question is that does image change our therapeutic strategy? It could be, I don't know if it changed for you, but it should. And I think that's the conclusion that I can give you. Thank you.
Well, that was a beautiful talk as well. I personally, as a visual person, I loved your diagrams because they really illustrated some of the challenges that we try to sort of figure out. And it also complements beautifully the prior talks. So thank you for that great presentation. Any questions from the audience or the panelists? We are kind of chewing a little bit into our lunchtime. And yeah, go ahead.
Just a quick one, fantastic talk. What do you think about stent design in terms of 2-connector, 3-connector for this type of lesion? Do you think it has a difference, and also the platform stent to artery ratio?
I think one of the issues concerning the treatment on osteal lesions, more ortho-osteal than these osteal lesions, but as well, is maybe, but we need platforms that have radial force. These lesions have recoil, and it's not uncommon to implant the stent. You see the full expansion of the balloon. You remove the balloon, then you do imaging, and you see the osteal with some expansion, small lumen. You post-dilate again. Even with larger balloon, the balloon is going up, You remove the balloon and the lumen is going down again. Then I think my favorite platform for these lesions should be one with more radial force. The problem is that the trendy thing is to have very, very thin struts, 60. Even maybe in the future we have 40. It's very nice to navigate, but it's not so good for ostial lesions. And the second is if we are going to do a crossover, a provisional, inverted provisional, we need, and there is a disproportion between the side branch and the main vessel, the platforms that are appropriate for overstretching and don't have the risks of shortening or just breaking. And when you do this from 2.5 maybe to 4, then you need to know very well what platform is more suitable for these overstretchings at the same time.
Regarding the type of intracoronary image, do you prefer the IBUS to the OCT or
I think both are useful. The only thing is that you need to know what is the plaque burden in the main vessel. That's true. Usually the disease in the main vessel in the true angiographic 001 is not very big because otherwise it's not a 001. You would say it's a 101 or whatever. But I think that both can be used. For the planning initially, maybe I prefer IBUS because I see the whole plaque burden, the whole vessel size. But for example, when the stent is implanted, OCT is better in order to show where are the struts and where's the malposition or whatever. Then every technique has different shortcomings and different advantages, but I think you can use both in these ostial lesions.
I have a technical question. If we put the stent main vessel to the left main to circumflex, then usually the stent malposition occurs in the POC area inevitably. Do you recommend the mandatory final kissing balloon dilatation?
Yeah, I think so. Yeah, we did in this case. I think you're right because the stent coming from the left main to the cert has some malposition just in the puck. Then you need to put sheet off the stent at that level and with the previous dilatation to the LAD in this case, and then final kissing is going to be mandatory to have a reasonable result. Yeah.
Okay. Thank you so much. Fabulous talk. Okay, so as they say, what stands between you and your lunch is my good friend Fernando Alfonso, who has been a leader in the field as well, and he's going to talk to us about 001 restenosis after 1 and 2 stents for bifurcations. Fernando, welcome.
Okay, so thank you very much for this kind invitation from the board, and especially to Manolo that I was on vacation, I received the invitation, I was very pleased. So basically it's quite easy. There is plenty of information, as you may see there, on the treatment of ISR, randomized clinical trials, consensus and clinical practice guidelines. And there is also plenty of information on how to treat bifurcation. And the work of this group is being of major value in this regard. However, unfortunately, in most trials, assessing the value of different strategies for ISR, bifurcations are systematically excluded. In the same terms, in patients with dealing with how to treat bifurcations, ISR are excluded. So there is very limited information on how to treat ISR after drug-eluting stent information. And if we just concentrate in the 001, well, virtually it's no data. And this is why I was not so happy when I was trying to prepare the talk. So that what I will do is just present a general overview of the information available, and hopefully this won't be too disappointed. So we know from the 2018 revascularization guidelines that both drug-coating balloons and drug-eluting stent may be used, and this is a 1A recommendation for patients with stent restenosis. And also, in those guidelines, we emphasize that intracoronary imaging was of value. We put together, this is a paper led by Andan Castrati. This meta-analysis is a patient-level meta-analysis with 10 randomized clinical trials with nearly 2,000 patients. And you see here how, when we compare drug-eluting stents with drug-coating balloon, there is a benefit regarding target lesion revascularization with the use of drug-eluting stents. But this is a major interaction here. So the benefit is when we use in patients with drug-eluting stent restenosis, but there is no clear benefit in patients with a more favorable setting of bare metal stent restenosis. Regarding safety, there is this signal, there is a concern of a worse outcome for patients treated with a stent. As you may see here, not significant, but again, the signal concentrates when first-generation drug-eluting stents were used, and there is no signal of any concern whatsoever when second-generation drug-eluting stents were used. Now, if you review all the current randomized clinical trials in stent restenosis, you may see in light blue that recently drug-coating balloons are selected for most of these trials. And when we review the evidence, I think it's important to emphasize that every time we face a patient with ISR, it's important to make a good diagnosis, to define the lesion. It is very important to prepare the lesion before a final strategy that can be drug-eluting stent or bare metal stent. So until now, we were saying, well, DCBs should be preferred when there is multiple metal layers, when there is resistant under expansion, when the initial result with pedalation is excellent, high bleeding risk patients, perhaps for many operators first in stent restenosis, and also, as mentioned, patients with bare metal in stent restenosis. But there is very weak evidence. I mean, there is quite a consensus that when the ISR is involved in a major or significant side branch, drug-coating balloons are better. Now, the problem is that in the new guidelines of chronic coronary syndrome, the presentation of the two strategies are very different, as you already know. So in these guidelines, it is said that in patients with in stent restenosis, this should be preferred over drug-coating balloon with a 1A recommendation. So perhaps we can discuss this at the end because it's quite controversial. Now, the other issue is that this group made this proposal suggesting that the Medina classification in the novel lesion can also be used nicely for patients with ISR. This is important. And this is an editorial we wrote some years ago with Manolo, very simply explaining why, the nailing technique, trying to catch the ostium of the side branch, can be virtually impossible. And sometimes, there is major protrusion of the stent in red to the main vessel. This problem is more complicated in patients with one stent in the main vessel, and is, too complicated perhaps when we got two stents because it's, metal everywhere, and perhaps we need to avoid this strategy. Now, the other side of the same story is what we know about bifurcation. I mean, you are experts here in the field. This is a meta-analysis we performed some years ago regarding DCBs for de novo lesions, and obviously in selected patients where the two strategies were considered of value, we found that the primary endpoint of this meta-analysis, TLR, was similar for DCBs as compared with other strategies, and this applies for patients that were included in bifurcation randomized clinical trials. So regarding other meta-analysis, this is a very nice meta-analysis by the group of Simon Ecclestad, putting together both randomized clinical trials but also observational studies. And you may see here that there are, very heterogeneous kind of treatment, but eventually the meta-analysis could demonstrate that DCBs were superior for POVA for the treatment of side branches. And this is the data coming from this meta-analysis. There is another meta-analysis, again, randomized clinical trials, but also observational data, and basically the same results. At angiographic follow-up, DCBs in the side branch are superior to POVA in the side branch. But we may know that. So regarding the question of ISR after the therapy of a bifurcation with a stent, this is a study, a classical study by the group of Antonio Colombo, and you may see here they compare drug-coating balloons versus second-generation drug-eluting stent for the treatment of restenosis lesions involving coronary bifurcation. As you may see in red, only a minority of these ISR were actually 001, and the conclusion of the study was basically that the two strategies, a stent strategy versus a DCB strategy, were similar, but in this paper it was emphasized that the initial stent strategy was associated with MACE. And this is another patient, again, related to the topic. This is angiographic clinical outcome of patients treated with DCBs for in stent restenosis, a coronary bifurcation stenting with two stent strategies. So in this paper, coming from the group of Robert Byrne, you may see how they perform a very detailed QC analysis of the branches. A follow-up, the side branch was showing the major impingement, the major involvement regarding minimal lumen diameter and percent diameter stenosis. And again here, a small number, but perhaps larger, up to 40%, were 001 bifurcation. This study compared two DCBs, and eventually the results suggest that the two DCBs were similar to address these challenging patients. But during follow-up, 1 out of 4 of these patients suffer recurrent in stent restenosis, and this was mainly involved the side branch, so emphasizing the importance of obtaining a nice result. Again, going to the guidelines, we recognize that OCT or IBUS is of major value. Every time we are facing a patient with stent failure, either stent thrombosis or ISR, and as mentioned by Chema, the October trial suggested that coronary imaging can be of major value in bifurcation, even though the 001 that we are dealing today were excluded from this trial. And we note also that this is a classical study suggesting that physiology is mandatory for this lesion, because when we face these patients, sometimes not only at initial presentation, but as you may see here, also at follow-up, when we do a follow-up angiography, and you see this narrowing in the ostial of the side branch, then the FFR in most cases is negative. So obviously we need to avoid that. And regarding the election of the DCB, well, this is data that we published quite recently. Limited studies, but 6 randomized clinical trials comparing DCBs with paclitaxel as compared with Limus DCB, at least the current generation of Limus DCBs. And it is very clear that late lumen loss and late lumen enlargement is much better when we use paclitaxel DCBs. So to summarize, I think it's important when we address ISR presenting with a Medina 001 pattern, that clinical indication is revised, symptoms, ischemic relevance of the territory. I think it's very important, and we sometimes forget to revise with care how the initial procedure was performed, the technical details, sometimes this is giving some clues. I think it's important to ensure that the side branch lesion is causing the symptoms of the patients, and if the side branch is not very small, I think imaging can be of major value. So my personal bias is that for these lesions, DCB with paclitaxel drug is the strategy of choice. I think it's important always to protect the main branch, and it's important to prepare the lesion and try to optimize the final results. So thank you very much.
Thank you very much for this great presentation. Just one question. It wasn't said today. What about bioresorbable scaffold? Of course, new generation. Might be this device could solve the problem of 1001. What is your opinion?
So BBS?
Yeah, but there's a new generation without this bias of past.
Well, we performed some studies in the Reeves saga with BBS in conventional ISR. Very good initial results, but when we compare our data, and we now presented this in JAC interventions, the 3-year follow-up of ISR treated with BBS, the absorbed one, with DCBs, paclitaxel, or everolimus eluting stent, there is a price to pay in the treatment of these patients that is more clear when the analysis you perform a landmark analysis after 1 year. So the same information we got for the general BBS also applies for patients when this device is used in stent restenosis, which is very appealing because you don't need another scaffold. Regarding the new scaffolds, I think we don't have any data, but again, this is very attractive.
Thank you very much. So we have still 1 minute for last burning question. If not, so...
Regarding the restenosis coming from one stent, 001, but with a previous stent at the main vessel, what do you prefer, to complete a two-stent procedure, T-tap or culotte, or apply DCB?
I would try to avoid using stents and as much as possible.
So now, just to conclude the very interesting session, Manuel Pan will show us some, let's say, directions of new investigations.
Thank you.
Do we need randomized trials or not?
Yes. Yes, definitively yes. Regarding this type of lesion, has been previously mentioned, we need a Medina reclassification, Medina physiology and Medina IBUS or OCT. Sometimes if you use physiology, you reclassify the lesion, as previously mentioned, from 001 to 000, so you don't need to treat it. This is the first approach. And then, has been also previously by Chema exposed brilliantly, that the use or IBUS or OCT again reclassify the type of Medina. So this finding is important in order to establish the therapeutic strategy. Regarding the treatment of the 001 Medina lesion, we have few evidence. That this is the sense of the EBC, to discuss problem of bifurcation lesion with few evidence and obtain a consensus or not. In this slide, you can see the different scenario. On the left, the 001 lesion with a small lesion, a small side branch, so it's easy to decide. It's a medical treatment. Again, if the side branch have a negative physiology, medical treatment. In the middle, the side branch is significant, close to the main vessel or a little bit smaller. And here you have different possible strategies. The use of DCB with a good preparation of the plaque, inverted provisional, or nailing the ostium, as Soledad mentioned, in the left main when the angle is favorable. When the side branch is equal to the main vessel, you can use the inverted provisional stenting and change the mother for the daughter. So treat the lesion as a 010. And finally, regarding the Medina 001 in the setting of a restenosis, if the restenosis comes from a simple approach, you can complete the complex approach with two stents, with T-tap or culotte, or as Fernando mentioned, use again the DCB. If the restenosis comes from a two-stent approach, you have to use image, correct deformation, and then dark coating balloon seems to be reasonable instead of a new layer of metal. So this is we have not evidence, we need a randomized study, and I think that these two studies may be proposed for members from the EBC. I think the most popular strategy are the inverted versus the use of DCB. This is maybe a randomized trial, and also at the level of the left main, the use of nailing versus crossover may be another proposal when the anatomy is favorable. Thank you for your attention. We need a photo of the meeting. Goran.
Yeah, dear friends, it's tradition to take group photo. We will do it now before the lunch, so please stay together. I don't know the place, but there is Ben, and he will take the photo. So let's make photo, and then we go for lunch.
siesta. I'll go for a siesta.
So you know the first presentation, Chairman Chen?
Yes. So
we go straight to...
I was at 4:30.
Ramsing Hall.
I have already the conclusions. Yes, so I will start the presentation, the presentation of the session, and then you will invite the different speakers. Okay. Okay. So in the interest of time, we will start this session. The session will be a little bit shortened due to the fact that the first speaker, Professor Chen, was not able to reach us. So with me as chair, I have Mila Kovacevic on the right and Tanver Rab, our friends, as chair with us. And then we have as panelists, we have Eun San-Shin, Carlo Brigori, Jean-Louis Gutierrez Chico, Dobrin Vasilev, and Christian Watson. So during this session, we have the possibility to hear and discuss a little bit more extensively the results of important trials that accumulated during the last 12 months. And so the first speaker will be Nils Holm. Okay, so Nils, come to the podium. He had other talk, all of you know him, unintended deformation of stents during bifurcation PCI, and October important trial sub-study.
Thank you very much, and thanks for the kind invitation to speak about this interesting topic. These are my disclosures. So when we do bifurcation PCI, we frequently intentionally deform our stents, but this talk is about when we do it unintentionally. There are several mechanisms, but two main mechanisms. One is the accidental abluminal rewiring, as in this case, where the wires are outside in a malapose stent. If you inflate a balloon now, you will crush the stent. The other main mechanism is guide catheter collision. You can see it here on the angiogram to the left. The guiding catheter is pushed forward and the stent is longitudinally compressed. And by OCT, it frequently looks, as you see to the right, where you have still a circular stent at the lumen wall, but also a pile of struts, several layers of struts suddenly found, typically in the more proximal part of the stent. Bifurcation PCI, in particular, left main bifurcation PCI, is particularly susceptible to guide catheter collision. As long as you still have a jailed wire and also a luminal wire, the guiding catheter will be attached to the stent edge. So every time you manipulate the guide catheter, you apply that force to a very small point on the stent edge. We also seen collisions with child catheters. This is a case we published a few years ago where a child catheter catched onto the stent in the middle of the stent, and we realized that it looked okay and didn't do any further, but 3 months later the patients were back in the cath lab and the stent was collapsed. So this small damage to the stent completely destroyed the radial properties of the stent in that area. We also see a combination of mechanisms here, longitudinal stent compression, and you could see the wires are outside the stent, and the stent has been crushed. So here you also just have a pile of struts at the end of the procedure, and you need to clean that up. They are even pooled in the ostium of the circ here, just to increase the onset for this patient. So there are multiple cases showing that this is a real problem, but there are very few registries pointing to this. I just want to highlight this particular registry from 10 years ago, already then showing that by IVUS assessment, 8% of left main cases had stent deformation as detected by IVUS. And in the core lab, it was only able to detect this by angiography in 18% of the cases, meaning that this is something you need intravascular imaging for. We have not seen these results published, but the Excel trial reported here at EBC 2017 by Gary Mintz that 6.6% of the left main stents were crushed in the ostium, and that was related to increased 2-year MACE in the trial. So we had good reasons to try to avoid unintended stent deformation in the October trial, so that was a focus point among all the other regular focus points with stent expansion and good lesion coverage and all that. We got a primary endpoint that was positive, a 30% risk reduction. And we also had a design that allowed for some mechanistic insight here later on that we mandated performing OCT after each rewiring. So we found that the two main mechanisms, as implied in the beginning, was abluminal rewiring and guide catheter collision was 44 and 40% of the cases. And we had 2 cases with a fractured wire when removing that wire caused a substantial distortion of the stent. And then we had some uncertain mechanisms, but most likely they were due to moving balloons and catheters back and forth inside stents. The biggest problem was in the left main setting, where 18% of the cases had unintended stent deformation at some point during the procedure. Looking for abluminal rewiring, we were a bit surprised to see that more than 5% of all cases had accidental abluminal rewiring. It was identified in a little more than half of the cases, but unfortunately left unidentified in 45% of cases, and then led to accidental crush of the stent. If we saw the relation to the clinical outcomes, we found that if unintended stent deformation were left untreated, well, that was clearly related to increased MACE. And in the cases where it was treated, so we corrected unintended stent deformation, we had no cases with MACE in that group. So now we have the 1A indications in the guidelines, and the left main stem and true bifurcations are highlighted, and we show with this trial and also many of the other trials that support the 1A indication that imaging guidance do improve clinical outcome. But I think we also showed with the October trial that there's still a lot of room for improvement, meaning we have not seen the full potential of intravascular imaging yet when we only discover half of the problems in these cases here. If you wish to see how we did it in the October trial, this is the October guiding protocol. It can be downloaded on the American Heart Journal page or via this QR code here. So in conclusion, unintended stent deformation was seen in 9% of cases in the October trial. Accidental abluminal rewiring and guide catheter collision were the two main mechanisms. Accidental abluminal rewiring occurs in little more than 5% of cases in contemporary bifurcation PCI. Unintended stent deformation was associated with higher MACE. If we corrected it, it offset the increased risk of MACE. Training may increase the clinical value of imaging guidance, looking forward to into the future with more use of intravascular imaging. Thank you very much.
So we have now time for questions. First one.
So,
okay, in the meantime.
So Niels, I mean, obviously people should be trained to pull back the guide before they move things around in the left main. So first of all, do you see deaths associated with this deformation in your MACE category? Secondly, in the OCT pullback, did you notice the guide just moving forward with the mechanized motion of the device?
For the latter question, no, because of course sometimes you need to push to hold the guiding catheter, but more frequently you will see that it actually pushes back out of because you flush and it moves backwards. The OCT catheter moves inside a sheet and should not draw the catheter inside. And to the first question, yes, the only procedural death we had in the OCT arm was a severe stent deformation in a left main case, a two-stent technique where certainly steps were not done in a correct way, and suddenly was a crushed stent in the left main, and the patient thrombosed and died during that procedure. And then there was all other cases that died during follow-up, yes.
How often did you use stent implantation to correct your problem?
I don't have those numbers. So it was dealt with in two ways. Some were just post-dilated again, but when it was quite excessive, another stent was implanted in most of those cases. So, but I don't have the numbers for you here.
I
Good
have
question. Thank you.
one question. Any impact of a stenting technique in two-stent approach, I mean, in the rate of abdominal recrossing?
So the most clear relation was the precision. So the more proximal in the left main, the worse the problem. So it was not really related to if it was a two-stent technique or single stent technique. So it was seen with all techniques. We couldn't see that it was much different. But the longer the procedure, the more you had to do, the higher the risk that we had this problem.
And you also mentioned that in 50% of cases, it was unnoticed that there was abdominal rewiring. And in this trial, there was experienced operator performing PCI. So we should search for this abdominal rewiring. So it's in 50% of cases to remain unnoticed is also like high percentage for such a trial, controlled trial.
Yes, so I think that's a very important finding because it highlights what we have discussed previously in this meeting, that training is extremely important. We should also notice that we had absolutely expert operators in the trial, but we also had some with limited experience with OCT. So we had a broader mix than has been communicated in some meetings. So we did have some that were on the learning curve. But even for experienced operators, this can be difficult sometimes to identify, and it requires that you systematically follow the wire out of the stent. With more training, it would be, all the operators, they received 2 to 3 hours of training on the initiation meeting, and it's a trial running quite long. That's very, very little. Of course, they got also the procedural feedback. But this is a technology that requires training to have the full potential of intravascular imaging.
We had also a series of stent distortion that we reported 10 years ago. Was not published because the distortion was based on stent enhancement, which was not accepted at that time as guidance. So just a few words to. I know that in the room you know how to avoid that, but I think it has to be repeated. When you do a crossover stenting, immediately after the deployment of the stent in the main distal vessel, you come with a bigger balloon and you do the pot. This is the things you have to do before doing anything else. Another important thing that we discovered at that time, you need supportive wire. Because if you use less supporting wire, and if you practice the exchange of wires, that your guiding will go out. And these two supportive wires help to keep the catheter away from the stent, inside the aorta, really, 1 or 2 centimeters. And of course, to make the exchange, Marie-Claude Maurice said us that we had to bring a third wire. You go with a small loop to cross the proximal part of the stent toward the LED. Then you pull with the shape, you enter the most distal cell. After that, with this also supportive wire, having the guiding inside the aorta, you will be able to free the gel wire. I think these things are simple, and I remember that after application of this, from 8% was even more than in Excel. 8% we found incidentally 1 or 2 a year.
But they were doing POT, right? They were doing POT by protocol.
Yeah, but all these
And
small
still-
details. Don't leave a guiding catheter close to the stent, because at least when you have the gel wire, after that you can manage to have the guiding inside the deploy stent. But with the gel wire, you push. It's typical. This is asymmetrical stent deformation. The proximal part of the stent has this shape. We recognize very well. And we see that very well also with stent enhancement.
Okay.
Thank you. Thank you very much. Next speaker, I think it's Gilles Montelescu, but the presentation is recorded, as I understood, yes. The title is Ticagrelor versus clopidogrel for complex PCI in chronic coronary syndrome.
Good morning. I am Gilles Montelescu. I'm professor of cardiology at PT Hospital, and thank you very much for this invitation to EBC. And the title of my presentation for today is Ticagrelor versus clopidogrel for complex PCI in chronic coronary syndromes. And clearly, we will be discussing this topic according to the Alphes trial, which was published in The Lancet, and we had a subset analysis in complex PCI cases. So first point I would like to make is that clearly we have an impact of myocardial injury and periprocedural MI on clinical outcome. There is a solid literature about it. It has an impact on long-term mortality and on cardiovascular events in general, as shown here in 2 studies. But we have a lot of studies showing exactly the same thing. So the study design is pretty simple. We recruited patients who were very stable for their coronary disease and were scheduled for PCI, and they were randomized for ticagrelor versus clopidogrel. They had a negative troponin at baseline, and they were followed up in the next few hours until hospital discharge for the troponin rise after stenting. And clearly we continued ticagrelor and clopidogrel for the next 30 days, and we have a follow-up at 30 days for these patients. The study was conducted in 2 countries and in almost 50 centers. The inclusion criteria were pretty simple. Elective PCI with at least one high-risk feature, and you have a list of these high-risk features. They were either patient-related or procedure-related. So it was a procedure with a certain degree of risk for the patient, clearly. We had an informed consent signed by all the patients, of course, and we did not enroll patients on oral anticoagulation, and of course, nobody was with an ongoing ACS at the time of this PCI. We had a small platelet function study showing that indeed ticagrelor was more rapidly active and more potent than clopidogrel, as shown here, in terms of VAS platelet reactivity. So this is something that we know, and this was confirmed in this study when we compared in a randomized fashion ticagrelor to clopidogrel. The primary outcome, again, periprocedural MI or myocardial injury, was not different between clopidogrel and ticagrelor, and we had no difference for MI, no difference for stent thrombosis, no difference for myocardial injury. This was clearly a neutral effect of ticagrelor versus clopidogrel. When we look at the Kaplan-Meier curves up to 30 days, of course, we get all the events early on, and it's pretty stable afterwards up to 30 days. So clearly very few events in this study. I mean hard events, death, stroke in particular, and clearly PCI was a safe procedure for this group of patients. But we had quite a number of periprocedural MI. The safety was good. At 48 hours, we had no difference in bleedings, no difference for major bleedings, but no difference for nuisance bleedings or minor bleedings between the two groups. But at 30 days, we had an excess of minor bleedings, which was significant in the group receiving ticagrelor. And that was expected, but it was confirmed here, more minor bleedings with ticagrelor than with clopidogrel. Again, dyspnea was more frequent with ticagrelor. Very interesting here, we published at the same time a meta-analysis of Alpheus with ticagrelor and Sassicaia, which is a similar study performed with prasugrel by Ginda mainly. And this study was much smaller and was stopped prematurely, but the data were available. And when we pulled all this data together with ticagrelor or prasugrel, the data were very consistent, and clearly there was no advantage whatsoever of these potent P2Y12 inhibitors compared to clopidogrel for elective PCI performed in stable coronary patients with a chronic coronary syndrome. So what we did also is to look at complex PCI in this group of patients on the basis of the procedure and on the basis of the angio. And as you know, this is quite well defined in the literature. So we took all these items to define the complexity of PCI, in addition to the high-risk features that we had to select the patients for Alpheus. So we have now complex PCI in high-risk patients undergoing scheduled PCI. And the primary objective and secondary objectives use exactly the same endpoints for these analyzers. And what you can see here is that we had roughly 50% of this population with complex PCI and 50% of patients with, let's say, non-complex PCI in Alpheus. But some patients had several criteria for complex PCI. 15% of patients had at least two criteria, and 10% of patients had 3 criteria. And we looked also at the subsets of patients to evaluate the same comparison for the highest risk patients in terms of complexity of PCI. So this is what we found for the primary endpoint. Again, periprocedural MI and myocardial injury. Of course, with complex PCI, and that was expected, we have more events than with non-complex PCI, roughly 45% of events with complex PCI and 25% with non-complex PCI. But importantly, there was absolutely no significant interaction between PCI complexity and antiplatelet therapy, the randomized groups, for the primary endpoint. So clearly, again, even for these complex cases, there was no advantage of ticagrelor over clopidogrel. We looked at a couple of secondary endpoints, and according to the number of complexity features that we had for this population, we defined 3 groups: low PCI complexity, only 1 item, intermediate, 2, and high PCI complexity with 3 or more of these factors. And again, whatever the level of PCI complexity, we couldn't find a benefit of ticagrelor over clopidogrel to prevent this troponin release after PCI. So clearly this is an important finding. I think the job is done by aspirin and clopidogrel, and we do not protect the patients better with aspirin and ticagrelor in this kind of elective PCI. Interestingly, we have recently the guidelines for these chronic coronary syndrome patients, and for PCI, they said that actually ticagrelor or prasugrel could be used with a 2B recommendation in complex cases with a C level of recommendation. This is very funny because we have 2 randomized studies, one published in Circulation, the other one published in The Lancet, absolutely not mentioned, and they conclude to the opposite of what we found in these 2 randomized studies. So in conclusion, from Alpheus, especially for these complex PCI cases. We have indeed higher rates of periprocedural and MI and ischemic events when these elective cases undergo complex PCI. There is a stepwise increase in the risk of periprocedural complications in case of combination of several criteria for PCI complexity, but there is no significant reduction of periprocedural MI and complications by ticagrelor in comparison to clopidogrel across different types and degrees of complexity. In stable coronary patients, outcomes may be related more to the complexity of the procedure itself than to the potency of platelet inhibition. And I think our studies and subset analysis, as well as the Sasikaya study, both go in the same direction to say the gold standard treatment for elective PCI, whatever the degree of complexity, is aspirin and clopidogrel. Thank you very much for your attention.
Is he connected? No. Okay. So it seems that Gilles was not able to connect timely. So anyway, I think that it is very, very interesting study to be commented, because we see that in the same period we have a study that is a confirmation for a previous study against, and the guidelines that give recommendation.
Yeah, but the endpoint was at 30 days, 48 hours after, like for primary endpoint. But we cannot estimate that giving the ticagrelor to the patient with chronic coronary syndrome will prevent MI during the procedure. It's usually technical related issue, like whether the patient is going within 48 hours. Usually when there is stent thrombosis, I think this is my fault, like as intervention cardiologist, not the fault of the medication therapy. Usually, this is my opinion. So maybe this primary endpoint, like 48 hours after giving this treatment, maybe can be discussed, like in the matter of like MI. But okay, regarding the MACE at 30 days, then we can talk about whether to switch the patient to do escalation from clopidogrel to ticagrelor if we have complex PCI patients, like if we have 2 stents in left main, whether to do guided escalation, like to perform multiplate test, and if the patient is non-responder for clopidogrel, to give the patient ticagrelor, for example. I don't know what is your opinion, but in regard of this, yeah.
So it's not uncommon to have an 80-year-old with calcified distal left main, 2-stent strategy. So it goes beyond that. And the other thing is they talk about 3 to 6 months. I'm very uncomfortable just saying 3 to 6 months of DAPT, rather give them a year of DAPT. I mean, and should these people be tested genetically or not? We don't have any clear-cut answers for that.
Yeah. Any other comment? So also, so it is true what you said, Mila, but anyway, the data also shows what you are saying, that the complexity by itself is strongly associated with increase of events. So once more, I mean, we are here to refine the techniques, since there is really a clinical need that is apparent across different trials, even in trials that are not designed on the technique. It happens that it is true that technical aspects may influence the outcome of the patients. And for me, this trial and the comments by Gilles document the fact that we have no parachute that can prevent us from having dreadful complications in the case we do not fix everything in the best way.
And do you think this might change a little bit with cangrelor? Because now in some patients with debatable indication for potent antiplatelet, now we have the chance probably to bridge these initial phases in case of complex PCI or acute coronary syndrome for 4 hours with cangrelor. And I mean, we have positive experience in this regard.
So, I mean, my perspective is the fact that the signal is not in favor. So we will see, but also the fact that in these trials they use drugs that have been associated with clearly laboratory assessment increased in platelet anti-aggregation that does not translate in benefit, seems not to, I mean, be a potent signal for other parachutes.
I think coming back to the complexity of the PCI, it's most likely because the complexity of the PCI is a proxy for older patients, higher bleeding risks, turn down of surgery, all of the above, and that kind of drives obviously higher risk for events in those patients that have lower risk. Correct.
Okay, so we go on.
So it's a pleasure to introduce Dr. Yang Su Zhang, who will talk about the OCCUPY study, which is the optical coherence tomography guided corneal intervention, PTS, with complex lesions, randomized trial. Dr. Zhang.
Do you have a recording or not?
We don't have any.
Is Dr. Zhang not here?
And you have no recording?
No record.
Okay. So we'll move on to Dr. Gori talking about randomized non-inferiority trial comparing reverse TAP versus DK, crush stenting for the treatment of complex left main bifurcation lesions. Dr. Gori? Thank you.
I'm here. So well, I have more time for discussion, right? Half an hour. So first of all, thank you very much for the invitation to be here. It's an honor, and especially for being invited to talk into a big trials session, whereby I honestly believe that my study is actually a product of laziness in the cath lab rather than a big trial. So this is the title that I kept because this is the title of the paper that is published. I actually the study is a comparison between DK crush, now become traditional. At that time, was not so traditional technique for the treatment of complex bifurcation lesions, and a simplified version that I then called reverse TAP, and that is actually some form of protrusion and flare technique, and then we can discuss about the nomenclature and the semantics. Now, of course, this is something that you're familiar with, the MADS technique, and what I want to discuss here or present here or state here is that all the lesions treated in this little trial were very complex. So they had at least two of the paradigms of complexity as defined in the DK crush trials. Very calcific lesions, some with thrombus, and definitely left main lesions. So at the time where I came up with the idea of doing something a little bit more simple for the treatment of complex bifurcation lesions, the 5 DK crush trials had been just published, so it is a while ago. And as I said, this study is a product of laziness in that I found at that time that the DK crush technique was a little bit complicated, hard to reproduce or spread into every single center that is equipped with interventional cardiology, and that this complexity could result into some troubles that Dr. Holm summarized under the rubric of deformation of the stent. So you will need 2 rewiring procedures. You will need a crush causing struts to be potentially floating into the lumen. And then you will need a kissing as compared to alternate PTCA of the 2 branches, thus limiting the possibility of expanding properly the 2 ostia of the vessels. So I came up with this idea of applying the concept of TM protrusion in a reverse way, and from that the name of the technique that I used at the beginning. And this is the technique that I compared in this randomized trial with the traditional DK crush. So the technique will be also a little bit complex, but involving only one rewire would involve placing first a stent with a very minor protrusion into the main branch. The first stent will be placed into the side branch. Then this stent will not be crushed by the sentinel balloon in the main branch, but rather alternate dilation will result into a flaring of the stent along the circumference of the side branch ostium. The following steps will be, and therefore this technique will not involve a first rewiring and crushing and kissing. The next steps will be very similar to the DK crush technique, therefore implantation of a main branch stent, pot, rewiring of the side branch for the only rewiring necessary in this technique, and then kissing and repot, and then final result. So this was an animation which I skipped. So this slide summarizes a little bit the differences between DK crush and what I call then reverse step, and we can discuss again about the semantics. DK crush would require at least a 2 millimeters protrusion, sometimes a little bit more, depending on the angle of the bifurcation. Reverse step will require no protrusion or very, very minimal protrusion. It will require only one rewiring, and then very, very aggressive alternate inflations of the main branch and side branch balloons in order to obtain dilatation of both the ostia. It would require no crushing, as I said, but flaring across the circumferential extent of the side branch ostium, and of course, as I said multiple times, just one rewiring as compared to two rewiring. So in order to compare formally the two techniques, I tried to run a randomized controlled trial comparing the DK crush with this reverse tap technique. I hypothesized that a non-inferiority trial would be the appropriate design, because the idea was that the reverse tap technique is an easier one, and therefore the advantage, and therefore the need of a non-inferiority trial in terms of endpoint as compared to a superiority trial. The primary endpoint, of course, in a randomized controlled trial, you have to choose one primary endpoint. And the most reasonable to me seemed to be the stent expansion at the level of the side branch ostium, which is also the position where we learned in the previous session most of the stenosis occur. So the study was, as I said, designed as a randomized controlled trial. It's one center. All lesions were Medina 011 or 111. The power was calculated, next slide, for 50 patients. Randomized 1 to one or the other, and of course the endpoint was measured immediately after procedure with OCT. There was of course a safety endpoint at 6 months. This is the power calculation. Power calculation was based on the DK Crush 1 trial. Essentially, said very shortly, I assumed that the reverse step method would result in at least 50% of the advantage of DK crush as compared to traditional crush, as shown in DK crush 1. This is the study flow. 208 lesions that could have been treated with this technique during the recruitment period landed with 50 patients, 25 per group for one or the other reason. This is a very busy slide presenting all the differences between the two groups. Essentially, there were no differences. It was a randomized design, except for two, which are very important. One is down. I can see it better if I see it here. Down here, we actually used more pressure during the final kissing balloon in the DK crush group. That should turn into an advantage for the DK crush technique. And the other difference, which was hypothesized to be so, is that the reverse tap technique was much faster than the DK crush technique, because it also involved only one rewiring as compared to two rewiring. In terms of procedural outcomes, safety outcomes, there was no difference. As we learned from the previous presentation, there was quite a few patients with troponin elevation. It was 13, so about 50% in each group, which is what Dr. Montalesco also showed, but no difference between the two groups. And this is the primary endpoint of the trial. The study was again powered for non-inferiority, which was met. And on post-hoc analysis, the reverse tap method showed actually superiority in terms of side branch stent expansion as compared to DK crush. Other than that, there was a very similar main branch opening data, and there was a similar malapposition in both groups. So this shows the 6 months OCT follow-up results summarized on the left side. There was less neointima proliferation in the reverse tap group, a larger opening area at the ostium of the side branch, and more malapose struts in the reverse tap as compared to the DK crush, without clinical implication, at least in the first year of follow-up. So, in conclusion, protrusion and flare. This is the changed name of the procedure of the technique strategy for the interventional treatment of complex left main bifurcation was non-inferior and actually superior to DK crush for the primary endpoint of the study, which was side branch expansion. It actually required less time, which is an advantage. It was also less complicated because it only required one rewiring, and at 6 months it had very similar results. Thank you very much.
Any questions?
You have half an hour for questions.
Thank you very much for the nice data. My question is about malaposition. In which side of the bifurcation, which level of the bifurcation was the malaposition observed in the reverse tap technique, and how do you explain that?
Yeah, I have no explanation because we only saw it at 6 months and not before, and it was at the carina. Yeah.
So was the carina covered in your initial index procedure by imaging? You did OCT in both branches, right?
Yeah.
And the carina was covered.
It was opposed. Yeah.
Opposed. So there's no gaps left, basically.
There were no gaps left. It's probably some form of positive remodeling potentially of the vessel. This is the data, but as I said, I have no real explanation.
I have just a question. We have learned from October trial that the unintended stent deformation by OCT occurred at least 5% of a complex bifurcation. Any case in your study?
Yeah, if I had known that there was this endpoint, I would have used it in the study. Actually, I found it a very instructive presentation. Yes, there were stent deformations, and I would say that they were more frequent in the DK crush group, but I cannot substantiate this statement. I'd rather not say anything about it.
Yes, and may I just, so it was an excellent presentation. My question is probably in the comment that the strategy is going to be determined according to the bifurcation angle, because this is the main point. If the angle is wider, then reverse tap is much more convenient, and vice versa. So if there is a narrow bifurcation angle, then the protrusion is going to be larger, then probably there can be crushed by the main stent, main vessel stent implantation, probably. Regarding to the side branch expansion, what we have learned also to do in DK crush technique, to do flaring also of the stent in side branch before we crush it. Then the expansion of this stent is going to be larger in comparison. Whether if we don't do flaring, for example, I wanted to say so the flaring is also involved in DK crush technique as well, like optimization of the side branch ostium.
Yeah, so absolutely agree with both comments. In terms of flaring, yes, it is very important. It wasn't in the guidelines to DK crush at that time, so therefore it wasn't done at that time. But absolutely, I totally agree with you that it's very important and it should be done now. In terms of the angle of the carina and the angle of the bifurcation, I can only say that I'm not a Taliban of this reverse step procedure, and I do DK crush, and I totally agree with you. If the angle is narrow, then DK crush is definitely my choice. Yes.
Yes.
Question there.
I really enjoyed that presentation. My first EBC 2006, I think, in Valencia, we multi-site study did something very similar from Australia. We called it shunt, and we modified T-stent. I moved away from it because it's a pseudoscience, and we try and mould that stent. But sometimes we would sort of undershunt, so the stent is a bit too far back, more than 2 to 3 millimetres. So DK crush was developed to allow and permit very high rates of final kissing. So if you do enough of these, or our shunt, your reverse flare, you do get a heterogeneous result and it can make it very hard to do the final kiss without doing the first kissing with DK crush. So it's just a comment, not a criticism. Yeah.
Yeah. No, I do agree with you. A fair comment. Yes.
Yes. I have a question, and I'm more favor the reverse tap technique because that is relatively simple to the DK crush. However, we need long-term clinical outcome data. So, do you have any plan to?
We will follow up on those patients. Yes. Okay. The problem is that it's a small study. It's definitely not powered for outcome data. The follow-up data or the clinical follow-up of the patient was only meant in terms of safety. Of course, if we would have had a signal towards stent thrombosis or wrist stenosis, that would have been important to report. Yeah.
Tommaso, we will have a short discussion about the discussion we have not done last year. So, from the beginning of EBC, and after that, Francesco, we are taking care to build the names by families, to avoid to have the same procedure with several names or the contrary. So, TAP is a provisional strategy.
Yeah.
That's a question. We are fighting with Antonio Colombo a long time ago about inverted or reverse. So we choose for a provisional, when you stand towards the side branch, we choose the inverted. So the reverse is available. So I accept reverse, and for TAP, I think we can find maybe something better.
Yeah, as I said, I've published it, and I can't change it now. It would be.
But
we can send a correction.
Maybe we'll exchange during the next week. All the assembly here.
No
propose
problem.
Something.
Let's make a poll.
This is very close to the modified T-stenting. That was what was the name of the Japanese with Antonio Colombo? Kobayashi. Yeah, Kobayashi. Was modified T-stenting. Was just before the crush. And looks like the only difference is the dilation. So you have to introduce that in modified T-stenting.
We have another question.
Yes,
there.
Dr.
Really half an hour.
Yes, still have some time here left over. Okay. Congratulations for the nice idea and the going on with this study. I have a couple of questions. Did you investigate the angle, that the bifurcation angle? Did it have an influence on the carina and the apposition? That's one of the questions, but maybe there's more patients and more procedures are needed to do so. And did you investigate the contrast media, the difference between DK crush and the contrast used versus the reverse step? But Professor Louva is absolutely right. Maybe it should be called inverted tap or something, but that's a very good idea. But it's very interesting. And one other thing that also the X-ray, was it different? So these are some procedural aspects of this procedure. And one other thing is that maybe should be at least maybe brought into the light, that maybe we should at least have also investigate this procedure against maybe DK culotte, because I think if you have OCT, the primary procedure, but I have a feeling that with the TAP, with the TAP, maybe is it fully covered, the side branch osteum, not the carina side, but the other side? I mean, I have a feeling that there might be some uncovered places regarding the bifurcation.
Yeah. So the two questions that are easy to answer are contrast medium and X-ray time. Yes, they're collected. They're presented in the busy table there. There is a trend towards less contrast and less X-ray in the, no offense taken, reverse step. Or no offense meant, reverse step, but it was not significant. Therefore, I didn't report it, and it was not to be reported. The other question was the angle. I didn't find an impact, or actually, I had not enough power to show an impact of different angles on different outcomes, because the study is so small, 25 patients per group, so I couldn't say it. The final angle after the implantation was tended to be higher in the reverse step group, so more towards 90 degrees. The inclusion was, one of the inclusions, of course, even just a subconscious inclusion criteria is that all lesions could be treated with both techniques, of course. Yeah. So, and in terms of comparing this technique with double kissing and culotte, of course, if somebody wants to do it, I'm very happy to participate.
Flared distenting. Flared distenting.
Okay. Flared distenting.
He loves names. So one more question. How are you sure 100% that your technique is different as compared to nano crash?
Yeah, that's
nano crash. It is reported. We had many reports, because at the end, I don't think that there is any possibility to be sure that there is some kind of crash.
Yeah, so at the time where I submitted to ethics, let's put it as a beginning time, but of course I had treated patients already outside of the study. There was no nano crash. It wasn't mentioned yet, so I was somewhat free to call it whatever I want. It is very similar. I totally agree. Yeah. If you see the paper, in the supplement, there is a comparison of this technique with other techniques, and the nano crash is very, very similar. Yes. What I don't like too much about nano crash is that if you see this technique, there is no crash, there is a flare.
No, but what a nano crash operator says is the fact that they are able not to crash due to the fact that they protrude not enough to reach with the 3 layers.
The other side.
So and when they perform imaging, they do not find any areas where there are 3 layers. That is the hallmark of crashing. The fact that you reach.
There is a difference with nano, is flared.
Yeah.
Last comment by Remo, because he was the one who characterized.
Yes, this is a nano crash. The nano crash is there was no name. It's a nano crash. The difference between the nano crash and your technique is that the nano crash uses a balloon inflated, or deflated. There are 2 techniques of nano crash. I used with the balloon inflated in the if you do a left main, I inflate the balloon in the left main LAD. This allows not to stabilize everything, because the stent, the ostium of the circ is dancing because there is the motion. But when you inflate the balloon in the left main LAD, then you pull your stent in the circ, you can position precisely. In addition, if you size this balloon to the LAD, to the distal main vessel, you can still inject and see, because there is some flow below the left main, because the balloon is sized to the distal main vessel. And this way, you have just a neocarina, which is 1 or 2 millimeter, which is crashed. And you crash directly doing the kissing immediately. So the crashing is doing with the kissing immediately. And in addition, you can explain why you have more side branch size. Because when you re-enter in the side branch, you re-enter through the stent through lumen. Through lumen. The stent has a true lumen, which is
Do not get too enthusiastic.
Yeah, no, but this is the secret. The true lumen is that lumen of the stent, the nominal lumen that you can expand the stent. So if I put a 3O stent in the circ, the 3O stent, depends on the brand, can be expanded to 5 millimeter, okay? But if I do a crash, I do not re-enter in the true lumen. I re-enter to the side branch. Is an opening, and this opening can never reach 5 millimeter. So there is a limitation, because with the crash, you re-enter in the side of the stent, not in the... And this is the reason why you have more apposition and better result using the nano crash compared with the decay crash.
Yeah, actually, yeah, I understand. I agree with it. I think that that one very, very important point, as you said as well, is the alternate dilatation with high pressure, which was not in the decay crash procedure at that time. Yeah.
You know, Patrick is right. We are completely crazy. You said that we are people crazy to spend a whole weekend on a bifurcation stenting. You're right, completely crazy.
Okay, we go on. Okay.
So the last speaker for this session is Antoinette Nelon. Only a part, the KISS trial. Is this in person or is this recording? Recording.
Dear Chairman, thank you for the opportunity to present at the EBC 2024 meeting. My name is Antoinette Nealon, and the title of my presentation is Only a Pot, the KISS trial. We must remember that it's only very recently that we've had some hard clinical data on the importance of performing a proximal optimization technique. And this data comes in 2021 when a bifurcation subgroup of the Ultimaster registry of over 4,000 patients showed us that the performing of a pot had a benefit for patients in terms of lowering target lesion failure. And this was very specific to performing a pot, because when they looked at kissing balloons as a substitute for pot, we didn't see this impact in target lesion failure, and there was no interaction effect for the use of both pot and kissing balloons. So it really comes back to the importance of performing the pot. In this other OCT study, we see a smaller number of bifurcations, and here they studied the impact of pot with side branch dilatation versus kissing balloon dilatation on strut apposition and the number of jail struts before the bifurcation branch. And inversely, in this study, we found that kissing balloon technique gave a better OCT appearance in terms of reducing malapposition and jailed struts. And what does the EBC tell us in terms of going one step further? Well, there's a very clear message that systematic proximal optimization technique should be performed, but after that, it's a little less clear, and it's left up very much to the operator without a lot of hard clinical evidence. So it was from this unanswered question that the KISS trial was born. KISS meaning Keep Bifurcation Stenting Simple. So when we think about side branch intervention, why might this benefit a patient? Well, maybe we have better rheology. We have less side branch occlusion, less peri-procedural injury, better relief of anginal symptoms, and less restenosis. But inversely, if we don't perform side branch intervention, we're going to have shorter procedural times and less X-ray exposure, and maybe less risk of side branch dissection, therefore less need for second stenting, and maybe this has an impact in terms of the risk of restenosis later on. So the design of the study was all de novo non-left main bifurcations, except 001 Medina, with the side branch that the operator felt was large enough to accommodate a coronary stent. Main branch stenting was performed using the Resolute Onyx stent with a systematic POT. After this, the operator evaluated the side branch, and in the case of no flow reduction or any signs of ischemia, the patient was then randomized to no side branch intervention or side branch intervention. And this side branch intervention was at the discretion of the operator in terms of kissing balloons or a pot-side pot technique. So the study primary endpoint was the rate of periprocedural MI, and this is using the ARC2 definition, using a troponin, an isolated troponin that was more than 70 times the upper limit of normal, or more than 35 times the upper limit of normal, with additional criteria for myocardial loss. And based on the power calculation, a sample size of 596 patients was going to be required. Secondary endpoints are technical success, acute gain as measured by QCA, procedural time, and X-ray exposure. And the clinical endpoints measured at 1 and 12 months are target lesion failure and its components, definite probable stent thrombosis, and angina status. So this then left us with an intention to treat analysis of 304 versus 313 patients and very small, low levels of crossover. So what are the main results? So this is a pretty typical profile of patients with mostly male and a mean age of 67, 68 years. Majority of patients presented with a chronic coronary syndrome, and ejection fraction was preserved for both. No significant differences in terms of diabetes, with slightly more MIs in the control rather than the no side branch intervention group. So the majority of cases were performed using radial access. In about 20% of cases, there was a non-target PCI performed before the bifurcation intervention. Most of these were LAD first diagonal bifurcations which were treated with a proximal main diameter of around 3 millimeters, which was the same for both groups, and side branch diameter of about 2 millimeters for both groups. Lesion lengths in the side branch was short for both of these groups at about 4.4, 4.8 millimeters, and we have a very high level of POT at over 99%. Kissing balloons were performed in about 40%, with most cases in the side branch intervention arm having a pot-side pot technique performed. And again, we see that there was significantly more side branch stenting performed in the control group, with about 4.5% versus the no side branch intervention. So in terms of the primary endpoint, that is periprocedural MI, what are the results? There is no difference in either the intention to treat, the per protocol, or as treated population in terms of periprocedural myocardial injury for either strategy. However, in the no side branch intervention group, we have a reduction in procedure time, we have less contrast media volume, we have less X-ray exposure, and less requirement for a second stent in the side branch. And this shows no interaction with lesion location, Medina class, side branch size, or side branch stenosis, as measured by QCA before the intervention. So, clinical endpoints. Are there any differences in terms of target lesion failure, target lesion MI, or stent thrombosis? Well, no, we don't see that coming through at 30 days or at 1 year. That no side branch intervention performs equally as well in terms of the clinical endpoints of target lesion failure and its components. And if we look at the subgroups of kissing balloons versus pot side pot, we see that again there is really no difference in terms of either of these techniques for clinical outcomes in the control group. So what has all of this told us? Well, we can see that provisional stenting in routine non-left main bifurcation using the Resolute Onyx stent is associated with good short-term and mid-term outcomes, with target lesion failure for complex bifurcation lesions at around 5 to 6%. That a no-touch strategy is non-inferior at 30 days to systematic side branch intervention, and this is a safe and effective strategy out to 1 year. And this relates just to non-left main bifurcations, so we don't have any information on whether this can be extrapolated to left main bifurcation stenting. So looking at this study as one of the participating centres, has this changed my practice? And I would say that yes, this has changed my practice. Whereas with the results out to 1 year showing no difference in terms of angina status or target lesion failure, that I am less inclined to kiss or perform any side branch intervention. This completely underscores the importance of the pot. And perhaps in the future, it would be interesting to see whether this is something that can also be extended to left main stenting, as while it has changed my practice for non-left main stenting, it certainly has not impacted my practice in any way for left main stenting. Thank you very much.
So, very interesting study, but I think, if I have understood correctly, you compare simply pot versus an intervention in the side branch, and 47% of the cases, that intervention was simply side branch dilatation without kissing. I think this is not the standard of care, right? So it's not a fair comparison.
This is pot followed or not?
Yeah.
By kiss.
No, but
No, in the case of side branch, the protocol, I mean, we have been involved in the trial. So in the case there was a randomization to standard of care, the operator was free of selecting either kissing or pot side pot. This was mandatory. So in the side branch intervention, this is the way. So when you see a side branch, there is also followed by repot. So it's incorrect in that. Anyway,
now it's clear.
40% of cases, yeah.
But,
yes,
excuse me, the criteria for randomization, I mean, you do stenting, you did in the main vessel, and then if the side branch was okay, you randomize. But what does it mean, okay? What does it mean, okay?
Mean okay,
no stenosis,
in terms of T-metry flow, and not tight lesion on the basis of angiography.
By visual estimation?
Visual estimation.
Francesco,
but any
pot
data
was mandatory and randomization after pot.
Yes. Okay. Like that. Yes, so it was pot. So it was crossover stenting, POT. Then, if the operator, and this was outside the study, so if there was T-metry flow and no tight stenosis into the side branch, it was no treatment, so procedure finished, or systematic treatment, so systematic treatment in absence of, let's say, guidelines forcing doing, but it is the concept of showing if it is deserved or not to systematically do things.
Yeah, just another question. You decide to randomize at the beginning?
No,
after stenting?
After crossover and POT. Crossover stenting and POT.
So you have a lot of bias.
No, it is not a lot of bias. We should know
very
when.
Selective.
So I think that the correct way of incorporating trials in our practice, probably this is why we are talking here. is to understand which is the flow that generated the data. So this is not a study that is against side branch intervention systematically. It is against side branch intervention in the absence of many things in, honestly, what I was quite surprised to see, side branches that are 2 millimeters. Yeah. This is probably the most important thing, because side branches were 2 millimeters with good flow, pot performed. So in this condition, I think that was promoted in the EBC several times not to do in this condition anything. Now we have a trial supporting it, because in the world there was many people that was probably doing differently.
But just to clarify, the non-side lesion, you could have pinching of the side branch, and that would still NTME3 flow.
As I
correct?
understood, sorry, Francesco, to answer instead of you. As I understood, the mean side branch, like a lesion, it was 30%, and the length was about 4 millimeters. So it's non-complex, non-complex, non-true bifurcation lesion. So it's a limit selected population. 30% of side branch stenosis, 2 millimeters of the side branch, and the length of the lesion was 4 millimeters. So it's like, as you said, pinch of the side branch, like selected population of the...
I was not okay with my associate Bernard Chevalier, and maybe not with but okay, they did the trial. My problem is the same as yours. 2 millimeters, normally they are not included in bifurcation trials since, after Nordic and a long time ago. But okay, we can say, okay, because if they have selected something with 2.5 non-left main, we will have seen a difference. But unfortunately, this is also done for left main. This is popular in Korea. They do a crossover stenting, they do a pot, and they leave the strut in front of the circumflex. They do that since a long time. And they consider this is safe. Maybe we can have some intervention of the, Jean-Luc.
But, and in answering to these provocative questions, please remember us about how you check fenestrated restenosis outcome that is usually taking years to come out.
Actually, we don't have a randomized clinical trial, it's just the observational registry data. But as you mentioned, that in Korea, we just a simple crossover. And nowadays, Goran mentioned that part is very important to make a better expansion of main vessel proximal part. That's a very important part to prevent the event. So it was very popular. And then now we do the randomized clinical trial across Cordis. Last year I mentioned that. So we do this study showed that the kissing did not make better clinical outcome. So we focus on the simple crossover and part. Then side branch visual stenosis is more than 50%. In those cases, we randomize, just leave alone or kiss. So I'm not sure what the result, but we are ongoing trial.
Yes, and in the case of kiss, do you re-POT after or not, according to the protocol?
Pre-part is mandatory, but
so it is left to the operator.
After kissing, the re-part is optional.
Okay. So I think that we can, thank you. I think that we conclude here the session. There were honestly important missings that we should ascertain how happened. Anyway, I think that we had the possibility to discuss important topics. Altogether, they are the pitfalls. We have mechanical pitfalls that we now know that impact outcome. We discovered that there are no drugs, antiplatelet drugs, that can, let's say, forgive us in the case we do. And at the end, we have a new technique that deserve name and deserve, let's say, discussion about the different people that publish similar things in order to find the agreement. I remember the history of TAP. It was simultaneously practiced in Rome and in Korea. So we, with Dr. Guon, decided to come out with a combined combination. So this is also something that is in the spirit of EBC, to find names together. And last thing is the fact that in the case it's minor side branch, for people that was deserving it, there is no need to do anything in the case the patient is okay and there is good flow. Thank you.
Dear Chairman, thank you for the opportunity to
Yeah, I think we can continue with the Medtronic Symposium. The name is Innovations in Bifurcation Treatment, and it's a really pleasure to be here with Dave, Marek, and Francesco. I did not like that sign to reduce the rate of kissing, but Francesco may help us come back with some data from in vitro testing. So we will discuss how in vitro testing in Visible Heart Lab in Minneapolis actually has significant impact on our practice and transforms the pitfalls that we learn in the visible heart in the proper way to perform technical steps. And Francesco is really a leader among EBC members connecting EBC with Visible Heart Lab. So, Francesco, pot, side pot, pot, kiss, pot.
Honestly, I do not know if, I mean, you are too kind with me. Anyway, what is very important, I think that we discovered it once more during the previous session. It is important to have in mind the concept that bifurcation intervention and stenting is a situation where we start with something and it can become unpredictable if we do not follow the, let's say, the steps. So stepwise provisional is very adaptable technique that allows to implant in the case of need. Second stent, for sure, it allows to treat the side branch in different ways. And among the different ways, what has been discovered that pot and kiss, something that still is practiced in trials, like we discovered now, is associated with different amount of deformation in the main vessel proximal that is completely unpredictable because it is related with how the two balloons for kissing are overlapping into the proximal main vessel. So for this, there is the invention of a simplifying methodology that is pot side pot, that is, according to bench tests, very able to allow the proximal part to maintain circularity and while having expansion of the side branch. So it seems really very easy and effective in the bench test. Then we have the possibility to restore the distortion that is induced by KISS by performing RPOT. And we know that with last generation drug-eluting stent, it is very suitable to have this transformation that make the stent probably very close to bifurcation dedicated devices. So on top of this, what happens is the fact that, according to the suggestions by the EBC, pot kiss post and pot side pot are the two best provisional sequences in the case of side branch treatment need. So this is actually the status. So the Krabbis trial was probably my dream. The condition where instead of having bench tests, we start with a new way of performing tests before having clinical phases. And this was done with the aim of to compare the stent configuration obtained by PCI practice using different side branch optimization technique after main vessel stent implantation in large bifurcation. So we are dealing with large bifurcation where the distortion might be large. And the two sequences are the best one, post-kissing pot and pot-side pot according to bench test that we tested. Why was my dream? Because instead of having bench test and then clinical practice, there was the opportunity to have a preclinical phase into the visible art laboratory before embarking into a clinical phase in my hospital. So the preclinical phase has been performed by practicing operators on radioscopic guidance, the technique into the visible art lab, and thereafter, after this confirmation of the safety, there was the possibility to come with the clinical phase. I think that it is really the way to go in the future for technical refinements. So the flow chart was this, I remember, this is provisional stenting, the stent crossover, sorry, this is, I think it is the battery has gone. So crossover stenting size according to the distality. Then, can you give me something working now? So are you going for me? Okay. So after crossover stenting, POT has been done with meticulous attention to reach also the proximal part of the stent and the carina, and then the patients were the bifurcations were randomized to either pot kiss pot or pot side pot. Are you? This is a similar activity. Okay, that's good. So thereafter, we know how important it is for provisional flow to perform distal rewiring, and it was done with the beating hearts at the best of the capacity of the operators. Then kissing balloon or the side branch with small protrusion inside the main vessel and small overlap in the case of kissing, and the re-POT to correct in both. So in the case of the preclinical phase, multimodality was performed, including angioscopy, OCT, and micro-CT, together with angiography that guided the procedure. In the case of clinical phase, only OCT was performed. So these are the preclinical study endpoints. We selected as primary endpoint the minimal stent expansion at the distal main vessel. Why? Because we know that in the case we dilate the side branch, we will create a carina shift into the distal main vessel, so that in the case re-POT balloon will not reach that area, we will have a penalization for pot side pot. And then secondary endpoints were, all the other aspects, including the eccentricity, so the circularity measured into the proximal main vessel. The stent that we selected was the Onyx stent, that is very suitable and very well tested in the bench test as adaptative to the provisional stenting. And the final results have been presented last year. So I recap for you. What was incredible was to see that into the visible art, the procedures were performed exactly in vessels that resemble the left main, large bifurcation, 4.2 millimeters into the proximal main vessel, 3.5 in the distal main vessel, and 2.6 to 7 into the side branch. And the devices followed this, so all the balloons and stents were exactly like expected in human left main interventions and large bifurcation. And regarding the results, I can share with you what happened with these two modalities in representative examples. You have on top the line POC spot as evaluated by angioscopy, OCT, and micro-CT, showing you the result. And with pot side pot, what is evident that at the carina, it is possible that you are not able to perfectly correct the distortion that induced at that level with the side branch dilation. And regarding the proximal main, the polygonal confluence and the proximal main vessel, what is apparent here is the fact that you had two main important aspects. The first one is the fact that with kissing you have this longer protrusion that can be seen by both micro-CT and OCT toward the main vessel. However, you have a circularity that is more preserved with the pot side pot. So, and this is also confirmed by the measurements performed by the two modalities, showing that in the distal main vessel there is a significant improvement with pot kiss pot. So overall, this first part was the first prospective randomized trial inside this unique preclinical environment. Bifurcation PCI conducted with PSP and PKP achieves different stent configurations that are acceptable anyway. PSP has better preservation of the circularity in the proximal main vessel, but PKP has better expansion and position of the level of distal main vessel, as well as better side branch scaffoldings. So on top of this, we embarked in the second part of the study, that is the Cordis clinical trial. It is monocentric, no profit, and randomized and no sponsored, honestly, because Medtronic did not support it, honestly. So, but we really wanted to go on with this project, so it is recorded in clinical trial. And we planned to enroll 60 large bifurcation, very large bifurcation, treated by provisional. And the patients were randomized, 30 and 30, and the clinical exclusion criteria were mainly the one of elective trials in the field. And regarding the endpoint, on the basis of the results of the visible art, we designed a superiority trial having the minimum stent expansion at the distal main vessel as evaluated by OCT for the trial. So the current status, unfortunately, I failed to give you the final result here, because we are actually enrolling 58 out of 60 patients, and all of them are mainly unprotected left main lesions, mainly treated by the Onyx drug-eluting stent, because when you see these images, you want to use the stent that performed so well in the visible art. And I want just, however, to share an example of what we are learning from a trial like that. So this is a case that enrolled in the trial. The patient has been randomized to pot side pot, and the operator did his best job to have this result. It can be acceptable, but I mean, we know that it is important to perform OCT and imaging, so the result was like that. We can accept as a good opening of the side branch. However, you see that in this area, you have some indentation into the distal main vessel that probably can also be recognized here into the image by angiography. So, and the other aspect is the fact that here there is no scaffolding like I showed at the end of visible art lab interventions. And MSA is 5.0 with expansion of 75% for distal LAD. So the operator decided to perform pot key spot to try to enhance the result. This is angiography, and this is the aspect, so the side branch is basically the same. However, what we see here is a different conformation with the stent struts producing much more toward the side branch, and here at the level of the distal main vessel we increased, reaching an expansion that is really optimal. So to me this is a very provocative case, and for sure it supports the concept that in the case we need to implant a second stent, this condition is much better because allow you to have no much protrusion inside the main vessel. Thank you for your attention.
Thank you, Francesco. Francesco, if you cross distally in both groups, how do you explain longer protrusion with kissing compared to balloon inflation towards the circ?
So I don't think it is a longer protrusion, honestly. If you come back to the case, there is basically the length of the protrusion is unpredictable because it depends on how the last ring that can be crossed is over there. The problem is that when you perform the side branch dilation with large balloons, we know that we have the possibility to have two kinds of distortion. One is the fact that we stress the other part of the vessel, so malapposition on the other part of the vessel, and this is corrected by the balloon that we add for RPOT. But there is also the possibility that the carina shifts the soft carina but also the stent struts, and the stent struts will be corrected in the position only by kissing or by the nose of the balloon for POT. But this looks a little bit unpredictable. So there are some cases. The last one I did on Wednesday, in which pot resulted in perfect result because I was probably able to reach with the nose cone, the nose, the carina. But I mean, in a beating heart, sometimes you fail.
Dr. Shaban?
It could be, corrected this or prevented the deformation of distal part of the stent by using underside balloon for side branch?
Probably yes. This is why we think that the use of aggressive technique, let's say aggressive things like kissing and POT repeated should be applied and considered as a value only in big bifurcations. I mean, they are considered to have really optimal results in big bifurcations.
Yeah, actually, that could be a good reason to use large balloon in distal left main. But left main bifurcation, I think, using a smaller balloon can avoid the deformation of the stent.
Yes, I'm quite sure that this is the case. And also shorter balloon, there are Japanese data showing that even a shorter balloon, at least in bench tests, are able to be effective. But for example, 8 millimeters balloon, are we able to be precise in putting there all the time in ostia that sometimes are not visualized perfectly?
One short question and then we have to proceed.
Just a short question and remark. I think the fascinating pictures, Francesco, you showed for the preclinical phase. And for me, I think it's going to be a very important study to show the differences between pot side pot and pot key spot that we probably tend to believe in more. Now, from the preclinical phase, we know that for long term, the side branch osteum might be going to tend to have some restenosis or some failure in the long term. And you showed that that's probably the most important, that for pot key spot, you have a better coverage of the whole bifurcation, and that's what's probably going to come more important than the proximal vessel, that pot side pot you do, because you can correct that with the repeat pot. Am I correct?
Yes, I mean, I want to stick to what we are telling. So this is a mechanistic study trying to evaluate which is the best acute results we may achieve with the technique of provisional. And this is convincing. I can tell you that it is what we also discovered is the fact that bench tests have carinas that are not able to be directed and shifted. So in the human, as like into the visible art, what we have is carinas that can be displaced. And when we displace the carina with metallic parts over, this translates in a deformation that needs to be corrected, that is probably more important than the one that we thought in the past, that was the malapposition induced on the other side of the main vessel. Yeah. This is my take-home message.
Thank you, Francesco. We look forward to see final results, and I would like to invite Dave. Thank you, Frank. Journey about DCB. I think we painted the whole meeting with DCB. So
we have, absolutely. Right, so I'm just waiting for my slides to arrive. Nothing's happening. It's not under my control.
You can start the journey before slides.
I'm ready. Hooray, hooray. Right, drug-coated balloons. My journey with these. Okay, so stents. They're really great when you need them. But, as many of you will have heard repeatedly during this meeting, people have developed nagging doubts about stents and when we should use them. I won't go back right through the evolution of when we started to use them, but they were a bailout technology which has then become a completely mainstream technology. So what was our experience? Okay, well, we would still see acute on chronic or acute stent occlusions happening, maybe a year, maybe 10 years after stents were implanted. It wasn't a thing that had gone away. And some of those were really bad, really difficult to deal with. The data that accumulated suggested that there was a 1 or 2% year-on-year MACE rate related to these stents. So intuitively, you couldn't really think, okay, this is a benign thing we're doing. No, if you place a foreign body inside the coronary artery that's going to be a permanent fixture there, that's not a benign thing to do. There must be some downside to it. And on a practical front, it's really difficult sometimes to balance the difficulties of, well, yes, this patient is now bleeding, but they only had a stent put in the proximal LAD 2 months ago. Okay, how are we going to balance those risks? So for very many reasons, I think I just went an overnight complete volte-face, a Damascene conversion. Essentially, my mental approach, it changed from I'm going to place a stent. How long is it going to be? How big is it going to be? How many am I going to place? To I won't place a stent unless I need to. And this was one of the cases that convinced me that this was important. This was a man who 10 years previously, when he was aged 37, came with some angina and had treatment to a 70% distal right. Okay, maybe it was the cause, I don't know. I wasn't there. And the operator didn't do a very good job. They put one stent in and missed it slightly, as people do. And so they put a second stent in. And then it looked quite nice, and they thought they'd done a great job. 10 years later, he came back with an acute coronary syndrome, and this is how it looked. And I was in the other lab, and there was a senior fellow doing this, and he called me, and I said, yes, okay, fine, so, wire it, pre-dilate, you might have to work quite hard looking at it, imaging, and then we're going to end up doing drug-coated balloons to this thing, okay? And he started off, and he's a pretty good operator, and it was clear that this was actually quite nasty. It was a bit like granite inside this stent. And he had to use a corset and was winding it through. And once he'd done that, it was hard to inflate. And he had to use, I can't remember exactly, but cutting and then non-compliant balloons. You could see the guideliners right down by the start of these stents. And in the end, he did, the best he could and put in a massive stent. Now, that's fine, and the guy's got a great result for now. But age 47, he now has 3 layers of metal. It's rigidified his entire right coronary artery. I mean, this is a tragic artery now for him for the rest of his life. That is like a sort of metal explosion down there, and you just know that granite, that inflammatory process is just going to carry on, and he's going to be back, and it's going to be really difficult to treat. So that was one of many cases that made me think, it's just not right. We're just bunging in stents and make it, it looks pretty now, but what's it going to be like in a few years' time? So I started doing cases with drug-coated balloons and thought, okay, am I sure? And it was really helpful that there was a clinical trial going on to be participated in. And so this was the kind of thing we started with. Somebody's getting angina. What would I have done before? I'd have probably placed a stent from the proximal LAD to about 3 miles down the LAD there. And then I might have just ignored the diagonal because it was a bit awkward because it's behind all the stent. Or I might have done a kiss. I don't know. But anyway, I didn't do any of that. I just did a little bit of dilatation and drug-coated balloon, and it didn't look too bad. I could sort of see a faint dissection in there, which was encouraging. And then same on the diagonal. It doesn't look beautiful, but it was actually clinically perfect. No stent, thank you very much, no angina, no problem, no antiplatelet issue, no problems with long-term difficulties with stent to your proximal LAD. So, I'm going to get rid of these last slides because we're a little bit short of time, but suffice to say I started doing it everywhere, and I'm very happy with it because actually the results have been really good. So this was actually I'll tell you now, this was a STEMI, and I thought, well, this is a great place to do this. Aspirate the clot, give some strong antiplatelet agents, because we always get the size wrong in STEMI, and we know we do, but we still stent them, and that was at the time, and then this was 3 months later. So, the vessel's quietly got bigger all of its own and isn't impeded by having a metal structure of the wrong size in the middle of it. So, in my early days, I've learned 3 things from this, and I will be telling you to suck eggs here, but 1, dilate the vessel properly, 1-to-1. Patrick, in fact, wrote a lovely editorial in CRM, I think it was, basically reminding us that angioplasty is dissection. That's how it works. It's not footprints in the snow. If you haven't dissected it, you haven't done it. You haven't done anything. You've just sort of annoyed it slightly. You've got to dissect it to actually make a difference, to open up the blood vessel and get a result. So I learned that, and I learned TIMI3 flow is really important. If you have TIMI3 flow, then you can be forgiven a great deal of other sins. It doesn't matter if it's ugly, so long as you have TIMI3 flow and you don't have either a spiral or propagating dissection or an occlusive dissection or some version of dye staining in and around the artery. And thirdly, the balloon is not for dilatation, it's simply for application. It's just to apply the drug. Don't use it as a dilatation instrument. And I would say to anybody who's thinking about it, try it. You might like it. Thank you.
Yeah, great talk as always, very inspiring. Francesco, you have a question.
You are a talker that is so nice that I cannot accept that you are so nice, and I will give you a bad question. So, since I remember why my teacher told me, my master told me that we are using the stents, that is because they had all the night to have the fear to be
call because there was acute occlusion of a ballooned vessel with a plain balloon, because at that time there was a risk of acute occlusion due to the evolution of dissections that were classified at that time exactly like we do now, and were accepted where now it is proposed to accept for drug-eluting balloon. So why you as operator think that there should be no risk of acute occlusion of these dissections we leave?
Yes,
with drug-eluting
it's a very
balloon?
good question. I think it's not that there's no risk. Of course, there can be a risk, but actually, for some reason, the risk is much lower. And other people will be better to answer this than me. What I think, personally, is that what people had before stents was they had no bailout option other than surgery. So they were actually relatively timid with their angioplasty. And it was that very timidity which got them in trouble, because all they'd done is abraded the lesion without dilating it. So, you know, I worked for somebody who did a 2 millimeter balloon at 2 atmospheres, 4 atmospheres, 6 atmospheres, you know, incredibly timid angioplasty. And there were problems. And actually, it's only when you've done a proper dissection of the vessel that you will actually get, okay, now we've got good flow, now we're much less likely to have occlusion. I think the antiplatelet agents that we have now that are much better as well, and others will be able to answer why. All I can say is that my personal experience as well, which is helpful, has actually been really reassuring. You know, I've had one case come back in a year, and that was because I did too much really in a STEMI case, but only one, you know, out of all the cases I've done. So I'm really reassured.
Dave, wonderful topic, lecture. What is your approach to achieve controlled dissection? You need dissection.
Yeah, absolutely. So I mean, it's one-to-one ballooning, it's liberal use of cutting balloons, scoring balloons, whatever. Actually make sure you can see a visible dissection and then think, okay, now maybe I've actually dilated this properly.
Yeah, I mean, first we have to remember that when we did balloon angioplasty 79, 80, 81 and so, there was only aspirin on board, nothing else. So that's the big change. And don't forget the diclopidine who came from Marseille. At the time of the stenting, the guy was giving diclopidine the day before the balloon angioplasty. If he had to put the stent, the diclopidine was on board. What was his name of that? Balagan? Yeah. Balagan. That was the big change. Now, what we have seen is in 95% of the case, there is a fracture. And the fracture is always at the smallest, thinnest part. We have measured that very precisely, 372 micron. That's where to get the rupture. Not at the site of the plaque, not even the edge of the plaque, what I was expecting, but just at the small part, the most weak, the weakest part of the vessel break. What you see on OCT, and we are still working on it because it's frame by frame by frame, and AI is not yet there to measure the small thrombus. Systematically at the tip of the two edge, you see small thrombus, probably platelet because there is no shadowing behind, but no consequence, absolutely no consequence. I would say this one will be in trouble. No, he was not in trouble. So also a little bit thrombus is part of the phenomenon. It's difficult to make the difference between the thrombus with shadowing, the thrombus without shadowing, but thrombus is there in a small portion, but no acute obstruction. Now, everything you said is beautiful. I mean, it's really the way we are thinking. It's the good sense. It's down to earth. I mean, I love this kind of talk. One thing that I am missing terribly, terribly in all this meeting on the DCB is that you don't cage the vessel. Thus, you have to start post-DCB a maximum therapy. That's what you have to do. You know, you will see very soon a paper where we put together two studies, multi-talent with the Supraflex cruise and Pioneer with the Sinomet stent healing and so. That's all about 4,000 patients. You know how many patients are below the so-called level recommended by the guideline? 15%. So you have access to the plaque with powerful atherogenic drug, but you don't see that systematically in the protocol. This is the moment to try to predict and rosuvastatin 40 milligram and ezetimibe in one pill. You have that. That's Sanofi, the Zimpas. That's one pill in the morning. That's it. If it doesn't work, you have to go to your lipidolog and say, guy, I'm giving rosuvastatin 40 milligram and ezetimibe, but it's still with 75, 100 milligram of LDL. And then you will have the permission to use the inclisiran, for instance. Inclisiran in our population in Europe is less than 1% today. Less than 1%. We have done a paper with Tom Lucia to say, where are the guidelines? Who is applying the guideline? Not the interventional cardiologist. And the drug-coating balloon, that's the reason why you have to go full speed with medication, I think. You know, it's quite interesting. In a public meeting in one of these, you know the LDL of Bornwald? 27 milligram. 27 milligram. I don't know how he reached that. You know the LDL of Yagat Narula? Everybody knows Yagat Narula. It was 21 because he was jealous of Jean Bornwald. And the last meeting publicly he said, you know what, Patrick? Now my LDL is 7 milligram. I said, Yagat, pay attention on hemorrhagic stroke. I mean, it has been described. So he's back to the 21 of 27. But it tells me something that it can be done. And you know, in China, the Lin Tao, Professor Lin Tao, we did this big trial on DCB, published in the Lancet and present at ESC. They are planning 10,000 patients where they have 0.8 millimole for LDL versus 1.4. 1.4 is 50 milligram. So they will go to the 25 milligram. I think these guys are in the right spot. I mean, DCB and very, very aggressive treatment. Then you will not have what we all fear. There is a piece of metal for 20 years with neoatherosclerosis and all these things. That's the way to go. And you know, Gunzig for a certain time used to say, I'm a dentist, and then he stopped to say that. But initially it was his dream. His dream was to maintain the patient in the one vessel disease. You do the right, you do the left, you do the circumflex, but you stay in one vessel disease. But you have to have drug to help you, yeah? Because my generation, the growing generation above 70 years, if you look at the pyramid of age, that group is augmenting every day, 70, 80, 90. The birth get reduced, and the working capacity, working people get also reduced. So that's calcified. That's maybe beyond anything called regression. But the generation which is between 20 and 45, that's the only generation Valentin Fester is talking about, because you can get regression and you don't put metal in these people. That's the message of David. And it's the Damascene scene. That was David or that was Simple? Oh, wrong name.
Fernando Alonso. Yeah, very short, very nice and stimulating presentation. Fully agree with that. But let me play a little bit of David's advocate, right? So that if you go to the guidelines are very clear. For the novel lesions, you need to put drug-eluting stent. This is 1A. In the last guidelines, in the recent guidelines, now you got even in the chronic coronary syndrome guidelines that even for ISR, they recommend drug-eluting stent versus bare metal stent. Well, this is what we got in the guidelines. Then you got all these studies, randomized or observational, in de novo. We performed some, but they and the results are, for selected patients, where the two strategies are very appealing. Inexperienced people, TLR, which is the main primary endpoint, is similar. So this can be done for sure, but there is a bias. And then we learned very recently that this is the recent Chinese study published in Lancet, say that non-inferiority was not met. So having said all that, of course you can do that. But why should be doing that? I mean, your interventional cardiologists don't have the experience to, see the sections. They go there, they use optical coherence tomography, and they see terrible things. So this can be done, but this is against the guidelines, I will say.
Yeah.
And how can we push the field forward? But not just saying, it will be great, not using metal.
So if everybody
I have to intervene here because I know the story behind. I mean, the story behind is Charlie Gao was a fellow together with 7 other fellows from China, and we planned that trial, KH1, 4 years ago, with a lot of interesting things, which is preparation before randomization, etc. And now Charlie Gao is busy these days with a huge amount of letter together with the Lancet saying that paper is misinterpreted. I mean, this is a remarkable paper. You have 2,600 patients. The half of the population is below 3 millimeter. That's what we do in the lab, below 3 millimeter. Look in your database how many times you use a 2.75 of a 3. And only the half of the patient is above 3 millimeter. Above 3 millimeter, you see a kind of catch-up. Maybe we will not aggressive enough with the drug-coating balloon. That's my point number one. Because it's not immediately, it's after 6 months, 1 year that it come back. And below 3, perfect. As good as the death for 1 year. So there is in the media in China misinterpretation of the data, and Lancet was so upset by that they wrote a letter to us and said, you have to correct that publicly in China. So that's what we are doing. We have been writing to everybody to say this is not a negative trial. This is a trial showing that below 3 millimeter it's a good treatment, above 3 millimeter and of course it's categorical as usual in medicine. You have to find a little bit the way in between. But that's very important because, key opinion leaders like Fernando is telling us the guideline make the wrong interpretation. No, they should clearly said, as long as it is below 3, you can do it 2 years. It's not 10 years. We discussed the 10 years yesterday, but 2 years is okay.
I think we should close this session. Definitely extremely interesting and important, and this is why EBC is really special. Thank you very much to speakers and to all of you.
So I think we probably ought to keep the energy in the room and get started. If you ever needed a warm-up act, I think to have Patrick and Fernando creating the debate, there's every expectation that this is going to overrun, Ben, I'm afraid, but I'd like to start the clock maybe at 15:55. So it's a great pleasure for me as the chair of this next session on behalf of Cordis to really extend the conversations we've just had in relation to this very exciting field of drug-eluting balloon and specifically now to consider maybe drug-eluting balloon use in bifurcation. We've got a fantastic panel. Joanna, I'm sorry that you are the only non-UK representative, but joined by then Peter, Simon and Dave, and actually all of us have been recruiting patients to the Solution de Novo study. If I could just have my slides up just to outline the presentation. So what we're hoping in the next 30 minutes is really to offer maybe some experience from our engagement in that study. There's another Damascene moment, I think, with Peter, who is going to kick off by describing his journey to metal-free. And then beyond that, Simon will give some of his experience and expertise, but then also very importantly actually share with us some of the data that was collected in the first 1,000 patients recruited to Solution. Solution de Novo has now closed recruitment earlier in the summer with the expectation and the hope that the primary outcome will be presented at next year's TCT. So I think for the purpose of time, we will get on, and I invite Peter up to present his journey.
Thanks, Tom. It's a pleasure to be here. Thank you for the invitation. If I could have my slides up, please. We had a very provocative discussion before this session, and I think this will also be very similar. So that's my necessary slide for conflict. This is really my journey, and it's going to be similar, perhaps, to what Dave was just suggesting. For me, I'm going to talk about a decade, and I'm going to talk about how we've gone from simple lesions that we made complex to more complex lesions that we can make simple. So that's the sort of message of this next 8 minutes. 3 components to intervention, in my opinion. Lesion assessment, and I think without doubt best done for bifurcation with intracoronary imaging. We don't get that much information from an angiogram. The second phase is, of course, preparing the vessel, and that's the key, and we've got to get it optimal. And then finally, destination therapy. Metal perhaps for some, but I think let's think about going metal-free and how we can apply this newer technology. We know that this sort of simple lesion, we can get a very interesting stent result. In this case, I'm going to show you, was with a culotte. It's a pretty simple lesion. We had a great session earlier about 001, and there's no perfect solution with stenting. And in fact, this looked okay angiographically, and it looked pretty good at 3 months, as you'll see in a second with OFDI. But I got obsessed about the carina, and I was thinking that the carina should be free of metal, which led me on to access. And in 2014, before that, we were putting in quite a few access stents. And the key we learned about this technology was that you had to prepare the vessel. You could get very nice results. You could get this carina free, as it said on the tin, but the rest of the vessel, they still became full of metal because we put stent distal, and obviously they had the access proximally. But the preparation of the vessel was the absolute cornerstone of this technology. It was tricky to put in, first of all, but if you didn't prepare the vessel, you could not get good placement. So if there's calcium, you had to use atherectomy or other tools. You didn't have IVL then. You had to pre-dill both the main and the side, and you often use cutting balloons to get proper effect at those ostial lesions for recoil. The positioning was, as I say, a bit tricky. Finished off with a kiss, but you could get pretty good results, and they were fairly reproducible. And actually, this was a good technique. But of course, the technology was never going to last. It was expensive to make, and the uptake was not that common. There's a few people in the room who are certainly using it. But we applied it to many different bifurcations. We even put it into lesions where we had complex CTO, and we finished off with access. We put it into vein graft failures in bypass surgeries. We'll see in the next case. Whether it was necessary to put all that metal in, I don't know now, looking at it. You could perhaps apply a different technique in the modern era. But, even some of my great companions here on the thing, they came across and we did some cases together. So everyone was out doing this. And then this other technology was around the same time. And this was even more appealing because it was something in my mind that was never going to stay there for the long term. And Patrick's already made that point. And this was a case from 2014, 2015 with clear stenosis. This was the only case I did with a double absorb type case. But preparation, again, was key. We did a TAP in this case. And I was really worried about this case for a long time. But in fact, this is 8 years later. Patient comes back, 2023, it looks perfect. It's got a stent to the LAD, you can see. The culprit here was the right coronary, and this patient was randomized in the solution trial, sadly to stent, and got a big stent to the right coronary with image guidance. So that's just, is a sort of modern era. But we learned today, and we've learned at every EBC, that provisional strategy is the best. And of course it is. Putting minimal metal in is being proven to be more superior to putting tons of metal in, which makes complete sense. But it isn't as easy as we all think. not in the cath lab. Not as you get older, your eyes get less good. And position in the pot, for instance, can be hazardous. You go too far, you shut the vessel. If you go too proximal, you have geographical miss. And Niels has already said from October, abluminal wiring, even in experienced operators' hands, you get it in 5% of cases. And if it's not corrected, it leads to MACE. And this was a case of a colleague, didn't correct it, didn't even notice it, and they crushed the stent. So abluminal wiring is a real problem. There's ways to get around it, of course. So here is a case from just a couple of weeks ago, anterior end STEMI. It looks like a simple lesion. We've got some coronary sinus reducer to do. This was like a warm-up case. I thought it'd be very easy. We do OCT guidance because the patient's going to go into the aero registry, which is Tom is running. OCT, I think, again, gives us real clarity of the case. It tells us to avoid that sort of bigger proximal vessel. We have a nicer landing zone just a little bit away. We've got perfect measurement. You see the diagonal is really clean. It's not going to be a problem. Very tight lesion in the LAD. So we prepare it, and at this point, actually, I was very tempted to stop. I thought I've got a great result. But we've finished solution, so it wasn't an option to randomize the patient. And this is the OCT and what we just heard from Patrick about these dissections you can see, but it looks fine. I could have easily stopped. But because we're not doing the trial and all the discussions about guidelines, I put a stent in. And I size it, maybe a bit oversized, but it was sized to this distal vessel. The pot balloon, I thought, put it in the right place. But that simple technique of putting the stent in jails that completely normal diagonal. So I've gone from having a really nice result to having a problem. And actually, it wasn't so easy to wire. Had to use a dual lumen, had to use a pilot 50, slightly aggressive, a bit risky, chance of perforation and so forth. We got it open and I kissed and then pot, and we get a good result and the patient's fine. But it's gone, an extra probably 30 minutes or 40 minutes of the case, more x-ray, more contrast, more time, and frustration because it delayed the rest of the list and meant it was harder to get to the next conference later in the evening. So 2024, I think we are moving away from this sort of perhaps concept that stenting is the right way forward for all these cases. And perhaps we need to think of alternatives. So how can DEB make it easier? How does it make it more simple? Well, it makes it simple because we don't have to think about these complex stent techniques. The principles of the case remain the same. So we assess the case, perhaps with physiology up front or with imaging, to understand what we're doing. And this is an example here of a more complex bifurcation than you've seen already. This is very basic imaging with eagle eye IVUS, but it gives us enough information about the plaque morphology, and perhaps our landing zones, and I think it's fairly simple, but effective and quick. We then prepare the vessel, and the preparation, as I've already said, is absolutely key. We use cutting balloons, scoring balloons much more readily than we would perhaps ordinarily. And when we're satisfied that we've got a good result in the main vessel, we think about the side branch. And here, this is a trial patient was randomized to solution. So independent diagonal does need treatment because it's severe. And, often you get this recoil effect, and we go for that 30% as a sort of the marker from the consensus paper. So we focus a bit more on the preparation with a cutting balloon at the ostium. It's very effective. We move to NC balloon. And then actually, we're kind of almost done at this point. We've finished with our preparation. We're happy. Angiographically, it looks good. What does it look like on IVUS? Well, we don't know the answer on IVUS in terms of how good we should get it because we don't have that information. I think we need to learn it. But because it's an angiographic study, if it's less than 30%, we're happy to randomize and go with we're happy to treat with a balloon at this stage. And then the treatment stage is really simple. It's a balloon to the diagonal with a solution. It's a balloon to the LAD, and the case is done. So no recrossing, none of all the complexities of having to work out where we've crossed with a wire and how does the stent look. Forget all that. It's really straightforward. So final thoughts. DK crush in that type of case, all those steps. You may have modified it with Thomas's talk. Provisional, less steps, but still quite a few steps. With DCB, it's all about lesion prep. And you go from heavy metal to minimal footprint. And I think that's got to be the way to go. We need data. And Solution, I hope, is going to provide it. And, of course, it may not. There's going to be more trials to come in different arenas. But this is where we're at, and I think this is where we need to think going forward. And there's still a lot to learn, but I think we're in a good place to learn it. Thank you very much.
Peter, thank you. Fantastic presentation. Now, this is a slightly loaded question because I think we're relatively aligned, but I'm not sure about the rest of the panel. You've emphasised quite strongly there a place for imaging. Do you think imaging is as necessary for the minimal footprint than it is for heavy metal?
Well, great question. I mean, obviously, for heavy metal, I'm 100% you have to image because I just don't think you get good results with angiographic, even in provisional. I think for minimal footprint, it perhaps at the moment it seems less so. You don't have to do it, but I think as a learning tool, it will help to us to understand, because I suspect there may be a point that we need to create these dissections, because you might get cases come back because you didn't prepare enough, and perhaps you have a minimum threshold of what you should be achieving with imaging guidance. Try and understand the sizing like we have with stents. I think that could be very useful information, but it may require another study.
Just throw that to the panel. So in Groningen, what's...
So not as much imaging because I'm not afraid about malapposition, etc., but more looking at flow, I think. I don't know if the QFR post-procedure is an answer, but that's what reassures me when I have a QFR above 0.91, and I don't even know if that's the right threshold for DCB. And just a quick comment also about this journey of yours about scaffolds. We always made this mistake of needing something to scaffold, and we don't actually, right? And to allow the positive remodeling, you actually don't need the scaffold, which always had a bit restrictive remodeling first. So that's a side note. Sorry.
Yeah, I would say at the moment a lot less imaging in this setting. It's very angiography driven, but angiography has so many limitations, it's quite possible that as we learn more, we will find out that IVUS or OCT or whatever will show us, okay, this is safe to leave, this is inadequate, this is good, you know, so it may be able to characterize things better than pure angiography.
Can I just make a comment? So as an American operator, I love coming to Europe because I always learn from the Europeans, right? You guys are always ahead of us when it comes to new technology like drug-eluting balloons. And having done PCI for a few decades now, I haven't taken this journey that David, you and yourself have taken. And it does seem, you know, kind of nerve-wracking, to be honest, because if you think about where we've gone with stenting, right, it's that consistency. It's, you know, the radial approach, you know, we have like 90+% same-day discharge. And so I think until you show me evidence, and obviously you guys are accumulating that confidence, that evidence that you can get away without acute closure, with, you know, what level of dissection to leave behind, what not to. I mean, the consistency we've gotten with stents, radial, same-day discharge, and then optimization with imaging, and, you know, all the standardization around physiology and imaging, it's become standardized, right? We've reduced the variability based on experience when you add physiology, imaging, etc. So I do think that while this is very exciting, to me, getting us, at least in the United States, to get the comfort level and the evidence is going to take quite a while. It's going to take a lot of learning, a lot of comfort. You guys in the UK and in Europe are personally going through that journey and getting that confidence, whether it's our medical legal environment, whether it's our financial situation, the expediency of having same-day discharge. It just seems like quite a journey before we standardize things sufficiently, get the data for us to embark on it.
Yeah. I mean, I agree that we've got to a standardized approach, but we've just had 3 hours discussing where the struts might sit in a bifurcation. So the standardization is a standardization of not really knowing. So the avoidance of the metal may be very attractive, but I agree there needs to be data.
Just a little comment about potential endpoints post-DEB. I think post-PCI physiology is an extremely good possible target. And we reflect the same concerns that were voiced earlier, that what is the endpoint? How do you know that this dissection can be left and this dissection should actually be addressed? Because we're always balancing the risk of an abrupt closure versus the efficacy in the long term. And I do think that post-PCI physiology actually offers an easy and reproducible endpoint, because if you do get past a particular figure, the risk of its closing down is probably a little less. I mean, I don't know, probably it's one of the targets that we should look at.
Yeah, I agree with you as well. And there's certainly been, when I've had some clinical doubt as to whether it's safe to leave, I have exactly done as you say. Usually I've started with physiology and then I've finished with physiology. And if you've got a very normal FFR,
I think it just proves that the flow is actually pretty good. But we don't really have a data set to back that up. But I think hopefully from Solution there will be a number of sub-studies. The invasive wiring was actually relatively low volume, but there will hopefully be some opportunity for sub-analysis with the non-invasive, non-wire-based physiological assessments that hopefully will give us some insight into exactly that question you've just asked.
Two more questions.
Yes.
So, Patrick.
The original data from POBA and restenosis, if we go back to the original paper by Gary Mintz in the 90s, 96, I think, in Circulation, they showed that restenosis after simple balloon was actually negative remodeling, 65, 70%. Do we have any data that the drug-eluting balloons improve the negative remodeling, or we have neutral or even positive remodeling? Do we know that? Maybe the way we treat it? Because I think that's the key. That's the neointimal proliferation. We know it was less after POBA than with stenting. But the negative remodeling, have we eliminated that with a drug-eluting balloon? Do we have any data?
So my understanding of the data related to balloon angioplasty only, when that's all we could do, was that you would get late lumen gain in about 30% of your cases. No, balloon angioplasty only. With paclitaxel balloons that have been investigated a fair bit over the last few years, the ones that work, that deliver the drug in a way that has the effect that you want, you are getting late lumen gain in about 70% of your cases.
Yeah.
And that's angiographically, but also, Patrick will tell us in a minute, on OCT.
Yeah, no, that's right. It's about 70% what you can do. No constrictive remodeling, it is a stable of increase. I want to come back on the two statements by Joanna. I think it's correct. Velocity of the flow is the key things. So many of these software now are measuring automatically the font of contrast in the vessel. That's probably enough. I'll tell you an anecdote after that. And I think David is also right. We are going to learn from the imaging. Maybe it will not be permanently necessary, but we'll learn. I think that when we do an OCT and you don't see any problem with the clearance of the vessel, injection of contrast, you can be sure that the flow is good. The contrast come in and come out. There is not a cut sac of a dead hand where you have red cells staying. That's a good sign. What we should avoid is to have the dissection post-stenting apply to the DCB. Don't forget Nieves Gonzalo has described the dissection at the edge of the stent. That's a totally different animals because it's a junction between something rigid and something flexible, and that's very dangerous. So don't apply the concept of dissection as edge problem. Don't apply that. That's really. I'll tell you one anecdote because I think it's interesting. In 1982, February 1982, I go to Stanford, to the course of John Simpson. Until there, 79, 81, 82, 2 patients on 10 goes to surgery in Rotterdam. There's nothing you can do about it, either at the time of the procedure or at 5 o'clock, Then we go to Stanford because there is a guy called John Simpson introducing the long wire. And I go well along with John Simpson, and I get 150 long wire. Go to Schiphol, pass the security and the custom with my 150 wire. And then, from a success rate of 80%, we went for 100 patients. The 101 went to surgery. But for 100 patients, we didn't have surgery. Why? Because my colleague, which was much more daring than myself, said, okay, it's dissected. Let's dissect it more. So when we have a dissection with a balloon of 2.5, we were going to 3 and dissecting more. And we were avoiding systematically the bypass surgery. That's what has to be done a little bit with the drug-coating balloon and the preparation before. It's not a dilating device, it's a eluting device, it's a delivery of drug. But I think that there was a message. The other things, if you look carefully in the literature, in Circulation, I have published a paper which is called Therapeutic Dissection. And therapeutic dissection, that was the line of contrast parallel to the angio. everybody was afraid of that, you know. There were already people saying maybe we should send the patient to surgery. And I said, okay, I mean, what is this? It's contrast who goes somewhere outside. Sometimes it was disappearing also. You wait a little bit and disappearing. That's what I call therapeutic dissection. And if you look at the paper in circulation, that was the best result post-angioplasty. Yeah? So that's all kind of sign. And I'm sorry to talk about anecdote, but you go back to the balloon, so you have to learn what you have seen in the past, yeah?
Great insight.
But yeah, so I think let's move things on. Thank you, Peter, for a lovely presentation. And if we have Simon up. But Patrick, you make a really important point. And in some ways, we need to distill that experience from 20, 30 years ago to kind of support us on our learning, because as you say, you know, how much injury is enough, and in fact once you see injury the default is to put a stent in because that's your comfort place. But actually, and maybe Simon's case will expand upon this, the learning of how you might adapt dissection and change the status of that is an important one. But Simon, hopefully you can share some of that experience in your presentation.
Great, thank you very much. Can I have my slides up, please? Thank you very much. So my name's Simon Ecclesall. I work at the Norfolk and Norwich University Hospital in the UK. This is the title I thought I was talking on, not the one that's in the programme. Anyway, it comes to the same thing. I'll be showing you a little bit of the solution work as well. So I presented this at PCR already earlier this year. We looked at the first 1,000 DEB cases in the solution study, and we divided them into early cases per centre or late cases per centre. We were just looking to see if there's any change in practice or any change in how people were working or what cases they were selecting or whatever. So essentially it's a little bit like the learning curve or the adoption rate. So as you can see on this slide, the later cases have a lot more type C, more calcification, more bifurcations, more multi-vessel procedures. So it looks as though people are getting a bit more confident in what they're doing. Lesion preparation was pretty much unchanged, slightly less physiology and imaging over time. What happened, what we were looking at was the bailout rate. So there's 2 points in time at which you bail out in a DCB procedure. The first one I'd call failure of lesion preparation. Whatever you do, you can't get a good enough result that you are happy to leave with a DCB. And most experienced operators who try to do DCB most of the time would say they're DCBing around 70% of all of their cases. These are obviously cases that people think they should be able to DCB. And at the beginning, they were bailing out after lesion prep at around 12%. As they learned a little bit more, it dropped not much, down to about 10%. The other time you bail out in a DCB procedure is after you've put the DCB in, and that shouldn't happen very often because, as everybody's told you already, lesion prep up front is all your angioplasty. The balloon is just to deliver the drug. So the reasons why you'd be bailing out after DCB should only be in that very small percentage where you're really unlucky and the balloon has done some damage that wasn't already there. However, what you tend to see is that people either haven't spotted that there's trouble before the DCB, or they put the DCB in and then essentially in the UK would say they get cold feet. They go, okay, it's a proximal LAD and I'm really anxious about the fact that I've DCB'd it and I just want to put a stent in. And at the beginning of our study, the beginning of the learning curve, that was running at about 9%. As it went along, it came down to less than 5%. And that fits actually with all the rest of the published data out there. So, what about the DCB approach to bifurcations? Must be an easier way than really complicated stenting. So to my mind, if you're trying to DCB, you've got some questions to ask yourself at the beginning. Am I putting a stent anywhere as part of my initial strategy, yes or no? And then am I treating one or two vessels? So, here's the time where you can put your DCB through your stent. This is when you were never planning to treat the side branch. You stent across it, you have to go and rescue the side branch. You rescue it well enough with the balloon that you could DCB it. If you wanted to do a planned hybrid or blended approach, the best way, to my mind, to do it would be you lesion prepare the main branch, you lesion prepare the side branch, you DCB the side branch, you stent across it, and then you don't have to do anything to your stent. That way, you're not affecting the integrity of the stent, and you're not affecting the drug you've just delivered to the side branch. If you've done good lesion prep and you've looked at your angiogram or your physiology or imaging, and you'll know that it's safe, it will manage with a stent going across it. It's very rare you'd have to recross in that situation. And I think that's what people worry about with the idea of balloon first and then stent across it. However, there are simpler ways. If you wanted to do both lesions, so side branch and main branch, the way to do it, Bruno's already told us this, you lesion prepare the main branch, you lesion prepare the side branch, you run a checklist that I'll talk about in a minute, basically telling you that you've done a good job in both branches and it's safe. Then you put your DCB in your side branch, and usually you then DCB the main branch last. So you do main side, side main, no kissing, no balloons together at any point in time. The other one would be you're simply doing the main branch, and the side branch is going to look after itself. Prof. Shin has told me endlessly, I use her slides forever, they're beautiful, showing that if you DCB the main branch, the side branch will get better as well. The last one, and I'm amazed that we had a whole session on this, surely the answer to the 001 is just to DCB it. It's so much less complicated and fraught with long-term problems. Right, so that was fairly controversial, possibly, but those are the 5 different ways DCB fits into bifurcation to my mind. So, I was asked to show a provocative case, so I've got a provocative case for you. Apologies for anybody that's seen it before, but it's still one of the most provocative ones I've got. 87-year-old lady came in for an elective angiogram with a lot of angina. Based on the pictures I just showed you, she was kept in for consideration of urgent bypass grafting. You know the answer, they're going to say no. She then had an NSTEMI on the ward while she was waiting for the surgeons because she was so anxious, maybe, I don't know. Guess what? The surgeons now have another reason to say no, which is why she's here. Yeah. So, that's her anatomy. What you're going to do with that? Just in case you're wondering if the left mainstem as well, yes it is. So, there's all sorts of things that you could do. Any of that lot is open for discussion, I guess. If you're going to do it, how you're going to do it, those are all the different ways that are open to you. Obviously, I'm going to show you one that I think means you don't have to put any stents in, and that was the approach that we took. So, 2 wires. You'll be pleased to know I do believe in 2 wires for these sorts of things. Pardon? It's good. A 2.0 non-compliant balloon, left main to LAD. Same balloon to the circumflex, slightly bigger balloon into the LAD. We're just trying to make some space and work out what's going on, really. So, in DCB land, that would be called an inadequate result. You'll be pleased to know I'm not that provocative. This is the checklist that we run in our lab. Lesion preparation. Are you making the vessel big enough? Are you giving them a load of nitrates? Have you got rid of the recall? Can you deliver your balloons so that you know you can deliver your DCB? Safety. How's the patient? What's the ECG like? They must have TIMI3 flow. What luminal compromise have you got? And is it progressive? If it's progressive, that's an intramural hematoma you have to deal with. Is there a vessel-threatening dissection? Is the contrast in the wall that's hanging around? If it's hanging around, it's getting in, it won't get out. When the patient leaves the lab, blood will get in, it won't get out, they'll be back with an occlusion. The last bit, you then have to think about your DCB. It's got to be 1-to-1 balloon to artery ratio, angiographically, the same as your lesion preparation balloons, a little bit longer. And then you obviously need to know your transit time for your DCB, how long from the wrist to the heart, and then your delivery time, usually 30 seconds. So, we haven't done enough work. Here is a 4.0 NSE alpha, so that's a semi-compliant polymer bladed scoring balloon. You can see that big chunk of calcium. It's always in the same place at the ostrum of the circ, hiding on the underneath. Same balloon, pushed around the corner, bit higher, still a big chunk of calcium. Bit higher still, less of a chunk, but doesn't look
perfect, does it, that balloon inflation? We'll then use the same balloon into the LAD. What do you think of that result? Are we allowed to take a vote? Who thinks, based on that one view, that that is enough balloon angioplasty? Thank you, I'm not alone. So you could take some more views, can't you? That's the checklist again. So we're now thinking that there's a bit of contrast underneath the left main stem around the circosteum. Maybe there was a load of calcium there. It's quite difficult to differentiate.
That's a therapeutic dissection.
Thank you. And otherwise, it's a pretty good result in that view, isn't it? So, how are you going to do? No. Very provocative, huh? So how are you going to do this now? You could do your left main stem separately if it's really big, circ first, LAD first, kissing DCBs. So many ways to do it. It's never one answer for everything, is it? But essentially, generally, sequential DCBs, you virtually never need to kiss. And like I said, it's normally main side, side main. I'm now going to break that rule because we were most worried about the ostium of the circ. So we did left main LAD DCB, left main circumflex DCB. This is now the result. There's the checklist. I think the only problem in this, in the spider view, is the ostium of the circ, which it was always going to be, wasn't it? It was where the rock of calcium was and where the balloon struggled. But the recall's not that bad. You've got TIMI3 flow, all the contrast is clearing, patient's fine. So I applied a rule which is a bit slightly odd one. If I'd stented left main LAD and I'd done everything I could and the ostium of the circ looked like that, would I be happy? That's another way of saying yes, so let's leave it. So she went from that to that. 14 months later, she comes back with angina. So she's now 88.5. She had a lot of angina. It looked like this. Ostium of the circ looks worse, doesn't it? One of the things we've learned from all our DCB work is don't just go on the angiogram at this point. Think about the physiology. So she's got some diagonal disease. That was there before. The ostium of the circ looks worse. So we pressure wired it. It was profoundly negative. The answer was the right coronary artery this time. Thanks very much.
The music came on at just the right time. It was kind of triumphant finale.
Yeah, very dramatic.
So, I mean, Simon, it was a lovely case, and it is provocative. And Fernando would absolutely accept the guidelines being out of kilter with this. But what strikes me in terms of the presentation is a very systematic approach. You went 2, you went 3, you went 4, you then went 4 NSE alpha. So you're creeping up on lesions, right? Is that
not
your
always.
approach?
In that case, yes. I mean, that stuff was so tight you couldn't go straight 1-to-1.
I mean, I tend to feel those lesions a little bit, so I don't inflate the balloon as quickly. I actually watch the wastes disappear and do it that way, so I massage it a bit. And the other little point that I wanted to make is that the drug-eluting balloon is it's only a drug delivery, but it's also something that you can tuck up your dissection with. So if you inflate it at 7-8 atmospheres for more than 1 minute, then you actually reduce your dissection sometimes.
I think maybe shockwave would have helped, at least for the long term.
Did you say shockwave?
Yeah.
Yeah, this case was so long ago, shockwave didn't exist.
Didn't exist.
No.
Mm-hmm. Maybe just to see the circumflex ostium, or maybe just 1.5, 7.75 rotablation, just to crack some of the calcium for the long term if you don't want imaging, and if you insist on just using balloons or drug-coated balloons. So I think maybe that would have helped, and with the help of the imaging.
I think imaging and rotablation would have been absolutely mandatory if you're putting stents in. I think with balloons it's a lot more forgiving.
Yeah, although that calcium was on the outer curve, wasn't it? So rotablation may not have had an impact. And so putting a stent in there, regardless of how aggressive you are with modification, has an ongoing risk.
Reasons not to put stents in.
So beautiful case.
Don't tell them guidelines to me.
Well, no, beautiful case, Simon. I mean, is a striking result, and perhaps it's the way to go. Now, I do remember very well when we started with a stent in the left main, because we were doing balloon angioplasty, and there was a major recoil. So when we started with the stents, the left main with all the elastic fibers, I mean, you were able to get a beautiful result, and with balloon, we were getting only a suboptimal result. And the other issue is in the left main, used to be plenty of calcium. In your patient, there was some calcium. And of course, it is possible that the outcome of the circumflex coronary artery with DCB in the two arms is better. But my point is, we don't have a significant series of DCB alone in the left main, including bifurcation. I mean, these papers are not there. So beautiful case, but we need the data.
So there's two papers that I'm aware of.
Small.
Shin.
Three now. Okay, yes. You told me you'd published. We've published ours, and Thomas Rittens has published his as well. We are all trying to get together to put the data together for a bigger series.
Okay.
So I think fantastic case. Just if I might, I'm sorry to remake the point here in the back.
Hello.
So you used physiology at the end when the patient came back with angina. If you'd used it right in the beginning, you'd have been a little more confident about, don't you think that would have been the case? After finishing the DCB, if you could have used physiology right at that time?
Yes, and we do that now, and I've learnt that from Prof. Shin as well. I agree entirely that physiology can really help. And actually, one of the lovely papers that she's written tells you that if angiographically it looks as though you should stent it based on DCB guidelines, that if it's non-ischemic, then it's fine to leave it anyway.
Simon, can you say a little bit more about the calibration of the drug-coating balloon? Because, in the Transform 1, we used the OCT to be sure that the drug-coating balloon was perfectly sizing. So at the end of the study, we had a ratio of 1 between the drug-coating balloon and the reference diameter based on OCT. That is the only reliable technique. When you use QCA, you are systematically 0.3 millimeter below. You underestimate. And IVUS is tricky because it's overestimating the big value and underestimating the small value. So how do you do that? You just use your last drug coating, non-compliant balloon, and say, I will use a drug coating of the same size of...
Yeah, so we're working generally angiographically 1-to-1, and I think maybe if you've been doing it for a long time, you're probably a little bit bigger than most people would think they're working at 1-to-1 angiographically. So yes, the last lesion preparation balloon is 1-to-1. Your DCB should therefore also be 1-to-1. And I think from the point of view of worrying about are you undersizing it, if the vessel truly is 4 and you've put a 4 in, it should touch the sides, but actually if it's 4 with the amount, because you're never going to get a 4.0 result just with a balloon anyway, so a 3.5 DCB will touch the sides anyway, but you might then be slightly underdosing.
And the 21, 22 scoring balloon and cutting balloon, is that still the number today, or is that much higher?
In the solution, it was 30%.
That was in the...
we haven't looked again. We were just discussing whether we should look again or just wait and do the big paper.
But we are running so over time that I think what this demonstrates is the need for even more time to discuss this very exciting evolution that we have in practice. I'm sorry, Tam, but we're going to have to probably move on to the next session. But I'd like to thank Cordis, thank colleagues, and thank you all for stimulating debate.
So, we have our last symposium, session 13. So this is the ABS Symposium. ABS is a Californian company, and his president is Mehran Khorsandi. He is proposing since years, maybe the last chance to have a dedicated stent to treat bifurcation, especially big ones. And it was David is gone, but he was still saying a few years ago that the dedicated stent will be the solution for bifurcation stenting. Until today, he was wrong. But regarding the prototypes I have seen through several years, I think that there is a potential for solving the problem with a dedicated stent. So Mehran Khorsandi, please show us your work.
Thank you, Yves. Ladies and gentlemen, the distinguished panel, thank you very much for allowing us to be here to present. I just want, before I start, I'd like to give a preamble. You must know that you guys here are the cream of the crop. Not everybody has your experience, not everybody has your hands, has your eyes, and has your minds. So whatever solution there is, being with the DCB, with stenting and whatnot, has to work for everybody. So with that in mind, I believe we have found a very relatively easier way of stenting all bifurcations with one unifying technique for all bifurcations. That's a fairly audacious claim to make. We have work to do to show that, but I will show you the potential of that. So I'll start by laying the background, showing you what we do, and I'm going to leave a few minutes for Q&A. So I think the reason for existence is that bifurcation stenting is complex. The complexities are in twofold. We have decision-making complexities in that an operator has to decide what technique they use, and as they take each step, they have to decide, they have to be adept at a variety of techniques to decide what they're going to do next to get the best long-term results. The technique we use also has its own complexities in terms of rewiring the side branches. In case we have to do two stents, they have their own complexities. With DK crush, for example, we want to rewire the side branch through the most proximal stent strut. Then we want to, after the KISS, we want to go through the most distal one. Those are all very complex, tedious, and again, it works in the hands of people who have huge volumes. But whatever we have has to work for everybody, and I think Americans are very cognizant of that. If I can have the next slide. Okay. So high-risk PCIs are performed by less than 20% of practicing interventional cardiologists. Complexities of bifurcation stenting, as well as risks associated with lesion prep in left main coronaries, are some of the reasons left main PCI is not attempted at all by most interventional cardiologists. I think it's now well accepted. These are the very basic rules for bifurcation stenting. Provisional stenting is better. There is a price we pay for a second stent. Have we started that with a second stent because we think the side branch is compromised, or if we add one, the MACE and restenosis is still higher? How do we do a provisional now? We wire both branches, we predilate the main vessel only. We don't want to have a dissection at the ostium of the side branch. These are the things we've learned at the EBC. We pot in order to rewire through the right strut. We go through the most distal strut. We try to find it centrally. We open the cell, then we KISS and repot, and depending on what the side branch looks like, we decide what to do with the side branch. We compromise with the side branch. Because there's a price to pay for fixing that side branch with a stent, we leave good enough alone. We say if the residual stenosis is 50, 70, 75%, leave it alone. We FFR it. We say if the FFR is good enough, leave it alone. We don't do that with non-bifurcations. So the reason we do that is because there's a price to pay for fixing that side branch with a second stent especially. And so I want you to think about this, which I'm sure most of you have. Current stents and delivery systems are designed for vessels that are cylindrical, where two dimensions, two variables matter only, diameter and length. The interventional community has tediously and very creatively found ways to place these cylinders at bifurcations where there's a third variable at the coronal region. I'm stating the obvious. By definition, there's some stent deformity with what we do and a high probability of some malapposition. Even more so when we have two stents. And then if in the primary two stent techniques, we have multiple layers of stents. As such, recommendations and regulatory guidelines for shorter duration dual antiplatelet therapy specifically exclude bifurcations. Most of us don't stop dual antiplatelet therapy when we've done bifurcation stenting, unless we are absolutely confident that we have apposed the tissue and we don't have malapposition. So I want you to consider something. What if we could stent bifurcations seamlessly, the way we do non-bifurcations, leaving a symmetrical scaffold behind that molds the bifurcation anatomy, extending into the carina, extending into the ostium of the side branch without any deformity or malapposition. So we have essentially our uniqueness is a delivery and stent integration system, which is now 6 French, is a very good 6 French, is nearly 5 French now, which simplifies the technical and decision-making aspects of bifurcation stenting. It's designed to mitigate the pitfalls of current bifurcation stenting techniques and lead to a symmetrical deployment of a stent at the bifurcation with protrusion into the ostium of the side branch without any deformity. As such, it enables stenting of all bifurcations in a simple, reproducible procedure designed for better angiographic outcomes and guaranteed continuous side branch access. The best way to show it is with an animation. I will show you more. Animation alone cannot capture. Can I have the sound? Okay, I'll speak to it. So we've tried to show the third dimension here. We're trying to show a bifurcation with a perspective. Remember, everything we do is on paper, or when we show is two-dimensional. You have to put your three-dimensional hat. It's an independently movable dual catheter system. The catheter that goes into the side branch can move back and forth. After pre-dilatation, we go to the carina, we pull back a few millimeters, we pull the side branch balloon back, and angiographically, we put the two markers next to each other. We go back to the carina, and here's the key to our technology. We inflate this side branch balloon first. This causes the necessary phase shift, the automatic alignment of the proximal segment of that stent looking down the barrel of the side branch. The wire bias goes away during that balloon inflation. The wire is centered. The ostium of the side branch is covered. We inflate the main branch. We're based on the Murray's law, and then we kiss, and we go to the next stent. So while we are mainly about a delivery system, and it's taken us some time to make it almost a 5 French system, we also have uniquely designed our stent in that our stent is designed as such that proximal to the carina, the stent pattern allows for a much larger diameter. As such, our 3.0 stent goes easily to a 5 millimeters without any deformity, and our 3.5 stent goes all the way to 6 millimeters. And remember, it's not a uniform stent. That's the segment proximal to the carina. We try to be even once we're done. So although our provisional systems for stenting side branch are relatively simple, we make that simple even simpler. What is unique about us is that we don't have to rewire the side branch. The alignment to the side branch and covering of that ostium is automatic, and this is very, very important. And there's no stent deformity when we're done. This is something which I have to show you. The only way I can show you this well is by showing you in high magnification. So this is a plastic model. You see the flaws in the model. You see the glue that has put the pieces together. I want you to look at the segment of the stent beyond the carina. Look at this part. While the balloon is coming up, look at that part. See how it turns and looks down the barrel of the side branch. So, and again, in order to capture that, we're going at a very slow motion. Watch that, watch. You see that? That is something we can't do now. We deploy the stent in the main branch, and the face of that stent is sealed. Now we're looking down the barrel of the side branch, and again, in slow motion, you will see the main branch balloon come up. Now that we're looking down the south branch, and the stent is deployed. The other thing which, as we deploy, I want you to see, we've put different coloring so you can appreciate each balloon better. And by the way, our catheters also have different colors so you can easily say which one's the main branch, which one's side branch. So we're very slowly inflating the main branch balloon. Look at the struts that protrude into the side branch. That strut is essentially perpendicular to the axis of the side branch. Should we require a second cylinder, a second stent, it's a T-stent. It's not a complicated procedure. It's the same way you stent any other non-bifurcating lesion. You just have to take care of the two dimensions, decide how long the stent needs to be. So that's essentially the crux, and as you see the main branch balloon getting inflated more and more, it's coming together. I'm going to let it play for one moment, because as we deflate, you will see the part that I'm talking about. And again, it's very hard when we look at such high magnification to keep all the stent struts in focus. So some of them are out of focus because they're in different depths. And again, we deflate and we pull back. I think it's pretty obvious. And for the sake of time, I'm going to go to the next slide. Look at the proximal part of the stent is not deformed. It could be stretched even more. And while we go with the Murray's law in terms of, because of the flow dynamics, the stent diameter at the carina, depending on the angle of the side branch, can be stretched much higher than what we calculate with the Murray's law, with the Finet's law. Okay, so the quote-unquote simplified approach to the treatment of bifurcations is shown on the left. This is what's published. That model is actually by Dr. Raab, who's sitting in the audience, which I had the pleasure of running into yesterday. Please note, on the left panel is actually what we are calling it the simplified approach, and that's not my saying. This is the published. And we go from that to one solution, and if you see any residual stenosis in the side branch, you'll deploy it. I think we're talking for drug-eluting balloons appropriately now, and we're for the most part saying we're going to leave good enough alone. But we need a system which takes care of all those things which was mentioned. We are confident when it's done, there's no dissection, there's not going to be a thrombosis, and we have the largest diameter according to the size of the vessel, and I believe we do that. And I will show you how far we've gone and what else needs to be done. This is a micro CT of one of our devices. This micro CT looks so good that if I don't tell you it's a micro CT, you think I've animated this. This is a micro CT without a pot, proximally, and that's why you see the proximal part is ovalized. This is very interesting. My colleagues at Boston Scientific actually sent this to us. You see the artifact. This is a micro CT of a Synergy stent on our delivery system with a second stent in the side branch. Again, at least in the model, it looks perfect. So based on this idea, several years ago, just after which I ran into Yves and Thierry, we put systems together from off-the-shelf stuff. We wanted to prove the concept. As such, this turned out to be an 8 French system. We had hand-crimped partially these stents because we had to be able to move the proximal segment. This is the very first one we did. This was a stainless steel stent, 8 French system done in Sao Paulo with Alex Abizet. And this was a 59-year-old gentleman who had come in with an acute MI. You see the middle segment was stented first. And the key thing is that we stented that bifurcation of LAD and diagonal after that proximal segment was stented. That means our device went over the 2 wires through the stent and made it to the bifurcation. Once we felt confident, we moved and we did a few more in humans, again, with our 8 French system just to prove our concept to ourselves. This is a provisional system. This was done with Jose Condado in Caracas in Venezuela. As a Medina 111, you see the system at the carina, you see the side branch balloon distally. I'm going to go through it quickly. You see the markers pulling back. We align the two, and there's their alignment. We inflate the side branch first, we inflate the main branch next, and here's the final result. I'm going to show you an eagle eye going through with ease into this small branch because there's no stent deformity. It's a railroad, it's completely open. We go from that to that without a stent in the diagonal in that case. This is a Widowmaker. There's a patient with subtotal stenosis of LAD and diagonal, very shallow angles. Shallow angles tend to be more problematic. They're harder to get a good results with the shallow angles. I think most people would culotte this. There's also Cirque disease. Again, the system at the carina, the side branch marker is way down if you see it. And in the next panel, you see the side branch very slowly coming back. So we'll align those 2 markers, inflating the side branch, a little contrast is trapped there, inflating the main branch, And in magnification, I'm showing the bifurcation. Look at the smooth transition. There is no pinch at the side branch. Is very unusual for us, no matter how good we are and how lucky we get, not to have a teeny tiny pinch at the side branch. And here's another view of the same thing. Okay, now we keep talking about LAD diagonals. Most of us hate doing bifurcations elsewhere. They tend to be more distal. They tend to be more difficult. Sometimes they're smaller side branches. We say, forget it. Here's a Medina 111 PDA-PL in a fairly calcified right coronary artery. Again, wired, pre-dilated, and I don't think we have any technology that can get you the results we see here. This was done with Samir Dani in Ahmedabad, India. And I'm going to show you one more, which most of us hate doing. This is a grungy, plaque-laden circumflex obtuse marginal 1. And I'm making a point of showing it in rotational panning on the right panel. Again, look at the smooth transition into the OM. This is, I believe, as physiologic as we could make molding the anatomy. So where are we now? So we kind of proved the concept to ourselves. It was essentially myself and one engineer who's a veteran of the industry, and the two of us set out to make this as refined as possible. Obviously couldn't have an 8 French system. We moved to 7 French, and we've moved over the years. We have found all sorts of technology to make our dual catheter system a lot smaller. We're nearly 5 French now. And you can't have a device without a drug on it. It's taken us a couple of years. Now we have actually a 4th generation polymer is made by a company actually in Germany. It's the least inflammatory, if you will. We have completed our animal implants required for the FDA. We met with the FDA a couple of years ago as we were going through this. FDA convinced us to have a US first policy. They said they will help us move things through as much as possible. That was around the time that the European Union regulatory system was changing, so we almost didn't have a choice, but now we're doing both simultaneously. And we were lucky enough for FDA to grant us a breakthrough device designation several months ago. So we have completed the drug-eluting version of our device, which I'm saying is nearly 5 French in the pigs. We're submitting that data along with a prerequisite bench testing of nearly 7,000 devices in order to start our human trials in the US and in the European Union. And if everything goes according to plan, we're targeting to be in the market sometime in late 2026. Obviously, a lot more studies have to be done to validate what I'm saying, and we will find things to make it even better, and we will find if there are any pitfalls, and we'll get better at it. So we're gearing up for that FDA trial, and we will nestle the CE mark into it, and we're looking forward to the work that needs to be done. Thank you.
Dear Meran, this is very promising device. Yeah.
Patrick is asking for the question.
So, Meran, between, I think, 2010, 2016, there was the time of the dedicated device. And it's very refreshing to see you here for the 3rd time, I think.
More.
Okay, so I remember Meran, and it took a long time, 2016, if you take that as a, not starting point, but at least getting public. And we are in 2024. You are an entrepreneurial person. What is the problem? What is the difficulty? The money, the coating, the drug, the regulatory, why it takes so much time? While
Excellent question.
In 2010, there was 8 companies with a dedicated device, and all disappear. Tell us. I'm really curious to know
so
how
there are
we
2
can
questions.
help you.
First of all, the answer to your question, what took so long, is all of the above, and I will elaborate more. In terms of all the other companies, I want to remind you guys that almost all of the other companies actually had CE mark. Under the old MDD system, it was not as hard to get a CE mark. And the reason they did not survive is because they did not make life any simpler and they did not have better outcomes. So even though they were on the market, at least in the European Union and one of them in the United States, it did not fly because they were not used. What took us so long is that, and how come we stuck to it? Because once we had done with the clunky 8 French system with a stainless steel stent, we knew this thing works. Technologically, to get it to be a nearly 5 French, to move easily through a radial 6 French access was a major feat. These are not two off-the-shelf balloon catheters to make it such a low profile. These are not hydrophilically coated catheters. Hydrophilically coated catheters actually, when placed together and stay in the environment, they actually tend to stick together. So we have special polymers to make it move very easily. We've done special things to the distal parts of the system to make the two balloons next to each other substantially rounded and not necessarily oval. We had to put a cuff on the proximal segment of where the stent comes out because a part of the stent is not fully crimped. So the cuff protects it if you have to come back into the guide catheter. A lot of little technologies had to go to make it possible. Money was an issue too, which we raised as we went, but money definitely was an issue. And then all drugs were proprietary. Not only drugs were proprietary, coatings were proprietary. And for a device to go through the FDA with a drug, you go through 2 divisions. So it became a very, very difficult thing. Sirolimus came off patent. So that's why we see so many sirolimus-eluting stents. And we had to find the best way of coating it. So while we solve the problem mechanically, we don't incite restenosis. So it took us a couple of years, 2.5, 3 years, just to address the drug, although we're not about the drug. And that's why it's taken such a long time. As we were struggling and doing all these things, we actually asked the FDA if we qualify to apply for a breakthrough device designation, and FDA said, you don't need to ask, you have breakthrough device designation, because they saw the merits, I believe.
Miran, maybe we can leave 1 minute to Imad, because after that we have to have a very short pause of 5 minutes and come back for the 2 next sessions. Please.
Actually, we worked on a similar device in the 90s that was from Invatec, twin rails. And
I'd like to comment on
main two problems were crossover wires and the length of the stent was not fitting with all lesion, length of lesion. So you have to add, often you have to add another stent proximally or distally. That's the main limitation, I think, for such a...
Minvasis had another issue in that even though there were dual catheter systems, it's important to realize Minvasis system was fixed. The 2 catheter relationships were fixed. The way you deployed the Minvasis system was you would deploy it in the main branch first. You would not be able to take care of the wire bias. And after you did that, you would advance the side branch. By then, the die is cast. The other issue with all two catheter systems like Triremia and Minvasis was the wire wrap, as you mentioned. Again, because the 2 systems were wrapped and the connection between the 2 is fixed. I have bench testings which show we simulate multiple wraps, and actually our system mitigates the wrap. The 2 go around the wraps and push the wrap behind. So again, these were among the things we had to do as we realized there were issues with other systems. I have a table actually which shows all the devices that have been in the system, the DVAX system, the Zions SBA, the Boston Scientific's pedal, and what were the shortcomings of each. For example, the pedal system was a beautiful, beautiful stent. The issue with that was we couldn't put it at the bifurcation with the appropriate orientation. And that's essentially what we've solved.
Miran, you are the last chance of dedicated stent to win.
Thank you.
What was David was telling 10 years ago, maybe the dedicated stent will win. For the moment, he was wrong, as he said. So
we have work to do.
We are supporting you. Next year, if you need help in all this audience in Europe or elsewhere, we can transmit your message.
Yeah, I just have to say, we love our EBC family. We definitely learned here, and we've adapted our systems to what we have learned here. And I can't thank you enough.
Thank you. So, friends, this is the end of the coffee break. In 5 minutes. In 5 minutes. So, in 5 minutes is the end of the coffee break. So, you can refresh or take a coffee and come with it. And we'll go for the 2 last sessions. This is very important because some of our colleagues will have flight problem.
Very good. So I guess you get your coffee. The next session is going to be quite interesting. There was a lot of exchange of email between Yves and other people in the panel and outside the panel. I would say that this session is his baby, yeah? And he wants to discuss the left main bifurcation stent sizing. As you could see, it's very short presentation, 5 minutes, 7 minutes, and so on. Then after 4 talks, we will have some discussion. Then we will start again with short talk and have some, again, discussion and finally conclusion. So at any time, Yves can interfere and say, no, you did not understand what I want to do, because it is his idea and his baby. Okay, so the first we have in the panel, maybe you can introduce yourself. It's the most easy. Take the microphone. And then we are...
Dr. J.S. Duggal from India.
Okay, the next one.
Hi, I'm Paul Morris from Sheffield in England.
Very good.
I am Jungmin, I'm from South Korea.
Yeah, you forgot that he was with me 2 weeks ago.
Yeah, I'm sorry.
Okay, good. So the first speech will be intravascular ultrasound optimization criteria for left main coronary artery stenting in pursuit of the magic numbers. And that's Shripal Bangalore.
Thank you very much. Can you guys hear me?
Sure. Yes, we see the slide.
Okay, fantastic, and thanks for having me on. And this sounds like an amazing session. So I'm going to just set the stage in the 5 minutes I have in terms of intravascular optimization criteria. These are some of my disclosures as it relates to this particular talk. And this is based off of an editorial we wrote for Circ Cardiovascular Intervention along with Akiko Mehra. For the study by Kim, Dr. Kim will be presenting later today. Just to set the stage, I mean, we all know, I think this crowd is very familiar with the data on intravascular imaging. So we published this data looking at intravascular imaging versus functional guiding versus angiographic guidance. And this is kind of the summary of all of the randomized trial data for the ACS subgroup. And clearly, intravascular imaging is the best modality for reduction of all cardiovascular outcomes, including CV death and stent thrombosis. And this was also true in the non-ACS stable coronary disease subset group of patients where intravascular imaging is the best. I was part of the ACCHA revascularization guidelines, and back then in 2021, we were still waiting for a few more trials on intravascular imaging. And of course, I mean, many of us strongly felt it should be class 1, but overall consensus was we went with the class 2A for post-PCI optimization, specifically for left main or complex coronary artery stenting. And more recently in the 2024 ESC guidelines with all of the accumulated data, I feel like it's absolutely the right direction that it's a class 1 level of recommendation A to use intravascular imaging for complex lesion, in particular left main stem true bifurcation or long lesions. So this leads us to intravascular ultrasound optimization for left main PCI. Some of the nuances to consider as we hear about the rest of the speakers are, can we come up with one single set of magic numbers? And what we had so far is couple of many different criteria, but the most prominent ones I have it here is criteria for what we used to call, Western versus non-Western world or Asian and Caucasian patients. For Asian, the data from S.J. Park's group, the 5, 6, 7, 8 rule was typically considered 5 millimeters square for a left circ ostium, 6 for LAD, 7 for the point of confluence, and 8 for proximal left main. And in terms of the Western world, this is data from Excel criteria for the Caucasians, and the thresholds MSA area criteria were larger, 6, 7, and 10. As we think about this, and if you look at back in the data for 5, 6, 7, 8 rule, This was based on angiographic restenosis at 9 months, and if you use that criteria, and as was shown in this paper, under-expansion versus no under-expansion clearly predicted MACE-free events and also TLR-free events. But a longer follow-up of this particular study, now reporting 5-year MACE outcomes, shows that the 5, 6, 7, 8 rule may not do as well as it did for 9 months angiographic criteria, and we may have to think of larger criteria, larger size criteria. For example, here for the circumflex, it's 6 millimeters square, LAD is 8, and left main is 12. So from 5, 6, 7, 8, so to 6, 8, 12, closer. It's closer to that of the Excel criteria. I think, and I think we'll hear more about this during the later talks. The other thing to consider is, I mean, this is one such example. If you look at minimal stent area and continuum of risk, here is IVUS MSA criteria as continuous variable and risk of events, whether it's a MACE or TLR. You can see it's continuum, and that there is a threshold. So we're trying to find a categorical threshold for a variable which has a continuous risk. And we'll come back to this at the end of the end of this. I also showed the Excel criteria. Akiko was telling me that that the manuscript is still in the works. They're trying to refine it. But what I want to point out from all of these criteria is, if you look at the Excel criteria, the sensitivity and specificity tends to be modest. I mean, this is around 50% sensitivity and specificity criteria for even this 6, 7, 10 criteria from the Excel trial. Now, of course, other trials have looked at various different criteria, but all of these have been applied retrospective. So in other words, taking data which is where investigators were not asked to chase after a target MSA and looking at optimal criteria. So here is data from the Noble trial looking at 224 patients who had post-PCI IVUS, and this was analyzed per core lab. And the highest tertile left main stent MSA, which was 13 millimeters square or greater, had significantly lower left main TLR compared to the first tertile. Then moving on to, so whatever I discussed so far were absolute thresholds. What about relative thresholds? So interestingly enough, I mean, there are a number of studies which have looked at the relative thresholds. So here is the IVUS Pro criteria, looking at IVUS optimization, the ostial and mid shaft by using a relative criteria. And this relative criteria is based on reference lumen area. It's a 90% of the reference lumen area. And the same for distal left main based on reference lumen area.
You hear the music of Star Wars because your time is over.
I think I may have exceeded my time, so I will. Sorry, yeah.
I agree that it's very intimidating, this music, you know. When you hear that, you say, my God, I'm in the back shape, yeah.
Yeah, that's what I thought. They were giving me a warning. But anyway, so I have just 2 more slides to end this.
Go ahead.
So, you know, based on all of these, so the existing criteria are ones shown on the screen, 5, 6, 7, 8 Excel criteria. There is also a relative MSA criteria. So what we proposed in this editorial is the minimal, if you're using an absolute threshold, the minimal based on all of the accumulated data should be 6, 8, 10. And the optimal is perhaps larger, 7, 9, 12. But if the caliber of your artery is small, perhaps use a relative MSA criteria. And this MSA criteria should be based on vessel area at the MSA site. So this 40% is the MSA relative to the vessel area there. So just to summarize, clearly what the data currently suggests, larger absolute MSA is associated with better outcomes, and it's on a continuum risk. But we definitely need to establish safety threshold, because the last thing we want to do in the left main is cause a vessel rupture or perforation. And relative MSA threshold may be useful in patients with small caliber arteries. And when we talk about relative MSA threshold, is it relative to the reference lumen? which should be 80 or 90%, or should it be in reference to vessel area at MSA site, which typically should be greater than 40%? One of the things as we talk about is to also think about the fact that we are using some of the data and retrospectively analyzing them using achieved MSA. And clearly, if you have a patient where you can achieve a given MSA compared to a patient where you tried everything you cannot achieve, it's for a reason. It's possible that when you can achieve it, it's more lipid plaque. When you cannot achieve it, it's heavily calcified fibrotic plaque. And despite all the plaque modification you've done, you may not be able to achieve it. And those patients are likely to have worse outcomes because they also have other risk factors, maybe renal disease, etc. There is also significant underrepresentation of patients with calcified coronary arteries needing atherectomy, and safety and efficacy thresholds are unknown and needs to be tested in future studies. Thank you for having me on.
Very good. So stay tuned. We will go the 4 talk in a row without discussion in between, and then we will have a common discussion. So the next speaker is Tatsuhiro Fujimura, and the title is Stent Expansion Indexes to Predict Clinical Outcomes, an IVUS Sub-Study from ADAPT-DES.
Thank you to Professor Slice. Good evening, everyone. I'm very happy to present my study at the historical EBC meeting. Today, I'd like to talk about stent expansion indexes from ADAPT-DES. As you already know, there are some intracoronary imaging findings at the post-procedure. Among these, MSA is a powerful predictor of clinical event. The cutoff value was 5.5 square millimeter in the previous report. However, MSA is limited by vessel size. And the cutoff value may not apply to different population. Therefore, stent expansion is considered. The conventional stent expansion index, based on music criteria, has been used in many prior studies. However, it is not always useful due to not simple vessel morphology. So, some relative stent expansion indexes have been reported. When I was studying abroad at CRF, we focused on the volumetric minimum stent expansion by HK model, as reported by Dr. Nakamura. This index, which takes into account the side branch size and vessel tapering, was calculated with an ideal reference vessel size by this dedicated formula, and had a better correlation with post-PCI FFR and 1 year composite endpoint compared with conventional stent expansion in Illuminate-1. However, that study was based on OCT, not IVUS. So first, we tried to demonstrate the usefulness of HK model in IVUS cohort, ADAPT-DES. Moreover, I believe the strong point of IVUS is to be able to measure the vessel size and the plaque volume. And I predict MSA with much plaque could be eventful. So we set MSA vessel stent expansion index as a new one, which is defined as a ratio of MSA to vessel area at the MSA site. Methods of this paper target was native coronary artery lesions treated with DS implantation, and the final IVUS pullback image in the ADAPT-DES study. We established stent expansion indexes as below. The diameters of all side branches more than 0.5 millimeter were measured to calculate HK model. The primary endpoint was 2-year clinically driven TLR or definite stent thrombosis. We investigated the relationship between between these stent expansion indexes and clinical outcomes. Result: 1,831 patients were extracted. There was the number of patients with and without TLR or definite stent thrombosis was 53 and 1,778 respectively. There was significant difference in sex, renal insufficiency, prior PCI, and PAD. In the lesion and procedural characteristics, 2,140 lesions were extracted. There was significant difference in ISR, CTO, lesion length, reference vessel diameter, and stent length. Unfortunately, left main cases and bifurcation cases were not so many in this cohort. However, I measured side branches in 1,956 regions out of 2,140. This main results show that only MSA vessel stent expansion index was strongly associated with worse clinical outcome. In the two-year Kaplan-Meier curves stratified by the cutoff value of MSA vessel stent expansion index, 38.9%, there was significant difference between two groups, 5.7% versus 2.5%. This graph is stratified by MSA quartile. In the group with MSA less than 4.5 square millimeter, the group with no more than 38.9% had significantly more clinical events than the group with more than 38.9%. Discussion. I think the reasons why the MSA was not a predictor of clinical event in this cohort is that the MSA was optimized with IVES. Because the average of MSA was 6.2 square millimeter, it was good stent expansion. The stent expansion criteria are frequently not achieved in any IVES study and trials. I speculated the reasons are not only due to lower balloon pressure or smaller stent and balloon size selection, but also due to insufficient lesion preparation before stenting, such as calcium reduction with developing devices and plaque volume reduction with PCSK9. Recently, AI IVES has become available, making it easy to check MSA vessel stent expansion index. So I hope that the MSA vessel stent expansion index will be adapted as one of the intracoronary imaging findings at the procedure that can predict a clinical event. A conclusion. MSA vessel stent expansion index was superior to traditional stent expansion indexes in predicting two-year clinical outcomes, especially in lesion with a small final MSA in the ADAPT DES study. Thank you for your attention.
Thank you very much. So, we are only 4 for the first session. Why you don't join us and the first speaker here? We have 3 seats and Srival is on video. Okay, so we will have that intense discussion later on. Then we have Jung-Min Han, optimal minimal stent area and impact of stent under expansion in left main upfront to stent strategy.
Thank you, Dr. Patrick Ray. My topic is optimal MSA and impact of stent under expansion in left main upfront to stent technique. So to begin with, I'd like to say that just to intracoronary imaging in left main stenting, insertion of imaging catheter is not easy, so you need some pre-lesion modification. It makes your procedure improved, outcome improved. Once you know the intracoronary imaging and then vessel size and geometry, you can do your procedure totally dependent on the imaging findings. So in addition, once intracoronary imaging is performed, try to achieve the minimal stent area criteria before finishing procedure. This is what I'm going to talking about. So previously, we published data 5, 6, 7, 8 criteria, but this criteria is derived from the heterogeneous patient group, the crossover and two-stent and first-generation DES against the 9-month instant restenosis. Another criteria we have nowadays. But I think we need some definite, more robust criteria in patients with a very heterogeneous population. So we included a patient only who underwent two-stent technique by the Cordis technique. So last several years, we included around 292 patients that underwent two-stenting Cordis technique and evaluated IVUS both sides, LAD and circumflex. We enrolled in this study. Patient age is 64, diabetes is 1/3, and mostly the true bifurcation patient. And then pre-lesion modification was done in 86, and post-dilatation with the NC balloon in main branch, side branch is 89 and 85%. The 100% final kitchen balloon dilatation was done in this population. And patient with a MACE or without MACE, only difference is minimal stent area. Different from the previous talk, the stent expansion index was not associated with the increasing risk of MACE. So we evaluated LAD ostium, circumflex ostium, and distal left main. So this is distribution of minimal stent area. The distal left main 10.8 median value. Prox LAD was 8.0. Circumflex ostium is 5.8. So this is the ROC curve and relationship between the minimal stent area of distal left main and adjusted hazard ratio. There is no significant difference between. There is no significant relationship with the MACE and distal left main minimal stent area. But the LAD ostial minimal stent area was significantly associated with the 5-year MACE rate. And circumflex ostium also significantly associated with the 5-year MACE rate. Very linear relationship between the minimal stent area and MACE risk. So above the threshold or below the threshold, the left main is 11.8, LAD is 8.3, circumflex is 5.7, but left main no progressive value. So I believe that LAD and circumflex total vessel is more important than the mother vessel, I think. So we grouped the 3 categories. The group 0 is no under expansion. Group 1 is under expansion in LAD or circumflex. Group 2 is both under expansion in LAD and circumflex. So only patient with both under expansion in LAD circumflex is associated with the MACE or coach death and myocardial infarction, target vessel revascularization. This is actually summary. When you evaluate the circumflex ostium, LAD ostium, and distal left main, the LAD ostium and circumflex ostium was associated with the MACE, and both under expansion is associated with the increased risk. So I think this study suggests that the operator should aim to achieve the sufficiently large minimal stent area in left main two-stent technique. In addition, the minimal stent area values we propose here might serve as a benchmark for the IVUS-guided optimal upfront two-stent technique with the Cordis technique to obtain the favorable long-term outcomes. So I'd like to briefly introduce our unpublished data, provisional stenting. So around 800 patients, we pull back the IVUS after stenting, and then we evaluate the minimal stent area. So we evaluated LAD ostium, distal left main, then proximal left main. The median value is 11.6, 9.9, 8.5. This is the cutoff value of the proximal left main, 11.4, above and below, associated with the long-term outcome. And distal left main, 8.3, above and below, associated with long-term outcomes. And LAD ostium, 8.2, above and below, associated with the long-term outcome, even after a simple crossover stenting. So we grouped the 3 groups similar to the previous presentation. So under expansion in the both at least two underexpansion associated with a higher risk of MACE or coach death, myocardial infarction, and target lesion revascularization. So I'd like to suggest the new IVUS MSA criteria for left main bifurcation stenting. 5678 is based on the 9-month ISR. But nowadays, our new analysis is based on the 5-year outcomes. One stent is 8811, two stent is 6811. So this is my summary. Intracoronary imaging plays an important role in left main PCI. Imaging itself is not associated with better outcomes, I think. Additional effort for more optimal stenting based on the intracoronary imaging may lead to better stent and patient outcomes. 5678 criteria were based on the 9-month ISR and should be considered a minimal requirement. And new hour criteria 6811 are based on the 5-year MACE. I should be a target goal to achieve. Thank you for your attention.
Right on time. 5 seconds you have. Bonus of 5 seconds. Okay, so the next is Tsunao Nakamura. Impact of stent expansion index on stent failure after left main stenting. It's always entertaining talk. That's my experience over the years.
Thank you very much. So actually, this is not my paper. Actually, my junior's paper. Actually, anyway, junior to me.
You look a little bit young on that one, yeah.
Okay. The title is the impact of the stent expansion index of the stent failure after the left main stenting. Actually, he used the stent expansion index calculated by the MSA divided the reference vessel area. Anyway, of course, this paper is followed by the his paper. Anyway, and we use a conventional stent expansion index. This is a flow chart. Anyway, we have 1,000 patients. Actually, this is only the New Tokyo Hospital data. 1,000 left main data. So among them, we have picked up the 342 patients with a complete IVUS data, and then divided three groups. So greater expansion index, and then finally we compare the high expansion index group and the low intermediate expansion index group. This is the histogram of MSA and the expansion index. About the expansion index, the low and the intermediate and the high. Thus finally we compare the high expansion index group and the low and the intermediate expansion group. Actually, this is the result. Actually, the TLFR and the TLR high expansion index group show the better clinical outcome. Anyway, but if you look at the baseline characteristics, look at this low intermediate group have a higher incidence of peripheral artery disease, and the dialysis may be double, and the insulin user double. While the kissing balloon inflation and the double stenting surgery are actually very low, and the clarification is the same percentage. How about with calcium lesion or without calcium lesion? TLF and TLR calcium lesion, the high expansion index shows a better clinical outcome. And also look at the baseline characteristics. Calcification group, calcification line and a low intermediate line, insulin user triple. And the chronic kidney disease may be much higher, and the dialysis may be triple more than. Actually, dialysis is very important. Anyway, this is a CKD or without CKD. CKD shows the TLFR, TLR, high expansion index group shows a much lower incidence. The baseline characteristics also. Insulin user actually almost double. Dialysis more than double. Long intermediate expansion index group. This is the predictor of the TLF in the patient population with the calcium lesion. Anyway, high expansion index show the great predictor of the TLF. negative predictor TLF, and also the CKG. This is the conclusion. High expansion index group show the lower TLF than the low intermediate expansion index group. So this expansion index show associated with the favorable clinical outcome, the PCI for disease. This is the study limitation. This is I thought, and then I highlighted. Retrospective study, this is the accidentally determinant selection bias, which may lead a big background difference in the two groups. Very long observation, routine angiography, and we could not evaluate precise severity culture region correlated with clinical outcome. Still question. Maybe only the stenting, not only the stent expansion index, presence and location, the classification, systemic factor, or anyway device or something like that. This is the case of a severely culture region, ostium, the LED. Plotted calcium, the ceiling on the left main. This is the good target of the rotor, good target of the rotor. So we did, and then very beautiful open up. But 9 months later, we have a severe stenosis. Shrink of the stent site due to maybe record a big calcium. Already we have a paper. And interestingly, this is the New Tokyo Hospital data, PCI with a rotor with heavy culture, unprotected left main. Look at this. In the case of HD, high percentage of stenosis. No HD, it's okay. I think we should take into account with the patient's systemic condition, especially CKD, dialysis, and how about the calcium nodule. This is the case of a significant IS, big calcium nodule. We did with IBAS Diamondback system, and then the Diamondback works, and balloon stenting, beauty open, very beautiful, but 1 year later, patient back because of severe heart failure. The patient was sent to the bypass because we know the eruptive type calcium nodule has a very worse outcome. We should very care. Stenosis in the left will lead the patient collapse. And also, we need to know the characteristics of each device's rotor, Diamondback, shockwave. Actually, I talk later this. And each device have a good target or weak target. Not easy. Expansion index of the rate sensitivity may be one of the predictive factors, but there are several important factors related to worst clinical outcome. Maybe we should search the hidden determining factor. So I thought my talk was before Jim Yan. So I just let's look forward to the Professor Jim Yan presentation. Thank you very much.
So I have come to join us here. There's a nice seat for you here. So I think that, as usual, we were somewhat confused to start this session, and at the end we will be probably confused at the higher levels. At least that will be the big progress. So we should, I think, see the speak one by one, have the comment of the panel. So the first paper was by Shipal. Who wants to make a comment? I can warm up and say, I mean, what he used frequently is this cubic spline curve, and then he take one value, which is the point of conversion in the cubic spline, and he used that as an average treatment effect, and he said it's 0.2 millimeter. But I must say that today in our medicine, we try to personalize. We don't use one value. I know it's easy because everything in the lab is binary, I do or I don't do, but I think it's, like he said many times, it's a continuum and should be used. So the question that I have, and I've been beat up by this kind of concept using a cutoff criteria. For instance, in the valve, they have the mismatch based on BMI, no prognostic value at all. There's just published a big meta-analysis. So my question is, why at a certain point not use some kind of modern physiological parameter. And I'm thinking about IVUS FFR of OCT FFR. You have both of both group. You see that there is no more limitation to flow. That's point number one. And eventually you can see where it is, because you have on the curve of the IVUS or on the curve of the OCT, you have the drop in the FFR. So there I have to work. I don't have the proper expansion. That's just a question for the panel. Who want to attack this topic? You.
Me, hi.
Very good.
I completely agree. I think the first talk was called magic numbers, and there are no magic numbers that define intervention or no intervention for every person in every situation. I like the idea of the relative index that they proposed, but there's no magic numbers. The arteries are there to conduct flow, and so the connection between anatomy and physiology has to be taken into account.
Very good. Any other comment from the panel? Otherwise, yeah?
Question.
Just a quick comment. I think in the last presentation you had all these complications, right? Perforation, perforation, perforation. And I think the danger of setting such strict guidelines with cutoffs is that you will overexpand things and overtreat things, and then you will cause perforation in the sort of tiger zone, which is not accessible to the surgeon. So that's my only concern, especially in calcified lesions in women.
Okay. Yeah, go ahead.
I was surprised, in fact, by the paper of Jung-min. It was because in Korea, other Korean people are grown, they are bigger, they are larger, so that's why they adapted the criteria to say that it will be preserved of event. And of course, this is not true. So I was really, I'm very, in the two groups you have, so those respecting the rules and those not respecting the rule, you have, of course, in those not respecting the rule, a higher rate of event. But this is very far from 100%. So we have a difference in event. And inside this group, which is not reaching the criteria you defined, you have people that have no event. And this is related to not to a magic number, but to a phenomenon that gives you the fact that we have to reconstruct the bifurcation as it was before. This is my interpretation. So, and the second point in your work is that this is dedicated to a population, not to an individual, which is something which is complex. I agree, I have not added to these complexities physiology. See, maybe we put that this year, next year, but will be a bit more complex maybe.
Yeah, I mean, I think I see Dr. Tu, and I just mentioned before he came into the room that to have the option to have an OFR and at the same time the anatomy is quite good. I mean, that concept of MSAA versus vessel area, there is something in it. You know why? Because it's individual. And basically it remember me a little bit the expensive remodeling who get exhausted by the value of 40%. Here it seems that 38% is the value that you have to achieve. That means that that individual has a certain level of remodeling, but despite the remodeling, you try to reach that thing. That's a value for that individual. There is something in it. What do you think here?
I think it has something to see with the branching law. And what is changing, what is modifying the measurement is remodeling. Positive or a negative remodeling. This is moving the law. So if you are able to measure the media to media in non-disease place inside the same segment, you will have very quickly, will go very quickly to the branching law, either the Finney or the CASAB. So I think there is something maybe more individual and precise than the population criteria to reach.
It's interesting because left ventricular mass is very dependent on the size of the person. Actually, it's been shown that it's on a formula for all mammals, in mice, in rabbits, in humans, horses, and even elephants. And you would think that also the size of the vessel is very dependent on the left ventricular mass. So somehow we should develop some indexed vessel size dependent on the person's size.
So two comments. First of all, I think we should exclude patients with renal failure and calcified nodules. They just don't fit into one bucket because they keep on coming back. And so I don't think that's very effective in that population with calcification nodules. Secondly, Dr. Fujimura, you said you had an optimal stent area derived, but maybe you needed better vessel prep. So that statement is contradictory. There you have prepped the vessel well, and you had a good MSA, but you're saying the MSA is fine, but your vessel is not prepped. So I didn't quite understand your statement on that.
Yes, I fully agree with the. Anyway, first question. So we actually, in my analysis, we adjusted by the body mass index. So in addition, I think it's very similar to the patient prosthesis mismatch. So even the small size people, the large size people, adjust by the body mass. So it is a very scientific or not, I don't know, because PPM is not associated with the long-term outcomes. So indexed by the body mass. In addition, I don't think we have a big difference between the my coronary artery, your coronary artery, I think. So size-wise. In addition, one thing I want to say is that our all analysis come from the patient evaluated by the intravascular ultrasound, so not angio guidance. So I think, so this population may have a better clinical outcomes than patient underwent angio-guided PCI only. So more important thing is our minimum stent area is just a benchmarker for better outcomes. I don't strongly say that, I don't like to strongly say that you have to achieve it, but please try to achieve this minimal stent area. Then every effort to achieve the minimal stent area may improve your patient outcomes, I think.
So we will continue. I think what is important to come back on this body mass index, because, you know, I've been beat up a few times by these things. I know big Korean with a small heart, so you see everything. And certainly in the valve, we have been beat up by the mismatch based on the BMI. That doesn't work at all. Yeah? Yves, your turn. So your topic is in pursuit of an ID.
Yeah, so I will show you the reason why you have this session tonight. So you all know this branching law. So this is the one of Finney, the Finney's formula. The Uyokasab, I know, of course, he explained me many times, but it's a bit more complex to calculate. And the Morris law also, which is another one. So we have shown that in many EBC. We have shown that outside EBC. I think many people knows. Maybe a bit less known is this, which is a quite rustic simulation of the result of bifurcation stenting, showing that showing different amount surface of low wall shear stress, which is a pro-atherogenic factor, as you know. And the smallest surface of low wall shear stress is following the Finney's law or the Uyokasab. So this led us to put in this recommendation, TCT-AP in 2012, minimize the number of DES, maximize their position, minimize overlapping, and respect the original anatomy. We are telling that, but we have, of course, not the beginning of validation. I have seen this proposition by Kang by Mayara, and I have seen this. I've read these papers for preparation of this session, and I have seen this in January with 6, 8, and 12. And well, 5, 6, 7, 8 was the beginning. The Mayara was 7, 8, and 10. So I was intrigued by the increase in the diameter in the surface between LAD and left main. So I had an idea. I was in my garden. I had an idea. So I decided to take these 3 recommendations to transform the surface in diameters. For me, it's relatively easy, as you can see, the formula. So I found the diameter, and with the diameter, I decided to calculate the ratio. For the Kang work was 0.55, for my Akiko was 0.62, and for Jungmin Han was 0.66. And if you have a line here, you see that 0.66 is very close to the finesse formula. So this was the point that raised me. I wanted to have something clear to explain this. So, with the help of Gary Mintz, who found my idea quite interesting, I asked for a post-hoc analysis of left main bifurcation stenting. Well, I asked David Dildix-Smith and Annette Masnicka in EBC main, but we have only 2D QCA and not intravascular imaging. I asked Jungmin Han, was the only one to accept to review his database. I have to thank him very much. Eval Christiansen for either subgroup of normal, considered as a too small group to be explored. And I discussed with Akiko Maera, which is not always easy to discuss with Akiko, but I have a rendezvous with Akiko at TCT. So I don't know if it's promising. José Maria de la Torre, we discussed also, but he was not seeing in his population the way to help me. I have not asked Tatsuhiro Fujimura, and I have the plan to ask Cordis registry, and why not Chinese colleagues also to explore this. So thank you very much for your attention. Before discussing, I will present what I asked to David Dildix-Smith and Annette Masnicka. Yeah, so I asked to Annette Masnicka to explore the effect of finesse fractal ratio on outcome after left main bifurcation PCI, sub-analysis of EBC main. So this is a distribution of fractal ratio. So this is individual, we'll calculate for all the patients. You see that the maximum is 70 and a bit more. She looked at with the recurve fractal ratio on MACE in the whole cohort, nothing. Fractal ratio and death in the whole cohort, nothing. Fractal ratio in the whole MI, nothing. And TLR, nothing. I was a bit disappointed. And after that, we look at dual stent. In this group, you have dual stent and single stenting. So for dual, all the the calculation were negative. For final pot or not was negative. And for final kissing with final pot, negative again. So you have here some comparison between 3 tercile. Under 0.64, between 65 and 74, and more than 75. And for the whole cohort, no difference in any MACE, DES, MI, TLR. With final pot, no difference, and with final pot, kissing balloon and final pot subgroup, no difference. Maybe a very small signal is a trend for TLR in dual stent group. But this is not an information of interest. You see, 0.09. So we discuss, of course, this result. achieving the radial ratio during the left main bifurcation PCI was not associated with clinical outcome in the EBC main cohort or in subgroups with dual stent implantation, final pod perform, and successful kissing inflation and final pod perform. However, a limitation is that the fractal ratio was calculated from the minimum vessel diameter obtained from 2D bifurcation dedicated QCA. Instead of IVUS and ORCT, and was performed in only 39% of patients in ABC main. So, and in single crossover stenting, in best projection to see the two distal ostia, there is a well-known carena shift phenomenon, giving us wrong information on the true side branch lumen on the side branch. It's oval, or it's even a slit. This may explain why we were not able to measure really the surface. So I thank you very much for this. So of course I will go on if you encourage me to do it with Kiko, and why not other call for other well maintained databases with double imaging in the two branch. Thank you.
Very good. So we will discuss that, and then we have the classical bigger is better. You know, in interventional cardiology, it has been a big topic. Don Albeim always said, mine is bigger than yours. I don't know what he was talking about, but that's what he used to say. So, bigger is better.
Thank you. So 2 months ago, Eve sent me an email. So why don't you analyze the fractal ratio based on our registry? Actually, I don't know what fractal ratio is. So I studied from since then. So I analyzed bigger is better, ratio is better, bigger and ratio is better. So my answer is very straightforward. Bigger is better, but considering the ratio may be useful in a situation. So I read some articles that there are a lot of the natural geometric law, the finesse law, flow conservation law, Morage laws. So, but I found out that different laws, but practical point of view, not that different. So in this study, finesse study, I can implant just a 3.0 or 3.25 stent, no big difference, regardless of any kind of law we followed. Anyway, finesse law, so if we know the natural geometry ratio, the basic assumption, basic idea is that if we know the two normal diameters, then we can assume the other. But to prove this concept, we have to prove that this kind of number, 0.67a, whether this number has a prognostic value, or this number would be supported by the clinical data. So based on the two-stent technique, cross technique registry, 292 patients with the cross technique, we evaluate the fractal ratio. Fractal ratio is evaluated by the mother vessel diameter divided by the summation of daughter vessels diameters. So this is a distribution of our two-stent technique registry. Fractal ratio is 0.62, very different from the EBC left main registry data, because EBC main data is around 0.70. Our data is 0.72, 0.621. And this is ROC curve. So best value to predict 5-year MACE is 0.63, around 0.63. Above the 0.63 is associated with a higher event rate. Lower than 0.63 show that the low event rate. So when you group according to total, the highest total median value is 0.68, very similar to the finite load fractal ratio, show that the highest event rate. the lower fracture rate is associated with the low event rate. So Cox proportional hazard model showed that the fracture ratio, high ratio is independently associated with a higher event rate, even after adjustment by the many clinical and IVUS parameters. So bigger is worse, I'm sorry to say, in fracture ratio. So, but the fracture ratio is relative, not absolute. What is a high fracture ratio? Left main is relatively big, or LAD or circumflex is relatively small. Low fracture ratio, vice versa. So this idea we put into the under expansion and not under expansion grouping. So we grouped the four groups. The one is under expansion, fracture ratio is high. One is under expansion, fracture ratio is low. Under expansion, no under expansion, fracture ratio is high. And no under expansion, fracture ratio is low. The patient with the under expansion plus fracture ratio is high is associated with the highest event rate compared with the other groups. So expansion rate is very similar, but the LAD expansion rate is lower in the worst group. So how to apply the fracture ratio in the practice? Higher fracture ratio is associated with worse clinical outcomes in patients with Cordis stenting. Cutoff value was 0.23, very different from the natural fracture ratio. The patient achieved the natural fracture ratio 0.68 was associated with the higher event rate, unfortunately. If there is no under expansion, fracture ratio does not have a prognostic value. If there is under expansion, fracture ratio may differentiate the patient outcome, but I think a further study is necessary. Thank you for your attention.
Can you come back to the not the last slide, but just before that, because I want to look at the last two group at the bottom there, 59 and 66. I mean, if you had there a value of 53 or 52, I will embrace your approach. But I'm a little bit puzzled by the last two groups, 7%, 5.7%, and then 0.59 and 0.66. If you make a trend analysis, I think that some of the conclusion could be different, but I don't want to destabilize the whole system because this is the idea of Eve. So I mean that works somewhat.
Bad idea. No, just to focus on the fact that you have at the bottom one group not respecting the value you ask for at the end of the procedure. One group is not big as you want. At the bottom, and he has a low rate of event. Yeah. So we recruited here a population that we can be confident having this, that the patient will do better, like others for the follow-up.
So look at the lowest two curve is there is no under expansion. So once there is no under expansion, fracture ratio doesn't matter, actually.
Right.
So, yeah, go ahead, please.
Let me ask one question to the audience. Who has ever looked at the textbook of Murray published in 1947? That's the last time that he published a book. Somebody here?
I've seen the first page.
Okay, so the first sentence in that book, that was my favorite, in 1947, I was born on 1947, so. But that book, the sentence is, what comes in, comes out. That's the whole principle of his life. He was interested in the coronary artery, but he was also very much interested in the heart, you know, what comes in the right atrium, right ventricle, etc. What comes in, comes out. And his great interest in physiology was about shunt. Every time that it is not comes in, comes out. So I think it was a brilliant concept at a certain moment, and and Ghassan Karab has certainly pushed that concept to the very extreme and refined. But is that really essential for what we want to resolve? I mean, today I'm a little bit pleased by the approach of MSAA versus vessel. Why? Because the 38%, for me, it's a kind of Glagov value, you know? So if you have that value, you're okay. So I would like to see more clinical data based on that, because the big advantage is a kind of internal normalization. It's a value for you, Eve. It's a value for me. We may have different remodeling, different level of remodeling, but it's normalized for the individual. So that might be something useful. And the Glagov is unbelievable. Still today we have published a paper on Glagov based on a multi-slide CT scan. Really at 40%, you see the lumen going down. Okay? Because apparently the Maasai guy in Africa or the guy western of Asia, they all do the same. At 40% of plaque burden, the lumens start to drop. So maybe there is something in this ratio. I just would like to have more comment about that. Yeah, ask us.
Ghassan, are you here? Do we have Ghassan Kassab live?
Patrick, I would like to ask you.
Ghassan?
He is probably not anymore online.
Not branch? No?
Hello?
Hey, Ghassan. Yeah.
Yes, I can hear you. Can you hear me?
Yeah, I hear you very well. So I was maybe not using very well what you teach me, but do you think, having seen what we have seen here, do you think that the objective of the treatment is to restore the initial anatomy? I mean, following some branching law. Is it the good branching law, Finesse law, or we have to test, for example, with your Kassab formula?
So before I answer that, maybe let me just point out an observation I made. I think it's important to understand that Finesse rule only applies to a Y bifurcation, meaning when the diameter of the two daughter vessels are approximately the same. If you have a T bifurcation or where the daughter vessels are of different diameters, Finesse rule, the fractal rule, breaks down. We've shown that clearly based on lots of experimental data as well as theory. Murray's law only applies rigorously to T-type bifurcations. It breaks down when you're looking at Y-type bifurcations. HK law is the only rule that applies for the entire spectrum. We've shown that back in 2012 and subsequently, and I forwarded to you the chapter from the new book, Eve's. We actually uploaded a cardiac calculator to make calculations of HK rule very simple, meaning you put in for a bifurcation 2 of the numbers, you get the third. If it's a trifurcation, you put in 3 of the numbers, you get the fourth. Having said that, I think with your data analysis, I would encourage you to go back and reevaluate your analysis based on the HK rule. With that, I know Finesse rule is simpler because it's an algebraic calculation, but that's the reason I uploaded in that URL, cardiac-calculators.com. It's a free app, you just put in the numbers and you get that back. Having said that, let me try to answer your question. What we've shown is that if you try to restore a bifurcation with dimensions, you can't just focus on one vessel in that bifurcation because it's a system. And that left main has to bifurcate the flow. Exactly, to what Patrick just said, what comes in has to come out. There has to be harmony between what comes. My conclusion is we ought to relook at that data, maybe with a kind of a more generalized analysis.
Thank you. So do we have time for to show What time is it? Thank you, Gassan. I will try to get from my friend Jungmin a reanalysis with yeah. We will move maybe to Ikichi presentation.
Okay, thank you very much. Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is Stent Size Selection in the Left Main. My disclosure. The measurement of jailed side branches in bifurcation lesion stenting remains a matter of debate, with no clear consensus established yet. Incomplete apposition in the left main has been observed, leading to disturbed blood flow. To avoid such risk and achieve proper revascularization, selecting the appropriate stent size is essential. Now, I will go through each step for this flowchart, explaining the rationale and technique behind the safe and effective stenting of left main bifurcation lesion. This step prepares the region for low pressure stent deployment by ensuring adequate expansion. Techniques like scoring balloons, debulking, and high pressure dilation help create optimal conditions for smooth stent placement and proper apposition. Here, I will explain the rationale for selecting the stent size based on the proximal diameter. This slide compared two synergy stents, 3.5 on the left and 4.0 on the right, deployed using the same condition in the same left main bifurcation model. The goal is to evaluate the degree of the complete apposition in the left main shaft between the two stent sizes. The red part shows the incomplete stent apposition area at the left main shaft. Despite identical KBI technique and inflation pressure, there is a difference in incomplete stent apposition volume based on stent size. This slide clearly shows that by selecting appropriate stent size, we can significantly reduce incomplete stent apposition in the left main shaft, bringing it close to zero. This highlights the critical importance of choosing a correct stent size for achieving optimal outcomes. Now, I will explain how to address key issues during the stent deployment. First, we focus on low pressure stent deployment, which is used to avoid damage to the distal vessel after stent placement. This slide demonstrated that even with 4 mm stent, safe deployment at 4 or 6 atmosphere with multiple inflation is possible. By using the stent delivery balloon, the distal side can be maintained around 3.2 mm, minimizing the risk of injury. 4.0 mm stent can be safely deployed in the small distal vessel with planned expansion, avoiding overexpansion or displacement. However, effective pot is crucial for optimal stent expansion and apposition in the proximal bifurcation, where incomplete apposition is inevitable. For safe and effective POT, the key requirements are selecting a high-pressure short balloon sized to the proximal vessel diameter, and it is crucial to ensure the direction of balloon expansion is carefully managed. On the left, POT was applied from the bifurcation to the proximal side, causing significant longitudinal stent deformation due to the balloon wings pulling on the stent. On the right, POT was applied from the proximal side toward the bifurcation. Minimize deformation as both ends of the stent were well secured. We recommended proximal to bifurcation method for better stent stability and reduced deformation. After low-pressure stent deployment, incomplete apposition may occur in the distal segment beyond the bifurcation. Additional post-dilatation with an optimal size balloon is often needed, and the pre-dilatation balloon can sometimes be reused. This complete treatment, as we have seen even with stent from the same manufacturer, the outcome varies based on size selection, highlighting the importance of choosing the right stent size. This is a large left main bifurcation model, but clinically, this size is not uncommon. The image shows the final result following the protocol we have outlined so far. It is clear that maximum expansion capacity of the stent plays a crucial role in the outcome. Megatron shows us superior performance, and Synergy 4.0 also performs equally well. Now let's move on to consideration when side branch dilatation is necessary. There are several important points to keep in mind to ensure the integrity for the main vessel stent during this process. Regardless of the stent design, the main vessel stent is elongated in the longitudinally when the side branch is expanded only.
Yeah. We should, yeah.
Once longitudinal deformation of the stent occurs, it cannot be corrected. Therefore, preventing this deformation from the outset is crucial. In this new variation of the kissing balloon inflation, the balloon in the main vessel is inflated first to explain the entire stent, minimize longitudinal deformation of the stent strut. Afterward, gradually side branch expansion is performed using the optimal side balloon with pressure of 6 to 8 atmosphere applied repeatedly. This model shows the left main bifurcation where the stent has been deployed toward the circumflex, and the sequent kissing balloon inflation has been performed toward the LAD. Although the image has some limitation, the result choosing match to the expected outcome of the procedure. Today is my summary and my key takeaway. Thank you very much for your attention.
I think that the message of this last presentation is quite clear. Don't take two small shoes for a big foot. I mean, that will not help. So I think it's a clear message. Maybe we should now review the session. Yeah. What did we learn? I think that we start by trying to find the magic numbers in the main stem, in the LED, and in the circumflex. I think that's what we have seen in the first talk. And I think that the magic numbers applicable to Mr. Everybody does not exist. I think that's my feeling. You have the small guy, the big guy, etc. I don't think that the normalization by using the BMI will be successful. That's my experience over the years. So that was a little bit the first part, the first type of talk. We tried to to introduce some physiology of some modern assessment. And I said I was pleased to see Dr. Tu in the audience and try to remember the presentation of Yoshi Onuma this morning showing this QFR going down step by step, and some technique are underestimating and some technique are correct. Apparently there was a great similitude at the level of the main stem between the Murray QCA, I would say, the Murray QFR, and the FFR CT. That's a message I got this morning quite clearly. So in our job, we like to do some imaging, but we like to have finally no pressure gradient between the main stem and the two branch. So I think that probably what we are going to see in the future, more of these combined imaging giving you physiological information. I mean, in many fields we start to see that. I don't see why we would not see that in the main stem. And we all agree that the ostium cannot be evaluated by the OCT, but the rest, the bifurcation very well. I mean, high quality pictures, you have to increase a little bit the flow, and you have the physiology and the anatomy. I was a little bit charmed by the concept of MSAA versus vessel size. The problem is that the usual OCT does not see the EM. I must say that I'm completely ravished by the spectra wave, which is a diameter of scanning of almost 16 millimeter. So you see the whole EM, you see the whole media, and you all even see the tissue outside the vessel. It's a kind of IVUS assessment, but in OCT. I mean, it's quite amazing. In Europe, we will not have access for the technology. It has been changed now, United States first and Europe second. It used to be Europe first and American second, but it has changed. That's the way to do. That's a little bit the message I have today. So these 38% MSAA vessel size, I would like to see explore in the sense not too much in physiology, but in clinical outcome. I mean, what does it mean if you reach that value? Because that's a value which is normalized for you and me, Eve, so we don't have to use a number coming from outside. And there is a similitude with Glagov, which is always something which is now almost 40 years old and all done all the time. Any other comment of any? Yeah.
To Yutaka, do you have completed the work that you have presented last year, so it was very interesting. Do you plan to make a clinical validation of your choice?
Clinical?
I mean the trial. The old way to perform with distal to proximal versus the choice of the proximal segment as a stent to do the crossover.
Yes. Usually, but today's presentation are usually performed for clinical case. Maybe also almost all cases will perform such like this step. and there is no problem. So I have to plan to this some study for the to forward, I think.
Okay, I think that we are coming to an end to this session. We have to thank Yves. We force us to think and to question things who seems to be stable, established, but when you scratch, you see that it's maybe less strong that we do. I mean, Ghassan has a very profound comment. I mean, you cannot just say it's what comes in, come out. It's much more complex. Shear stress, malapposition. There is today 4 or 5 different type of shear stress if you have a T or a Y, etc. So I think we will come back on that concept, but we need to be supported by clinical data. Without clinical data, there is no point to impose a criteria of a value if it's not to do something good in the patient. Thank you very much, everybody. I think we have to go to the next session.
And a big thank to Jungmin, if you are ready to go on with your CASAB. And thank you. You were the first to accept to review this. Thank you.
All right. Now, so this is the last session, so kudos to everybody who stayed till now. So we're going to, I'm Joanna from Groningen. I'm joined here by an excellent panel, Dr. Magdi, who's going to be my co-chair. We lost David, unfortunately. But we'll go to the first presentation, and we jumbled up the order. So Marta Kaluzhna is going to talk to us about the impact of left circumflex coronary artery ostium, stenosis, and outcome for patients after PCI of unprotected left main.
Sorry that we changed the order of our presentation, but I have the already. So I want to show you results of our study, our registry, that show impact of left circumflex coronary artery ostium stenosis and outcomes for patients undergoing left main PCI. So all the time if we are talking about left main bifurcation, we have before our ears probably the same picture. So we must recognize how looks the plaque distribution at the bifurcation and in how many cases the left circumflex coronary artery is involved. Then we must recognize how looks the anatomy of this left main features, and we remember that the left main bifurcation is the biggest bifurcation in coronary system, and the circumflex artery is usually relevant side branch. Then we have a lot of studies which discussed how should look the strategy of left main bifurcation management, and nowadays we know that we should go very simple, so with provisional stenting and only in some special situation go with upfront 2-stent strategy, but they are of course situations which must change our thinking during the procedure, and we must skip to the 2-stent technique after preparing the lesion. We know also that there are some things and some studies showing that left circumflex coronary artery can be really important and influence of the prognosis in our patient, that it's a 5-year outcomes according to the FFR, showing that left circumflex coronary artery, which is crossover stenting during the left main PCI, and the FFR, which show the low ratio, it's really an independent factor of worse diagnosis, and this study showed also that there was no correlation between FFR and percentage of diameter stenosis observed in angiographical imaging. So we see that the target lesion failure as well as the MACE in generally was higher in this group of patients with lower FFR, lower than below 0.8 or below, and it was also connected with a higher rate of repeated revascularization in the future in this 5 years follow-up. Then we see the second method of the ischemia assessment, which is prepared in a bigger population and more than 1,000 patients, which here recognize that ischemia assess using Murray-Low-based QFR ratio, and according to the 3-year outcomes show us that there was also a quite big population of patients with residual ischemia after left main stenting, and the most the biggest population with the ischemic ischemic artery after revascularization of the left main was observed at circumflex area. And it was also connected with MACEs and showing that this residual ischemia can influence on cumulative cardiovascular death and also the endpoints according to the bifurcation lesion. Then we have also a different assessment. If we talk about complete versus incomplete revascularization of left main is all the time the question how to really, it was also today discussed, how can you really define if it was completed or incompleted revascularization. It's very difficult. There are a lot of methods, and here is one of the newest study from this year showing that if it was it was assessed using anatomical, functional, or residual syntax score scales, it doesn't show the differences, but if the authors use residual jaw part, the scale is a very old scale, which was published in 1985, also based on angiographically assessment, but with a different segments, with many different views of coronary angiography, showing that also this residual jaw part, the score, shows that if it's high, it shows that the death or myocardial infarction rate is higher in this population. It was specially shown according to the circumflex coronary artery. Then we have the consensus that we should do proper left main bifurcation angioplasty with using intracoronary imaging, but we know from the last one consensus of the Euro Bifurcation Club that it's not so easy because intracoronary imaging is underused, and we usually undertake our angiographic guidance results like what we do in everyday practice. So the aim of our study was to assess whether the involvement of circumflex coronary artery ostium carries prognostic implication in patients undergoing unprotected left main PCI in a real-world population in our center. It is a prospective registry. It is a bigger registry, but we analyze here only patient who had at least 1 year follow-up. It was 564 patients and 135 with left circumflex ostium stenosis and 419 without circumflex ostium stenosis. Here's the definition, how we define the ostial circumflex lesion. And our primary endpoint was in-hospital death and periprocedural myocardial infarction, but we were much more concentrated on the long-term all-cause death, like the most important thing what we want to assess. So if you see here the comparison of these two populations, so people with left main plus ostial circumflex coronary artery stenosis were older, have a higher rate of chronic kidney disease and diabetes, and of course higher syntax score. And here the disease was much more diffuse with a bigger number of calcified left main and a bigger number of severe right coronary artery stenosis. And if we compare the interventional procedure characteristic, of course, our patient with circumflex coronary artery had much more often two-stent strategy up front. But you can see here about 50% of patients undergoing also stenting of ostial circumflex, of course, according to the operator decision, usually due to the carina shift, plaque shift of dissection in the left circumflex coronary artery. So if you see here, if we have used two-stent strategy, we are really fall in love in DK crush. I am from the center from Professor Maciej Lesiak, so everybody by us should learn how to do it. So it was our favorite method to treat this patient. And if we compare the periprocedural complication, there were no differences in these both two groups. And the intracoronary imaging was not analyzed in this study because the rate of intracoronary imaging was quite low, about 55.8% in all population, with a little bit more often taken in this group without circumflex coronary artery involvement. So if you see here the 7 years follow-up, the median was almost 4 years. We see here no differences between this population with left main disease without circumflex ostial stenosis and with circumflex ostial stenosis. And here if we compared 3 groups of patients which were analyzed, so left main plus circumflex, left main plus LAD, and left main plus circumflex and LAD ostial stenosis, there was also no differences in this long-term follow-up. In this group of patients with circumflex ostial stenosis, there were also no differences in all-cause mortality if we compared group with one-stent strategy to those with two-stent strategy up front. And if you see here the all-cause mortality in this group of patients without ostial lesion and circumflex, but who were treated also with the second stent implantation due to the operator decision, the all-cause mortality was also quite low, so about 20% in the 7 years of follow-up. So the conclusion of our study is that left main PCI is generally determined by the stenosis in the circumflex coronary ostium, but also by atherosclerotic lesion length and difficult of coronary side branch access. Their circumflex ostium involvement in left main disease PCI was associated with increased long-term mortality, which is highly beneficial for heart team decision-making process. And there was no significant differences in long-term mortality between groups treated with one or two stent strategy. There were also no differences in the long-term mortality regardless of coexisting circumflex ostial stenosis or LAD ostial lesion. Subgroup of patients without circumflex coronary ostium stenosis who underwent PCI during left main PCI because of the plaque burden shift or carina shift, they are the most important situation, also presented good long-term outcomes. So the message for this year from this study is that stepwise provisional approach should continue to be the preferred option for interventional in bifurcation of the distal left main stem, and procedure optimization, intracoronary imaging and physiology, invasive and non-invasive, can be the solution to achieve really good results. Thank you very much.
Thank you very much. Let me ask you the outcome you judge on the angiographic restenosis or the clinical outcome of those who are left with residual stenosis in the CX.
We didn't have the angiographical follow-up, so it was only clinical outcomes, all-cause mortality. We didn't make an angiographical assessment in this patient.
And what is the best treatment for restenosis of this notorious site of this ostium CX in the study?
Based on this study, yes, we didn't do a detailed analysis of the. It's also preparing for the next publication. What kind of strategy did we use mostly in treating the restenosis in this patient? But they were not analyzed in detail because it was not the scope of the study. And it was analyzed on the all-cause mortality, so we do not know the patients were also treated in different hospitals later.
Very good presentation. I wanted to ask you about the impact of length of lesion on circumflex. Have you considered that, or?
We didn't consider that. It was also the question I was preparing this presentation. We tried to make analysis also based on our intracoronary imaging, but the group was very small, and we decided to do not make because it was not statistically significant. So it was not assessed. We didn't also assess it making our coronary angiography image. So it was not analyzed.
Thank you very much. We're going to move to the next presentation of the.
No, it's.
In patients treated with provisional stenting, do you have the information on the proportion of the patient with circumflex-oriented stent?
Yeah, it was 13.6% of patients treated also with additional stent in patients without circumflex coronary artery lesion at the beginning.
Yeah. Thanks.
Thank you very much.
Thank you.
So the next presenter is Dr. Sunao Nakamura, calcified lesions in left main bifurcation area, how to deal.
Okay, this is very fractional one. So just to enjoy my slide. Anyway, I need to catch also H30 international flight, but always ready first. Anyway, PCI for calcified left main lesion is very difficult. This is the minimum requirement of the left main PCI. So IVUS is very indispensable. Also, you need a Hawkeye. Best preparation is very important. Evaluation of the calcified lesion and the skill. And selecting the appropriate devices very important. We have a very nice ablation devices. Diamond back, low tension selecting a shockwave cutting balloon. Anyway, each devices have the characteristics and the feature. The rotor, the high-speed rotation is a linear manner. Diamond back, ledge frame manner. And the shockwave, you already know. The laser and the cutting balloon, high pressure balloon, you already know. And the good target and the weak point, we have a different. The risk of the complication is also the different. This is just a schema. Maybe you don't believe me. This is just like a schema, like this. The follow the guardian bias, the movement is like this, the developing in a linear manner. The diamond back is something like this. So developing a ledge frame manner and back and forth. So sometimes can cut this part. And also diamond back can aberrate in this kind of the situation. Shockwave, you already know. The frequency, the waveform, the disrupt, crack of the calcium. The first learning point is understanding the characteristics of each device, what kind of rule following a track, developing only the calcified lesion or the others can change the developing position with a changing guide angle, a guided catheter angle. So keep high level understanding the principle of the technique of the steering ablation device is very important. So look at this. This is a calcified left main lesion. The left panel shows the ceiling of the left main. The middle panel shows the bottom of the left main. Actually, use of the imaging device to identify the precise location of the calcification is very important for noticing the calcium and checking the location of sign of thickness is indispensable. This is the case. The ceiling of the left main, we can see the calcium lesion. If you look at this, the OCT picture plotted the calcium the ceiling of the left main. This is within the range of the rotor. So we can see the shape and the thickness, the precise location of the calcification. This is very good target of the rotor. So something like this. The targeting and then a good skill and then a finish. Targeting and then a skill and then a finish, and we have a very nice opening up. But anyway, actually, this patient have a severe stenosis. Shrink of the stent side due to the maybe record the big calcium lesion. We already reported that. The point is, actually, so in Japan, 1/3 of the population is more than 6 years old. we have millions of HD patients. In the case of HD patient, we have not so good clinical outcome, so please be careful. So in the case of HD patient, it is highly probable to stent require chronic phase. So we should take into account the patient's systemic condition, especially CKD dialysis. This is the case of significant ISR, the bottom of the retina, not good target, or this is not good target of the rotor. So we can use a diamondback this lesion. Rotor bar in a linear manner, the rotation to the rich plane manner, the diamondback. So this case, we can do the diamondback or debarking, and then like this. According to the wire bias, actually, the nice debarking, the eccentric neoantimal hyperpressure, calcified part, and then high pressure ballooning and stenting, because of the effective plaque reduction, large lumen could be achieved even multiplayer the stent itself. About the calcium nodule, I already showed that this is a calcium nodule. In this particular case, using IVAS, we can see the severe stenosis with the calcium nodule. And in this case, because we use a diamondback system, and we can dilate very appropriately. But just 1 year later, the patient coming back to the acute heart failure because of restenosis of left main. So patient was sent to the bypass because the eruptive calcium nodule has a very worse clinical outcome, we already know. So we should be very careful. This is a restenosis in the left main is a very, that's good. We lead a patient collapse. This is a very simple case, looks very simple case of left main. But the point is that we have a calcification on the ceiling of the left main. If you do not develop in devices, so actually accidentally wire was out in this case, but continue the left main to the LED stent in the circumference gone. So because thanks to the technique of our CTO technique of the PCI, we can open up and then beauty angiogram. But why happen? The calcification opposite to the side branch is a problem. So if there's no calcified lesion, it's okay. But if I have a calcified lesion and there, the stem branch shifted to the actually side branch, the stenosis. We already have a paper impact of the main branch calcified lesion on the side branch stenosis in the bifurcation stenting. The actually calcium plaque opposite the carina is a predictive disruptor of the side branch occlusion. This is it. This is the learning point of the 6. And the final case is that this is a very severe calcium lesion. Maybe everyone cannot expect to fully open up the circumference. Diffusely severely calcium circumference, larger, very thick calcium lesion. How actually shockwave we do. The shockwave, the 2 shockwave, and then high pressure ballooning and then stenting, we can fully open up diffusely severely calcium circumference lesion. Also the LED, the shockwave, the fully open up. We just above the beyond our expectation. This is very amazing, but we can fully open up. These are my final message. The point of left main PCI for lock of the pipe. Select the most appropriate devices. Please keep in mind characteristics of each devices. Of course, you need to have a good skill. And the imaging devices is a very indispensable. Also, reading imaging precisely, you need a Hawkeye to watch and evaluate. And do not forget, especially the CKD or dialysis. We should take into account of the patient's systemic condition. Of course, if this is my junior, actually, if we can get some information about the location of the calcification, maybe we can select the appropriate device before PCI. Something like this. Anyway. Finally, I just present to you. This is a sakura in February. April in February is so beautiful, but the sakura in winter is also beautiful. Thank you very much. I need to catch the plane. I go.
so we don't have time for questions because he's leaving, but maybe we can discuss it ourselves.
By email.
Yeah, exactly. No. I guess my question would be, so we had this discussion about using only DCB in those calcified left mains, but on the flip side of it, I suppose, if you have one of those big nodules that can recrush your stent, I mean, does anybody still think about using stents that are have more radial strength or thicker struts to prevent this from happening, or is this the thing of the past? So, I don't know. Does anybody want to answer?
I think the problem with the calcium, I mean, this is a challenge. You have to remove it. So I was going to ask him. Maybe we can ask Francesco and Ahmed if there is advantage of rotational rather than simple atherectomy standard regarding the no reflow. It's higher, and if there is any rule for the new cutting balloons, they can facilitate, or you go directly for atherectomy.
So the question is very difficult. I cannot, give final advice. For sure, I think that in this presentation, what was really correct is the fact that the ROTA has a wide bias. So when selecting the device and when applying it, we should take in account this, because alternatively we will not get in contact. And regarding the stent type, for sure the stent characteristics across different manufacturers differ a lot. So it makes sense. Overall, the 3-link stents tends to have higher radial strength, and for some manufacturers, for bigger sizes, there is increased thickness of the device, like from the Onyx one. So it changes. Let's go on.
All right. Shall I introduce the next speaker then? So tolerance study, a long-term outcome of state-of-art PCI versus CABG in the left main disease. Dr. Yoshihisa Kinoshita.
Thank you, thank you, Chairman, and ladies and gentlemen. It's my honor to present my data in the EBC 2020 Hope. My talk is about the outcome after the PCI and or CABG in patients with left myocardial disease. Okay, this is my disclosure. Yes, the untreated left myocardial disease is associated with the poor prognosis if compared with other type of the coronary disease. And following the 2018 European guideline remains the CABG for the main care of the patient, for the patient of the left main with the left main disease. PCI received the class 1A, and if patient had the low syntax score, and the class 2A, if syntax score is intermediate, as you know. And in contrast, in American guideline, PCI is still class 2A. It's achieved the equivalent revascularization to that possible with CABG. And recent evidence from the randomized controlled trials and the meta-analysis comparing PCI using DES with the CABG among these patients indicate the equivalent result for the mid and long-term outcomes. The optimal revascularization strategy for left myocardial disease remains controversial. Also, large and contemporary of the patient trials are still lacking. So this our current study evaluates the clinical outcome of the PCI compared with the CABG for patients with left myocardial disease in the real-world clinical practice. And current study is a multi-center cohort study which enrolled all consecutive patients who underwent left main and left main PCI and CABG from the January 2009 to the December 2020. And that is not randomized trial. So we make the we do the propensity score analysis, and the propensity score analysis performed to account for the baseline difference in the patient characteristics and the control for the potential bias. So the definition of the left main coronary disease is more than 95% diameter stenosis by visual estimation, or 50 to 75% stenosis deemed hemodynamically significant using the non-invasive or invasive means of the testing. And of course, about the treatment for the patient, we had discussed with the surgeon team. And the patient who refused participation in the study when we contacted the follow-up was excluded. The primary outcome is a major adverse cardiac event, which was defined as a composite of all cause of death, myocardial infarction, and stroke. Secondary outcome is each component of the major adverse cardiac event, as well as cardiovascular death and the stroke, any cardiovascular death, and any revascularization, hospitalization for heart failure, and major bleedings. So this is a baseline clinical characteristic. So totally 965 patients was enrolled. So as you can see, before matching, there is a big difference between the two groups, and also in this in this population, there had a large proportion of the patient with high age and diabetes. And also the chronic kidney disease. And so before matching, in this original population had a patient who underwent the another concomitant surgical procedure in the surgical group. So this patient was excluded before propensity score matching. So as a result of the propensity score matching, the 191 pair of patients were successfully matched. And as you can see, after the propensity score match, after the score matching patient, there is no significant difference between the background of the patient. Regarding other region characteristic, in the PCI group, we can see the little bit more proportion of the high syntax score patient, 31.4%, and the CABG of 24.6%. But there is no significant difference, statistical difference between two groups. And also the CABG group, still there are patients who had more disease coronary artery disease than the PCI group after the matching. This is a procedure data. As you can see, in the 99% of the patient, intravascular image guidance PCI was performed in the PCI group. And also the debulking device such as rotational atherectomy or directional atherectomy were used more than the 20% in the PCI group. And the single stent strategy is commonly used in this group. And in the very few cases, we could finish our procedure without stent. Almost in this patient was performed aggressive debulking, like using by the DCA or rotational atherectomy. In the in the CABG group, the off-pump, mainly the off-pump CABG CABG was performed. And this is primary and primary outcomes. The median follow-up is 3.9 years, and primary outcomes is primary composite outcomes rate is 8.9% in the PCI group and 15.2% in the CABG group. There is no significant difference. Each component of the primary outcomes, there is no significant difference in the total death and myocardial infarction and the stroke. And about the secondary outcomes, also there is no significant difference between the two groups, cardiovascular death and any revascularization, heart failure hospitalization, and the major bleeding like this. But there is some limitation in this study. As I said at the first of this presentation, that this is not a randomized trial. So even though the propensity score matching were performed, but total elimination of the potential bias between the two groups was not possible. And so it's unclear whether the generalization of these findings for the other countries is possible, I think. And this, ladies and gentlemen, this is my conclusion. The PCI in patients with the left main accumulated disease showed a statistically insignificant difference in all causes of death, myocardial infarction, or stroke compared with the CABG. And also, there is no significant difference between the two groups about secondary outcome, including any revascularization. Thank you for your attention.
Congratulations, Dr. Pinosita, for your interesting presentation. The patient who went to surgery, what was the indication? Complex coronary multivessel disease or complex left main disease?
Yeah, so thank you for your question. The most important condition had the patient has the left main disease. So and of course in many cases we always, as I showed here, that we always discuss with the surgeon team. That means that this case is a very complex left main disease, especially including the left main distal bifurcation stenosis or left main plus any other vessel disease.
You leave me a little bit scratching my head because you took patients with really extremely high syntax score that was higher even in the PCI group, but you actually have such low event rate compared to bypass. It's mostly driven, I think, by MI, but yeah, can you explain that somehow?
Yeah, thank you. Actually, we are surprised to see this result. In my impression, that before the making of matching, I really thought that our syntax score is surely higher in the CABG group. But I think that in this, when I saw that in this result, that is maybe as a background, it's depend on the characteristics of Japanese patient. So the Japanese patient, especially older patient, actually don't want to choose cabbage.
The other point in the study that the major technique used in left main bifurcation lesion, it was provisional stenting, 90% of patients. That means complex bifurcation lesion was not there. So maybe this one of the factors that balancing the good results.
Yes, thank you so much. Actually, so many Japanese doctors always try to finish the single stent strategy, even in the complex left main bifurcation case. So, as I show here, that we usually use developing. In many cases, we use it developing the device to develop especially in the side branch ostium to develop the calcium plaque or fibrous plaque to finish to finalize the single stent strategy.
It seems also that the surgery was more or less ideal. They used bilateral mammary arteries in 90%, and I don't know whether the message outside Japan, because maybe they refuse surgery there, to do the PCI if the Euroscore is high, comorbidities, or the coming up that the PCI we are doing this well, and so this should be the standard from now on. Okay.
Yeah.
Thank you very much. So next speaker is Chang-Wook Nam, differential diagnosis of true bifurcation lesions according to left main versus non-left main location and treatment strategy.
Thank you, respected Chairman. Can you show the slide? Okay, this is my disclosure. So this slide, actually, we saw in the morning. So true bifurcation lesion is a higher event rate, but we don't know the different prognostic implication of PCI for the true bifurcation according to lesion location are unclear. So we want to show this result. So the aim of this study was to identify whether clinical outcome of true bifurcation lesion differ between left main and non-left main bifurcation, and also to determine the optimal treatment strategy for subtype of bifurcation lesion in current generation of DS. So we merged the three different registry from Korea Cordis 3 registry data, which was performed as a second generation DES. Also, two Italian group registry, the RAIN registry and the Ultra registry. They also use the second generation DES. So we called this merged registry as Ultra bifurcate registry, including more than around 7,000 patients, but we excluded several patients, and then finally we analyzed 6,500, more than 500 patients, and divided it 25% is a left main bifurcation, true and non-true is 44%, and then more than 6%, around 6%, and then non-left main bifurcation is 75%, and then well-balanced true and non-true bifurcation. So primary endpoint was MACE, a composite of cardiac all-cause death and myocardial infarction and TRR and stent thrombosis around 3 years, and secondary endpoint is following. So sorry for the very busy slide, but baseline clinical characteristics is a little bit different, but not so significant. Diabetes rate is around 35%, and CKD is a little bit higher in left main bifurcation and true bifurcation lesion. And mostly stable coronary artery disease around more than 50%, and ejection fraction is not so low, and very similar clinical characteristics. And about the angiographic and the procedural characteristics,
left main is all the patient is left main, and then non-left main bifurcation, mostly LAD and diagonal bifurcation reason. And true and non-true is divided as a circular analysis. And then about the provisional strategy, most non-left main bifurcation is performed provisional one stent strategy. But the left main, as we can see, the true bifurcation reason, and nearly half of patients was performed two stent strategy. Among the upfront two stent strategy, crushing was most common procedure, and then next followed the tap. IVUS guidance was performed more frequently in left main bifurcation, around 50%, and the non-left main bifurcation around 20 to 24%. And about the technique, the kissing balloon was performed in left main, more true bifurcation is 82%, and then non-left main bifurcation is around 70 to 60%. But the non-left main bifurcation more performed the POT technique. So we can see the more details about the diagram. So treatment strategy for bifurcation according to lesion location and type. First, you can see the left main bifurcation. As you can easily understand that the upfront two-stent strategy is more common in true bifurcation reason compared to non-true bifurcation reason, around lesser than 10%. And purport kissing mostly, and POT was more, POT and depart was around 30%. But in non-left main bifurcation, definitely you can expect the upfront two-stent strategy is relatively low. But true bifurcation reason around 20%, but non-true bifurcation, very rare performed. And then kissing balloon technique also, instance is relatively low. But the POT technique is more frequently in non-true bifurcation, non-left main bifurcation reason, because we prepared provisional one stent strategy. About the MACE, the primary endpoint, left main bifurcation, true bifurcation reason has a higher event rate, so around 20%, and then non-true bifurcation reason is 13.4%. It's definitely different. About non-left main bifurcation, even though true or non-true, there was no difference in clinical outcome, so there was an interaction, P was positive. When we focus on the left main bifurcation, in true bifurcation reason, as we already, left main bifurcation is higher event rate, especially in true bifurcation reason, there is no difference between one stent and two strategy. So it's more high event rate in that reason. So even though it's a left main bifurcation, but non-true bifurcation, if you performed two stent strategy, relatively higher event rate compared to provisional one stent strategy. In terms of non-left main bifurcation reason, whatever you do, true bifurcation reason or non-true bifurcation reason, one stent or two stent strategy is not different outcome. So I may say it's in non-left main bifurcation, you can treat it as definitely provisional approach, whether it is true or non-true bifurcation reason. When we result the analysis of predictor of a primary endpoint, left main bifurcation, if you low ejection fraction, high event rate, and femoral access, also maybe it's not just bleeding, but also maybe we do prepare the more complex situation, and also side branch resonance is shorter, is better outcome, and provisional approach better outcome. In non-left main bifurcation, CKD, femoral access, low EF, and diabetes was positive. And non-left main bifurcation and the use of a thin strut and the kissing balloon was a better clinical outcome. But this is an observational study, so there is some limitation, and there is no QCA analyzed. And then non-left main bifurcation, very low percentage of two-stent strategy. But we can conclude like this slide. So as I already mentioned, that non-left main bifurcation has a lower event rate, and whether it is true or non-true. But in the left main bifurcation reason, true bifurcation reason, a very high event rate. And not just very high event rate. But also, if you compare the 2-stent and 1-stent strategy, non-true bifurcation is a better clinical outcome with a 1-stent strategy. So provisional 1-stent strategy should be preferred approach for the treatment of a left main non-true bifurcation lesion. Thank you very much for your kind attention.
Thank you. Very, very interesting data. Well, I think that the use of 2-stent technique in distal left main in this group was more than 50% of cases.
Mm-hmm.
And I think that the anatomical characteristic of lesions might induce you to use 2 stents.
Yes.
So the final conclusion that provisional is preferred when it's possible, not always.
Yeah, yes. Of course, it's true bifurcation reason. Well, whatever you use 2-stent or 1-stent, both group has higher event rate. So it's we do not hesitate to use a 2-stent strategy in left main true bifurcation region. But if left main non-true bifurcation region, it will be better to try the provisionally.
In both groups, it was imaging-guided intervention in all the patients, or only with left main?
In left main bifurcation, I was image guidance around 50%, but non-left main bifurcation is lesser than 30%.
So you can also assume that the results could be related to use of imaging in some patients more than the other. And the other point is left main, if you compare to the non-left main, of course the circumference most of the time is important compared to non-left main, where the side branch you need to judge and to see the length and the segmental myocardium, all these things. And so all these things count in the results also.
Yeah, you're right. So as I already mentioned that the predictor analysis, if the side branch region length is lesser than 10 millimeter in left main, it means the circumflex disease is lesser than 10 millimeter, a better clinical outcome.
The criteria for implanting a stent in the circ when provisional stent was planned was angiographically, TIMI flow, based on physiology?
Actually, we don't have a physiology approach instances, but for us, because it's a merged of 2 different countries, so we don't have data in this study. But I prepared when I, honestly, for me, yes, I very prepared the physiology guidance of circumflex procedure disease making.
Reassuring to see that it sort of replicates a little bit of EBC main data, right? So with 1 stent is better. Okay, thank you so much. I'm going to introduce the next speaker, and that's Dr. Anas Maroufi, to talk to us about temporal trends over a decade in left main PCI.
Good evening, everyone. It's a great pleasure for me to be with you today in order to present for you the temporal trends over 1 decade in left main PCI, which is a collaboration work. Actually, it goes without saying that left main PCI is a challenging subset in terms of interventional cardiology. Why it is this way? Obviously, because there is a high myocardium putting at risk, and also from a technical point of view, we are dealing with a bifurcation, with a different angulation and different disease in terms of dorsal cells. There is evolvement of tools and techniques over the last decades, and actually there is the trials, and especially randomized clinical trials in EBC main was one of them, in terms of guiding us what would be the best stenting strategy. However, the real-life data also has a complementary role in order to shed light about what is our current practice and also try to see where are the areas of further improvement. So actually we try to study the trend in left main PCI in terms of the context of 15 years of a prospective large single center registry, and for that the organization was as a following. So the procedure was performed in the National Heart Foundation Hospital in Bangladesh, and the data was collected by the team of Dr. Fazila Malik and the analysis was done by our group in Heart Center of Graz by the leadership of Dr. Gabotot. So we included all consecutive patients with left main PCI and included the procedural characteristics and clinical data, and that was studied over 15 years period from 2006 to 2022. And what are the results? So actually we managed to collect over 3,500 patients, and we divided them over 4 groups. Each group, it has the same number as the others. But actually here there is this striking difference in terms that we managed to collect 873 patients in the timeline of 10 years, which is equal what we could have collected in the last 2 years, which gives us an idea about a high increase about left main cases that we come to treat percutaneously. In terms of average age, it was 57 years, which is quite young, and in terms of male propensity, it was 80%. So in terms of diabetes, it was over 50% of the patients with diabetics. There is an increased trend about renal disease patient that was treated percutaneously, and also a decrease of the number of protected left main, which gives us a hint about the high complexity moreover towards the year. In terms of the ACS, it represented 25% of the patients without any trends in terms of the timeline. And here, intravascular imaging, it was quite low in terms of the use, which is around 20% of the cases. However, in terms of the last 2 years, there is a decrease in terms of use of intracoronary imaging. And this is maybe because it's related to the high increase of the caseloads afterwards. In terms of advanced lesion preparation, it was high. I mean, here what I mean with advanced lesion preparation is also the Biocan devices, rotablation, IVL, scoring, or cutting balloons. So all of them is like in the same group. And there is a tendency of an increase of advanced lesion preparation throughout the years. And again, in the last few years, there was a decrease. And maybe here it's related to the lower use of intravascular imaging, because if you don't see the calcium, you would have less tendency to treat it. Now let's move to the stenting technique. So we compared one stent technique to 2 stents, and here I would like to say that for 2 stents, we don't have the data about if it was initially meant to be provisional and end up with 2 stents, or it was from the start an upfront 2 stent strategy. In terms of the trends, it was a lowering of the 1 stent use in favor of 2 stents throughout the years till 2021. And here comes the deflection to lands around 75% of the cases was done with 1 stent strategy. In here, let's dive into the double stent technique. What was the technique that used? And seeing the crushing techniques, which include nano crush, mini crush, and DK crush. The peak which is started from 2019, which was quite concomitant about the publication of the DK crush study. The tap technique remains the highest use of double stent technique, and the culotte became only popular later on, starting from 2019, which became later on the 3rd preferred strategy. Now let's speak about mortality. So mortality known as such decrease in terms of 1 year mortality and 30 days mortality to reach a certain plateau level around 1% in terms of 30 days and 12 months mortality around 5%. So why this is important? I think we had a continuous understanding of left main PCI throughout the year, and that's have a reflection about how we use our strategies. And here, this real-life data also, it gives us an idea about how we tend now to increase the complexity of the cases, and also more cases and cases are being treated percutaneously compared to CABG, and also this is reflected also on the recommendation. And we need to also see our mirror reflection about how our practice are and the emphasis of low use of imaging compared to high volume patient, and also in countries where there is low resources. And also this is all of it is just to try to see the areas where we need to improve our practices. So it's essential to remember that still we can finish up 75% of cases with one stent strategy, and the trends, there is a dynamic trend in terms of double stent strategy. Thank you.
I think the most important is the learning curve that had increased all over the world in the past maybe 10 years, that previously it was only shown in the live transmission in the conferences. Now it is our daily practice. And that's why maybe some specialists like CTO, some people only are doing, but left main, all the intervention cardiologists are familiar with. But we congratulate you for the outcome, and of course, we should, the other point is we should respect the economy of each country. Maybe not everybody is allowed, like my country, also to do imaging routinely. This is very important.
Absolutely.
Do you have any idea if Bangladesh has sort of a registration of all the outcomes of patients undergoing PCI nationwide, and is that compared, monitored over the years, or is that sort of a single center attempt to create that?
Yeah, actually, it was just the data about single center. It was not like generalized about the whole country of Bangladesh, so we don't have that. And also, it goes that I have to say that in terms of the sub-analysis, one stent strategy performed better in terms of mortality. So it was expected.
Very interesting data. I have seen that in between 2016-19, there was an increase in the use of 19 to 21 increase of the use of DK crash, and was associated with higher mortality in the same period. I noticed that. So this came back, and you went for more simple double stenting. That means TAP was increased and mortality goes down. So
yeah, I mean, we didn't dive into that details.
Is that related to complex procedures?
Maybe also that could join also the learning curve. But I mean, I cannot say for sure that it was related to the DK crash. So, but still, I can only say that it was maybe related to stent strategy more. Yeah, absolutely.
Well, thank you very much.
Thank you.
Can I present the last speaker, Professor Robert Jan van Guns from Holland. And I believe one of my fellows is working with him, Mohammed Reda. He recommended me to.
Yeah, so Mohammed put quite some work in doing this analysis, so I'm happy to present on his behalf. And I asked him to look at our study we did several years ago, but I was intrigued by the combination of diabetes and bifurcation stenting in left main. So we worked on that for this, and we know if we talk about complex PCI, we talk about multivessel disease, and we talk about left main disease. Now, if you have multivessel disease, all these studies, it's pretty clear. If you have diabetics and multivessel disease, CABG is recommended. If you have three-vessel disease, no diabetes, you have a pretty good option to get away with your PCI. If we look for the left mains, now we look for the XL trial, and from the XL trials we see there's no impact of diabetes. And that still keeps you surprising a bit. Now, there were quite some left main bifurcations in these, and also the left main bifurcation or shaft didn't have an impact. So, and then even if you want to look at higher numbers, so Stuart Head and Patrick and Peter Kaptein looked at 11 trials with 11,000 patients, 3-year follow-up, 4-year follow-up. You look at this table and we know all patients, diabetics, has a poorer outcome. I think I can use that mouse. No. On the top. Top button, thank you. Here. So we know the impact, all patients, and then the diabetics, they do worse. So they should be going for surgery, not for PCI. And that's mainly different by the multivessel disease. If you look at this analysis where they looked for mortality in the left main, again, the numbers for P of interaction 0.13, 13% versus 16%, hazard ratio 1.34. No interaction, so left main disease and diabetics, you could pretty make your point and say that PCI is a very good option. And that's what we're doing today. Well, I have to go forward, of course. So in the recommendations currently, and in the left main disease, if it's percutaneous or surgical approach, there's nothing about diabetes. That's very easy. But we know from the study we have just seen on Bruno, and he was working on a little bit earlier today, on the huge Cobus 3 and the RAIN registry, bifurcations have a significant problem. Diabetes and bifurcations have a significant increase. So this is bifurcation data, 4,000, 5,000 patients. If they have diabetes, they do worse. Now, if you look at that table on the interaction, you have to really understand and try to see if there was diabetics and bifurcation, an impact through bifurcation or non-through bifurcation, because that's where I want to go. Now, there was no interaction on that segment. They even looked at 2 stents, no interaction. For left main, there was getting maybe some data which might be more interesting to have a little bit a look on. So still we have quite some specific data on left main bifurcation in diabetic patients is limited. And the stent technique on the long outcome we don't know so much. The aim of, therefore, for this evaluation, we did to study the impact of diabetes on left main bifurcations and to assess whether the stent technique influences the long-term outcome of left main bifurcation PCI. Now, I asked him to look at our ideal left main trial, which had 800 patients. We presented that at 2019 at the TCT. 818 patients, they were randomized versus Synergy with short-term DAPT or Science with long-term DAPT. I can show you, this is your Kaplan-Meier curve. The P value there was 0.15, so no superiority, or the trial was officially non-inferiority. Again, no difference between the 2 strategies. So we had a nice data set. At that same year, we had the presentation of one of the fellows. Yes, 1 stent, 2 stents, of course. Every left main study you look at, 2 stents has an impact. So the log rank, the p-value for that one was 0.02, doing 2 stent strategy doing worse. So we are doing this interplace, and you can put more arrows everywhere there between diabetes, 1 stent, diabetics, 2 stents, or no diabetics and 1 or 2 stents. The endpoints are pretty simple: MACE, or cause death, MI, or ischemia-driven revascularization, or device-oriented clinical endpoint. And that's, I think, in the point of diabetics important, because diabetics have a lot of MACE events, but not always related to the device. So the baseline data we talk about, 800 patients. The diabetics, more females. The diabetics a bit more hypertension. And the number of stents, 1.8 versus 1.2, 0.05. So probably the number of lesions and the number of stents, well, there was no difference in this one. Just for your discussion, maybe we learned that from 2 presentations ago, IVUS in the whole data set of ideal left main was about 50%, 40%, a bit more in the non-diabetic patients. Statistical, no difference. So this was, I think, before the current guidelines that is a 1A for imaging during the procedures. Now, baseline data, slide 2, non-diabetic patients, and keep it away from the diabetics for the moment. What kind of procedures were done with the 2 stent approach in the METS classifications? So a lot of provisional strategies with the main across the site first, at 80% of the patients, and in the 2 stents, then you can get, we couldn't differentiate that anymore, which is exactly a culotte or a crush, but at least the site first is a crush, and the 2 stents is a main across first is a tap or a culotte. That one we couldn't differentiate. Number of stents, yeah, of course, if you do 2 stent strategy is higher. Number of lesions treated a bit higher in the non-diabetic patients. IVUS, again, close to the 40%, and the 2 stent strategy, always higher uses of IVUS, that's 55%, than if you have only 1 stent implanted. Now we'll put it to the side. The diabetic patients, a bit smaller group, we have to be honest, 127 patients versus 48 patients. The distribution a bit the same. A lot of tap culottes versus somewhat crushes, 25% was done in the two-stent strategy in the diabetics, so around 20% in the all over population. Now we have here 4 columns, and I put some in red to make it a bit more clear. And of course, we had expected that the diabetic patients were having more events, MACE events, than non-diabetic patients. And it will give you already a hint if you look at the one-stent strategy versus the two-stent strategy. That's 18% or 19% versus 29% for the MACE. You see something on the target lesion revascularization, and I put a mistake there. The red one box is just a bit too low. That should be, of course, on the 12 versus the 27% with a p-value of 0.01. This p-value is initially calculated across all 4 groups. So we have to dive in still a bit deeper to try to understand our conclusions. Results non-diabetic patients, and that was interesting because this is 500 patients and a two-stent strategy 130 patients. No significant p-values anywhere in everything we looked at. So the non-diabetic patients, we think that sometimes two-stent is bad, didn't make that strong point in this one. We'll show you the diabetic patients, smaller groups, so it's more difficult to get significant values, but the numbers I would say striking. MACE, 18, 19 versus the 29. We need to have more patients. Maybe I can ask some of our Korean colleagues to work on this with me further on. And then we have the most report. We noticed that on the DOCI, we already achieved in this small group a p-value of 0.02. Could be still, of course, a chance of luck that we find something in there, but the data are there, I think, numerically clear, and we found some statistical significances in this analysis. The multivariate analysis, if you do that more formal for the formal group, it is diabetics and the two-stent strategy. This gives you the multivariate analysis, which is positive for the stent strategy and diabetics. So we try to conclude it like this. Patients treated for left main disease with diabetes do have a higher risk of MACE. I think that was an open door. But the one-stent strategy bifurcation seems only beneficial in the diabetic patients, and then especially if you look at DOCI, because that's the lesion of interest in that part. Two-stent strategy for left main bifurcation does not have a penalty in non-diabetic patients. That's what we did see. While POCI significant increase in diabetic patients treated with a two-stent strategy. So then considering the guidelines we have, I think that we are in one moment when we are looking at left main patient, and you know he's diabetic, and you think this will be an upfront two-stent strategy. I see there 5-10 millimeters of side branch disease. You might consider, did we do a good decision in the heart team, or is this patient still have a good option to have CABG instead of doing this procedure? Thank you for your attention.
Really nice data. So can I ask something provocative to you? I guess if it's a little bit logical to me that for diabetics, the more stents, the more chance of instant restenosis and all the other problems. So should we there be also using drug-eluting balloons in the side branch?
Should we use more IVUS, I would say first, because this presentation, we're looking at data from 2009, 16. We didn't do 100% IVUS or OCT imaging to make our optimal results. And then we still have to wait, I think, for better studies showing that DCB in the side branch, and especially the left main side branch, the circumflex, is as good as any other solution, because we don't have